to present Professor Dr. Rudaina Sobhi, Professor of Pediatric and Pediatric Cardiology, Cairo University. She will present pediatric bradycardia. Please start, Professor Dr. Rudaina.
Thank you, Dr. Hela. First of all, I'd like to welcome حضراتكم جميعا in the conference. Today my talk will be about pediatric bradycardias. Bradycardias are bradycardia is defined as a heart rate lower than the normal limit for age. It's also should be a bradycardia that's inappropriate to the level of the activity and the clinical condition of the child, not just the number. In children, we have different heart rate ranges because they are a dynamic population. Bradycardias defined as age-based definitions. Usually we say newborns who have heart rates less than 100, infants till the age of 1 year with a heart rate less than 90, and children till the age of 10 years with a heart rate less than 60, and the more than 10 years with a heart rate less than 50 are considered to have bradycardias. Bradycardias can be physiologic or pathologic. A physiologic bradycardia can be seen in the conditioned athletes, can be encountered during sleep or in conditions with a high vagal tone. However, a pathological bradycardia may be due to an underlying systemic disease or cardiac disease. Etiology of bradycardia can be due to cardiac causes, either congenital or acquired, causing sinus node dysfunction or AV node dysfunction, namely the heart block. Like for example, this is a second-degree heart block and complete heart block. The first two slides were in a congenital patient, and this ECG shows a complete heart block in a post-cardiac surgery. You can see the complete AV dissociation. Systemic causes that can affect the heart rate and cause bradycardia include the increased vagal tone, for example, in vasovagal syncope, hypoxia, which is a common cause for bradycardia in neonates, especially the preterms, or apnea. Medications like beta blockers, digoxin, calcium channel blockers, metabolic causes or endocrine causes like hypothyroidism or electrolyte disturbances, infections, sepsis, for example, myocarditis, and neurological condition like increased intracranial pressure. In children, these causes are more than the intrinsic causes. Bradycardia has a range of presentation. If it's mild, it may be asymptomatic, okay, and can be detected accidentally during routine physical evaluation, like for example during sports participation evaluation. Infants with bradycardia, if it's not severe, also moderate, can present with non-specific symptoms like failure to thrive, feeding difficulties, and older children can present with exercise intolerance, dizziness, or even syncope. Severe bradycardias may present with hemodynamic instability and symptoms of low cardiac output and poor end organ perfusion, and may even end in cardiac arrest. as mentioned, we have intrinsic and extrinsic causes for bradycardia. So our diagnostic evaluation should include history and detailed physical examination, including symptoms, if the patient is on medication, a family history of arrhythmia or sudden cardiac death, in addition to a comprehensive cardiac examination, of course, the 12 leads ECG, a continuous ECG monitoring, the Holter monitoring, and it's indicated class 1 in evaluation of bradycardia to assess intermittent bradycardias, pauses, and to correlate symptoms with the heart rate. Exercise stress testing helps to evaluate the heart rate response. If a patient is bradycardic, we can evaluate his response to physical exertion and know if he has a chronotropic incompetence. And of course, an echocardiography is an integral part to detect structural heart defects and for cardiac evaluation. In addition to laboratory tests to evaluate or detect the extrinsic causes like electrolytes, thyroid function, and investigation to rule out infection. Okay, how do we manage a child with a bradycardia? Physiological bradycardias usually do not require treatment, especially if the patient is asymptomatic. For example, a well-conditioned athlete or a bradycardia that occurs during sleep with no other symptoms during the day. These need no treatment. If there is an underlying cause, first we need to treat the underlying cause. And in symptomatic bradycardias, can be considered an emergency. We can use atropine or isoprel to increase the heart rate acutely. And finally, we have the pacemaker. We can use it either temporary in acute conditions or permanent in patients requiring having a permanent condition causing the bradycardia, not a reversible cause. Temporary cardiac pacing can be inserted epicardially, as in post-operative patients after cardiac surgery, transvenously, or transcutaneously using a transcutaneous pads, or esophageal pacing. And medications, and you can start طبعا definitely لو العيان عنده hemodynamic compromise. We can start CPR if the heart rate is less than 60 with signs of inadequate perfusion. And then we can use the medications and the temporary pacemakers. Okay, so who are the patients who might require a permanent pacemaker? A child who requires a permanent pacemaker. Indications of permanent pacemaker in children include the congenital heart block. It's, as I said, the sinus node diseases or the AV blocks. The congenital AV block, if it's an advanced second or third degree heart block having a wide escape rhythm, so the ventricular escape is infrahisian, this patient is indicated for permanent pacing. If he has a ventricular dysfunction, if he has complex ventricular ectopies, if the heart rate is less than 55 per minute in patients with structurally normal heart, or less than 70 if they are associated with structural heart disease, and of course if the patient is asymptomatic, يعني عنده exercise intolerance, عنده feeding problems, عنده failure to thrive. Recently, guidelines went lower with the heart rate to avoid too early insertion of pacemakers in patients who are asymptomatic, and now we are talking of the heart rate is less than 50 even in neonates. And actually our experience supports this very much. We tend to see children with heart rates around 50, even slightly lower, and they grow well and they get their pacemakers at older age. Unlike the congenital patients who are usually stable and tolerate the bradycardia, post-operative AV block following cardiac surgery is patients, they cannot tolerate this severe bradycardia because it's an unstable rhythm, infrahystian, and it's an acute condition for the patient. So post-operative patients with advanced second or third degree heart block that persists, guidelines بقى اختلفت. في ناس قالوا up to 10 days, we can wait to 10 days, and the European Society of Cardiology في آخر guidelines قالوا 5 days. A heart block that persists more than 5 days will need a permanent pacemaker. حتى لو العيان returned sinus after the 5th day, this is very risky. Even in some conditions, in patients who do not have an escape rhythm, some patients, if we stop the temporary pacemaker, they do not regain an escape rhythm. We get an asystole. Those patients can even insert pacemaker earlier than the indications. Also, PACES consensus in 2021 noted that it's a class 2B indication in patients who have transient AV blocks who revert normal, but they are prone to progressive AV block, like for example, patients with CCTGA, AV septal defect, heterotaxy syndromes. They are even indicated, although their heart block was transient, they can, it's a class 2B, they can insert also a pacemaker because I'm expecting they will get a heart block. Patients with sinus node dysfunction who have symptoms correlated with age-inappropriate bradycardia, if you have a complex congenital heart disease with a resting heart rate less than 40 or ventricular pulses more than 3 seconds, they are indicated for pacemaker. In patients with isolated sinus node dysfunction who have no symptoms, no minimum heart rate, according to PACES consensus, no minimum heart rate or maximum pulse duration is recommended, so long the patient is asymptomatic. As I said, 3 new guidelines referring to pediatric pacing and defibrillation, the PACES consensus, the European Society guidelines, and the HRS guidelines, they lower the limits for a pacemaker implantation to reduce too early implantation of pacemaker. Okay, and device implantation was underlined that heart rate criterion is not absolute. ممكن العيان يركب على numbers higher than the guidelines if they have symptoms and they do not tolerate the bradycardia. So, يعني still we need to consider the symptoms of the patient. Okay, so, and of course, most guidelines يعني advise for physiologic pacing, especially in patients who require a high burden of ventricular pacing. So, finally, what I want to say is that bradycardia in pediatrics range from a benign condition to a life-threatening condition. A thorough evaluation is crucial to distinguish between physiological and pathological causes. Multidisciplinary care and long-term follow-up are essential in management of children with symptomatic or pathologic bradycardias. And the approach to bradycardia in children should be tailored to the patient's age, symptoms, and underlying cause, as the management strategies are wide from just observation in benign cases to pacemaker implantation in severe cases. Thank you.
Thank you, Dr. Rudayna. Very comprehensive presentation. Any question from the floor?
Okay, thank you, Professor Rudayna, our elegant female member of the electrophysiology team, the only female we have. Very nice presentation. I just would like to ask, say, a scenario of a case that I had. a baby 1.5-year-old, and he came first presenting with attacks of cyanosis. Somebody did him a Holter monitor, a 24-hour Holter monitor, showed vagotonia with a heart rate going down to 51 beats per minute. His normal was 121, and it would stay for around 1.5 seconds. The parents are very, of course, alarmed by this. They're worried, asking for anything that we could do for him. It just goes by itself. It's repeated. I think it's always precipitated by crying and agitation, so it's kind of a breath-holding attacks for the baby. But would you recommend anything for that child?
His average heart rate is normal.
121.
And it's nothing happened during the Holter monitor.
It went down. He had 2 or 3 attacks of the breath-holding attacks, and during that time, it went down to 51.
I think I'll just observe and try and manage the breath-holding spells, and then wait and see. I don't think this 51 for 1 second needs anything apart from addressing the breath-holding episodes.
Okay. Any role for vitamin D in it? For the breath-holding attacks?
Iron.
Iron, vitamin D?
Yeah.
Okay.
Iron. Okay.
Thank you.
Okay.
بس في يعني هو مش خطأ، هي دايما مش خطأ شائع. حضرتك قلتي بوست اوبراتيف لو العيان جاله كمبيوتر هارت بلوك وقعدت اكتر من 5 ايام هنركب بيس ميكر even if he revert into sinus. طبعا هو كان ساينس وهيفضل ساينس even if he reverted to normal conduction مش sinus.
Okay.
غير خطأ غير مقصود أكيد.
And I would like to add just one thing, if I have 30 seconds. I've seen patients who reverted sinus, and then later years, they developed heart block. So that's why I totally agree with reverted to normal conduction. I'm sorry, yes. We had a patient, a post-operative patient. She had heart block. She had a pacemaker. Then few months later, she became stayed sinus for 4 years. And then once her father called, we lowered the pacemaker rate. And then the father called us and said she's feeling dizzy. So we brought her back. She's in complete heart block. We turned on the pacemaker again, and then she's still in heart block, and she changed the device and so on. So, yeah. Thank you.
Okay, our next speaker, Dr. Peter Aziz. And I would like just to take a minute to thank him very much for his visits to us in Egypt here in Cairo University, adding a lot of information, expertise, education to our electrophysiology group. He's the head of the electrophysiology unit in Cleveland Clinic Foundation. And he helps us a lot with saving lives of our children in Egypt here, especially that we deal with the poor kids. So congratulations, our electrophysiology team founded by Professor Wael Lotfi, Dr. Usama Abdelaziz for all his efforts, Dr. Rudaina, Dr. Rania, Dr. Hussein. Among this financial recessions and the problems we had to arrange for this meeting, it was a lot of work from their side. Dr. Peter, when we met in Cardio Alex, we were just having a goal of having few lectures with him, and he was very promptly replying to us once he went back to the United States when he would come to us to help us more in the cath lab. And it was first, we wanted him to give us 2 or 3 lectures. Now the electrophysiology team were able to arrange for the first pediatric electrophysiology conference in Egypt, and thank you for making always Abu Rish the leader and heading for this subspecialty. A very enthusiastic team, very dedicated, and we're so happy with Dr. Peter's present, Dr. Shadi. And I just want to say, even Shadi understands Arabic, Dr. Peter a bit. They even sponsor the air flight tickets بتاعتهم هم اللي دافعينها. Every time he always tries to save us money and help us as much as we can. Their aim is in هم to help as much as possible kids and to exchange and educate more and more experience to our team. Thank you again, Dr. Peter, for your presence.
هقول بس كلمة صغيرة عن الغائب الحاضر الدكتورة فادية محمود. أنا سنة 88 بعد ما خلصت الدكتوراه في الإلكتروفيسيولوجي في وحدة الدكتور شريف مختار، كانت أول دراسة ميكانيزم أوف سوبرافنتيكر. رحت كليفلاند كلينيك على أمل إن هم أتعلم معاهم الأبليشن. قابلت هناك الدكتورة فادية محمود، هي طبعا أستاذتي. بتعملي إيه؟ قالت أنا جاية عشان أعمل اسم بيدياتريك كارديولوجي. وكانت كل يوم قعدت شهر ما بين كليفلاند كلينيك وكيس ويسترن، وفعلا رجعت انشأت اسم البيدياتريك كارديولوجي. وبعد كده few years قالت انا كمان عايز اعمل سب يونت اوف الكتروفيسيولوجي، وبعتت لي رئيس القسم الحالي الدكتور وائل لطفي او يعني البايونير، وعمل معايا رساله الماجستير والدكتوراه في السوبرافنتيكر. الماجستير عملها معايا هنا في اللاب، كنا بنشتغل سوا في التسعينات. وبعد كده سافر عمل دكتوراه تحت إشرافي برضو مع الدكتور نادير سعودي في فرنسا. فأنا بحيي الدكتورة فادية محمود الغائب الحاضر.
So we can move forward into benign ventricular arrhythmias in children. The name of the lecture, the title of the lecture for Dr. Peter.
Thank you so much for that incredibly kind introduction. I'm humbled to be here as always in Egypt, and it is our absolute pleasure to be here to serve. And I can't tell you how proud I am to see the first EP conference for arrhythmias here in Cairo, and so happy to be part of that. So thank you so much for allowing me to be here. And we're going to be talking about benign ventricular arrhythmias in children. So let's talk about some features of benign ventricular arrhythmias to start. Clearly, the absence of concerning symptoms is where we all want to start with our history. And when we see this patient, the football player here who is unconscious, they're feeling for a pulse, this is definitely not a benign syncope situation, so nothing like that. You want to make sure the family history is clean, specifically the absence of these features, sudden death in patients less than 50, unexplained drownings, seizures, syncope, early heart failure, cardiomyopathies, and defibrillators, pacemakers. We always ask at an early age, just so we don't hear about the 70 and 80-year-old patients in the family that have pacemakers. And we need to know that the heart is normal by way of a stethoscope first, so we listen to our patients, and if their heart sounds normal, that of course is reassuring. If there's any features of the history and physical that do not suggest normal findings, then of course we move to imaging studies, whether that's echocardiogram, MRI, if needed. So let's go through our first case presentation. A previously healthy 15-year-old athlete was referred to us for an irregular heart rate noted during a sports clearance physical. The patient had no symptoms, no palpitations, no syncope, and again was an athlete. And this is the electrocardiogram this patient has. So you see here that there are little bursts of Y-complex tachyarrhythmias here, and we'll see this in a blown-up version here in a second. And this blown-up version, the arrows there point to sinus node beats. So this is a sinus node that is activating through and independent of the Y-complex rhythm. So this is pathognomonic for ventricular tachycardia, which is what this was. And of course, once we define that somebody has ventricular arrhythmia, we'll want to know what the morphology of the PVCs is and the axis of those PVCs. So as you can see, the PVCs tend to have what looks like a left bundle suggesting coming from the right side, and the access is inferior with a late Curis transition. This is all suggestive of right ventricular outflow tract tachycardia, which is very common in otherwise healthy children. What is RVOT? Tachycardia. It's the most common ventricular arrhythmia in the young. 60 to 80% of all idiopathic VTs are this RVOT, VT. They usually arise from the pulmonary valve. Mechanism is CAMP triggered automaticity. The reason why that's important is because medications that act on CAMP triggered automaticity, like beta blockers, calcium channel blockers, and even adenosine, can be effective in treating these arrhythmias. Anatomically, this is the construct in my mind that I think of outflow tract and really ventricular arrhythmias in general, and Dr. Nachla can teach us much more about this given his experience on the adult side. But V1 is a very instructive lead. V1 here is showing you 5 different examples of VTs that arise from the ventricles, the outflow tract VT, where you see basically a Q wave in V1 is very, very anterior, all the way transitioning to more posterior loci. Here, the posterior mitral valve leaflets, where you have a right bundle in V1. So examining V1 is very important in terms of localization. Clinical characteristics occurs usually at rest and suppresses with exercise. Mean age of presentation is about 8 years of age. Patients are usually asymptomatic. 82% in a study were found incidentally in physical exam, much like our patient was. Much less commonly, they have symptoms of palpitations, but again, that's the exception. Natural history is usually benign, typically goes away on its own, and the burden will also decrease with age, so not typically something we target for treatment. So back to our case, this patient had negative family history, a normal cardiac examination, a normal echocardiogram, and look ectopy burden on Holter. Pretty boring, I think we would all agree. We exercised this patient, and you see at peak exercise, there's absolutely no ectopy at all. And then during early recovery, again, there's no ectopy, and as we wait a bit longer in recovery, we see this really isorhythmic ventricular rhythm and sinus rhythm sort of exchanging. So we did nothing for this patient, and the patient's ectopy actually resolved on its own. Our second case is a previously healthy 17-year-old female. She actually came to the American Red Cross to donate blood and noticed that her heart rate was fast. So they denied her for blood donation and told her to see her primary care physician, which she did. She has a negative cardiac family history, normal examination otherwise. And the ECG in our PCP's office prompted referral to us. This is her ECG. You see a wider, though relatively narrow, complex tachycardia with a right bundle and a left axis deviation. So again, going back to examining the PVC morphology, we see now that this is a left axis now with the right bundle, suggesting a left ventricular origin, and in a patient like this, very highly suspicious for a fascicular ventricular tachycardia, something that we see commonly in the pediatric population. So what is fascicular VT? It's also referred to as idiopathic or Bellhausen VT. It's first described by Douglas Zipes, in 1979. So it's been around for a long time. It can be induced, as key features, can be induced with atrial pacing on electrophysiology study. Patients typically have a right bundle, left axis, and their hearts are otherwise normal. Bellhausen later described, 2 years later actually, the sensitivity to verapamil. Occurs mostly in males and typically in the young, and accounts for 10 to 15% of idiopathic VT. Anatomically, what we see when we have catheters in the heart are these low amplitude fractionated signals in the ventricle close to the left fascicle. And this is a cartoon here drawn depicting the mechanism of tachycardia, where there is an area of slow conduction in the ventricomyocardium, and then it rotates back up the left fascicle, and this is our reentrant circuit. This slow zone of conduction is thought to be what's sensitive to verapamil. Clinical characteristics, usually the tachycardia rates are 120 to 250 beats a minute. People oftentimes tolerate this quite well. Some patients may have dizziness or palpitation. Syncope, though, is rare because this does not typically cause enough hemodynamic compromise to make somebody lose consciousness. The natural history is usually benign, predicated on symptoms and ventricular function. So absence of symptoms and preservation of ventricular function, we would not treat. Verapamil and catheter ablation are both very effective, though, if treatment is indicated. This patient actually came to the EP lab based on some mild ventricular dysfunction, and we were able to obliterate this, though this is the ECG when this patient was in sinus. One thing that's notable here is you see that there are T-wave inversions in the inferior leads, probably because the LV was having some sort of compromise based on this tachycardia. The Holter of this patient before ablation showed incessant VT, briefly in sinus while sleeping. And again, the echo showed depressed LV function. After discussing treatment options, the patient decided to go for an ablation, and these are the ablation lesions that we placed on the septal aspect of the LV. Our next case is a baby. This is a 9-month-old baby that we met in the ICU, was having a lacrimal duct surgery. And in the PACU, a wide complex tachyarrhythmia was noted, and our service was consulted. The patient was totally tolerating this arrhythmia change, had no overt symptoms at all of compromise. And this is the electrocardiogram, which shows sinus that slowly progresses into a wider complex arrhythmia. And if we look at this in a blown-up version, you see that there's a progressive fusion here from sinus beats to fused beats, between sinus and ventricular activation to fully ventricular activation there towards the end. And this fusion happens because the rates are pretty similar. This is an example of accelerated idioventricular rhythm, another very common arrhythmia that we see in the young, healthy patients, most commonly in the very young and newborns, actually. Rates are usually 10 to 15% faster than sinus, so barely faster than sinus. And again, compromise is very, very uncommon. Suppresses with activity and stimulation, a sign of benign ventricular arrhythmias that we've seen before. Patients have normal hearts, and the mechanism is considered to be enhanced ventricular automaticity. The prognosis is actually great. Spontaneous resolution is expected, though we do follow these patients to make sure that we can document resolution. This patient had a negative family history, normal cardiac exam, normal echo, but very frequent ectopy on Holter, so we decided to follow this patient. This patient now actually saw several months ago, is 8 years old, and she still has the same amount of ectopy she did before. I was expecting it to go away, but it has not. But the ventricular function's preserved, and we've decided to not treat this patient based on that. So our take-home message is pediatric VT is usually benign, particularly in the context of the absence of syncope and negative family history in a normal heart. Not all VT, though, is created equal. But I think being disciplined and not overreacting is the take-home message. Ventricular arrhythmias in pediatrics are rarely malignant. When they are, obviously, we have to react, but they typically are not. Thanks, everybody, for your time.
بسم الله الرحمن الرحيم. يعني أنا أول ما الدكتور وائل طلب مني الحضور، الحقيقة ما أقدرش أتأخر على الدكتور وائل أبدا. دكتور وائل شخصية اكسبشنال من التسعينات، وهو الحقيقة يعني في حاجات ربما هو حتى نسيها. يعني هو كان أخذ الزمالة في الأول وإحنا كنا لسه مخلصين الدكتوراه، فلما لقينا حد مشي في قصة الزمالة البريطانية ابتدينا بعديه. فبراير 1997، وكان 7 لسه مخلصين دكتوراه دخلوا امتحان الزمالة، فاتنين نجحوا، أنا والدكتور شريف فتحي رحمه الله رحمة واسعة. وده كان أول ناقوس خطر إن في مشكلة عندنا في الدكتوراه، إن هي ماشية في اتجاه ثيوريتيكال أكتر منه كلينيكال. ف يعني كانت البداية الدكتور هو يعني لما احنا ابتدينا في المسلك بتاعه في موضوع الزمالة وكده، لقينا في جاب، في ديفكت كبير محتاجين ان احنا نكفر الديفكت ده. وده يعني الامباكت بتاعه بقى لما يعني ربنا حطنا في موقع ابتدينا ان احنا نحط الاريزمياز، بيدياتريك اريزمياز، تدخل امتحان. طبعا الاول حطيناها في محاضرات، في سلسله المحاضرات بتاعت سامنا صباحا دي حطت. اهلا يا دكتور اسفني، اهلا بحضرتك. لقينا ان ضروري نبدا نحط البيدياتريك اريزميا في الجنرال بيدياتريكس، والخطوه الثانيه اتحطت في امتحان الماجستير، والخطوه الثالثه اتحطت في امتحان الدكتوراه. ولقينا الحمد لله ان نسب النجاح كانت ممتازه، رغم ان يعني كان في تخوفات لاي حاجه جديده. طبعا هي اتحطت مع حاجات تانية، يعني ابتدينا نحط الاي سي جي مع الاي اي جي، وفي حاجات كتيره جدا. حضراتكم طبعا العيان ما بيجيش سيباريتد من اول لحظه، ما بيقولش ان هو دي يعني قصه السينكوب وكده. الاي سي جي والاي اي جي بيفضلوا لغايه اخر لحظه، وكنا يعني مهتمين جدا ان العيان يعرف. كانت الدكتوره رانيا حجازي مشكوره شاركت معانا في قصه السينكوب ديت في المحاضرات، وابتدينا ان احنا نقول في حاجات معينه للبوست جراديوت ما ينفعش الجنرال بيدياتريكس يعدي منها من غير ما يعني يبقى عارفها فيري ويل يعني. بالنسبه طبعا الدكتور وائل ما بيسكتش عند كده، يعني هو حتى الخطوه اللي بعد كده انا فاكر اليوزمل وقصته ان هو عايز يروح امريكا، وقال لي عشان ابقى جاهز لو هناك قرر ان هو ياخد البورد او كده، وكمل في السكه دي. وقتها طبعا انا حتى في الموضوع الزماله انا لسه فاكر بيدياتريك ديرماتولوجي، كتاب كان قصه في الزماله، هو اطلس، كان قبل النت وقبل القصه دي كلها. الحقيقه يعني دي برضو بتبقى نقطه مهمه. الكتاب ده كان حاجه قيمه جدا وقتها في غياب النت وغياب اللي هو اطلس اوف بيدياتريك ديرماتولوجي، وكان اول صفحتين فيه كده فاضيين. فابتديت ان انا عشان موضوع الزماله كان لازم تبقى عندك جود نوليدج الحقيقه ان هو بعد كده سافر فرنسا وكان فاوندر لموضوع البيدياتريك اريزميا. وحتى يعني برضو عشان لما اشتغلت في الرياض كان في WPW، حسبنا قصه ان واحد مش متامن عليه يعالج WPW دي في الرياض، ولا اسهل له ياخد تذكره طيران وينزل مصر وابعته للدكتور وائل. لقينا ان دي نص التكلفه بالظبط، وكان عملنا كوميونيكيشن معاه وكانت نص التكلفه بالظبط. فالحقيقه هو شخصيه اكسبشنال. وطبعا احنا اول ما ابتدينا الموضوع يعني ابجريدنج للجنرال بيدياتريكس عندنا كان لازم نستعين بيه وناخد خبرته. هو شارك معانا في سلسله المحاضرات، يعني جزاه الله خيرا. يعني طبعا الدكتور وائل نحتاج نتكلم عنه كتير قوي قوي قوي، لكن عشان الوقت بس بتاع المؤتمر وبالنيابه عن جنرال بيدياتريكس كلها، شكرا يا دكتور وائل، شكرا. فين حضرتك؟ ممكن تقدميها بقى حضرتك عشان
It is my pleasure to present Professor Dr. Wael Lotfi, Professor of Pediatric and Pediatric Cardiology. He will present supraventricular tachycardia in children when to refer to EP-LAR.
بسم الله الرحمن الرحيم. الحقيقة thank you very much for يعني البرزنتيشن اللي ما استاهلوش. Supraventricular tachycardia in children was my first introduction to the arrhythmia arena. With the idea from Professor Fadia Mahmoud, my professor, to communicate with our adult colleagues, Professor Sharif Mukhtar, the professor of my professors, and Professor Hassan Khalid, who were overviewing me in my master and in my MD thesis, which continued in arrhythmias. Coming back to our topic, since the dean is coming at 10:30. I will discuss briefly, in simple terms, not in complicated terms, the indications to refer supraventricular tachycardia to the EP lab or to the EP specialists. Diagnostic indications, interventional indications, pacing indications, and considerations before referral. The most important thing to remember is that a child is not a small adult, because we commonly refer, particularly in private hospitals, whenever a hospital does not have a pediatric cardiologist or even a pediatric arrhythmologist, the common formula for treatment is referring for an adult pediatric cardiology, asking for the medication that they usually give, and then looking for the dose for this child and giving this medication regardless of anything else, regardless of the diagnosis, regardless of if it's beneficial or not, natural history, things like this. So please remember that a child is not a small adult. My discussion today is based on the European Society of Cardiology guidelines for management of patients with supraventricular tachycardia. The reference is there. The most important summary that I can convey to you, first of all, we need to consult. Whenever we see, even myself, my colleagues, whenever I see something I'm not used to, I consult. I consult locally my colleagues, I consult overseas to ask if somebody has seen this before, does he know the natural history, the prognosis, before doing anything. It's usually very important to think, diagnose before acting, not to move into doing things. I have seen in the ER sinus tachycardia patients 1 month, 2 months receiving repeated DC shocks because they were diagnosed as SVT. So before acting, particularly if the patient is hemodynamically stable, think, consult, ask. And of course, if everything is stable, you can always refer. And it's about evidence, not about logic. The key messages from the European Society of Cardiology guidelines were that the amiodarone and digoxin are no longer mentioned in the new guidelines for acute management of narrow complex tachycardia. Sotalol and lidocaine have been removed from the acute management of wide complex tachycardia algorithms. Despite we are not doing this, but they recommend not to use sotalol with supraventricular tachycardia, secondary to the pro-arrhythmic effect of it. They do not recommend using flecainide or propafenone in patients with left bundle branch block or ischemic or structural heart disease. Do not use amiodarone in pre-excited atrial fibrillation. 1 in 5 patients with asymptomatic pre-excitation will develop an arrhythmia related to their accessory pathway during follow-up. So seeing a pre-excited patient, even if he's not symptomatic, should make us consider intervention, even if he's not symptomatic now. The risk of cardiac arrest, ventricular fibrillation in a patient with asymptomatic pre-excitation is 2.4 per 1,000 person years. Multiple drugs have been removed from the acute and chronic management of inotherm reentrant tachycardia. Verapamil, diltiazem, and beta blocker remain as options for the chronic management of AV nodal reentrant tachycardia, but they were downgraded from class 1 to class 2A. Diagnostic indications, in simple terms, whenever you're not sure of the diagnosis, whenever there is a possibility of something more dangerous than a simple SVT. Non-invasive screening may be used for risk stratification of patients with asymptomatic pre-excitation, but its predictive ability remains modest. Invasive assessment with EP is recommended in patients with asymptomatic pre-excitation who either have high-risk occupations or are competitive athletes. If the arrhythmia is significant and the diagnosis cannot be established otherwise, for example, the differential diagnosis of a wide complex tachycardia, SVT versus VT, suspected serious substrate like the Brugada syndrome, the Ajmaline test, things like this. Both invasive and non-invasive tests are for the risk management of patients with asymptomatic pre-excitations have limitations, being dependent on the autonomic tone. We are aware of cases, and we have seen cases presented where a pre-excited normal child have been taken to the EP lab and decided to be safe accessory pathway, and he's doing extremely well. And then to see this same child after 6 months, after 1 year, coming with AF converting to VF in the ER, even after the EP lab was completely safe. So you have to think of this. The proper management of asymptomatic pre-excitation and strict catheter ablation indications have not been established. The genetics of SVT have not been adequately studied. There have been evidence for familial forms of AV nodal reentrant tachycardia, AV reciprocating tachycardia, sinus tachycardia, and atrial tachycardia, but data are scarce. The ablation indications, if we can speak in short, it will be any patient that is 4 years, 15 kilograms, with a supraventricular tachycardia. The first choice is EP and ablation, electrophysiological testing and radiofrequency ablation. This will be the first choice for him. But coming into more details, the first indication would be symptomatic recurrent supraventricular tachycardia due to AV nodal reentrant tachycardia, WPW syndrome, unifocal atrial tachycardia, atrial flutter. For these indications, catheter ablation is first line. And according, of course, to the patient's choice. But for us, it will be a first-line therapy. The second indication is atrial fibrillation with lifestyle impairing symptoms and inefficacy or intolerance of at least one antiarrhythmic agent. Both left atrial ablation for restoration of sinus rhythm and AV junction ablation for rate control are class 1 indications depending on the circumstance. The third indication is symptomatic recurrent VT. Catheter ablation is first-line therapy in idiopathic VT if that is the patient's preference. In structural heart disease, catheter ablation is generally performed for drug inefficacy or intolerance or as an adjunctive therapy with an implantable ICD who are experiencing frequent shocks that will drain the battery rapidly. Uncommon catheter ablation indications, according to European Society of Cardiology guidelines, are symptomatic drug refractory inefficacy or intolerance to with idiopathic sinus tachycardia. Lifestyle impairing ectopic beats, they're very frequent and impairing the patient's life. Symptomatic junctional ectopic tachycardia. Junction ablation for rate control are class 1 indications depending on the circumstance. Ablation is the treatment of choice for tachycardia-induced cardiomyopathy due to SVT. This particular indications, if refractory to medical treatment, is even indicated in the younger children. We usually try to avoid ablation below 2 years of age, but persistent heart failure, irresponsive to medications, is an indication. AV nodal ablation with subsequent biventricular or his bundle or left bundle branch spacing should be considered if the SVT cannot be ablated. Contraindications to catheter ablations, unstable patients. Relative contraindication are the patients who is less than 4 years, less than 15 kilograms. His risk is a bit higher. Few absolute contraindications to radiofrequency catheter ablation exist. Mostly apply to adults. Left atrial ablation, an ablation for persistent atrial flutter should not be performed. I again remind you that atrial flutter that presents in the first year of life usually responds to conversion of this atrial flutter and usually will not recur. The only thing to remember is to make sure that this patient does not have an accessory pathway, because this is a predisposition to atrial flutter in the first year of life. Usually when converted, whether by overdrive, whether by DC, they usually do not recur, and even medical prophylaxis is under discussion. Similarly, mobile left ventricular thrombus would be a contraindication to left ventricular ablation. The presence of a mechanical prosthetic heart valves are generally not crossed with ablation catheters. Female adolescents of reproductive age should not be exposed to fluoroscopy if any possibility exists that they are pregnant. Alternative energy source are being investigated. We are actually using now the cryoablation, particularly for the anteroseptal accessory pathways very near to the AV node, with the great advantage of reversibility before confirming the ablation. Research is also focused on developing better methods and tools for catheter ablation of ventricular tachycardia with structural heart disease or even VF. Epicardial ablation is being done now. For those who are very small, those who are younger than 4 years, less than 15 kilograms, we have concerns. The first concern is that radiofrequency lesion formation in immature sheep myocardium, similar to that in adult sheep myocardium acutely, but is associated with late lesion enlargement and fibrous tissue invasion of normal myocardium. So the lesion at first is the same, but later on results in a greater area of fibrosis. So as much as possible, we try to avoid ablating the very young and very small children. These observations may have implications for clinical RF procedures in infants and avoidance of RF ablation, if at all possible, in the first 2 years of life. Second, non-specific catheter and tools exist for the pediatric population. Currently available catheter, the minimum is a 5 French for non-irrigated RF tips. And curves are in general too large. This is particularly limiting in small children. Commonly, when the child is, let's say, 30 kilos or more, we are more, let's say, optimistic about the success. Finally, the experience of the operator and the center is crucial. Small patients requiring ablation should be referred to experienced reference centers for treatment. The number of catheter used and procedural radiation times should be minimized in these growing bodies. Electroanatomical mapping system are most valuable in this setting. An important consideration in children is the sports participation in the presence of a pre-excitation. For the presence of premature atrial beats with no symptoms, structurally normal heart, they are eligible for all sports. For the AV reciprocating tachycardia or atrial fibrillation in the context of WPW, ablation is mandatory. Sports are allowed 1 month after ablation if there are no recurrences. For asymptomatic ventricular pre-excitation, the issue of much debate, ablation is mandatory if the patient is at high risk. Better safe than sorry. Sports are allowed 1 month after ablation if there are no recurrences. For those with paroxysmal supraventricular tachycardia, evinodal reentrant, AV reciprocating tachycardia over a concealed accessory pathway and atrial tachycardias, ablation is recommended, and again, sports are allowed 1 month after ablation. If the ablation is undesirable by the parents, the patient, or not feasible for a reason or another, they're still eligible for sports, except those with high intrinsic risk of loss of consciousness, contact sports, for example. EP and radiofrequency ablation is first choice in most SVTs if the child is more than 15 kilos and more than 4 years of age. Thank you. Any questions?
من الحاجات اللي احنا بنسمعها في الجرايد، هل انت بتحذرنا من حاجه زي كده او examples اللي عمالين نسمعها في الجرايد؟
والله from the cases I've seen, يعني I can remember one case. The parents were doctors. The aunt was the head of the anesthesia department. And I came with an adolescent female. She was 12 years old, and she was having syncope. And she had a long QT. And I discussed with them and with the aunt and that she needs an ICD and this is very dangerous, but they totally refused the idea of either intervening or screening the rest of the family, or they did not want to do anything. And during the revolution, her sister died suddenly while asleep. Her sister. They heard pistol shots. The sister died. And then they considered that they should be doing screening and doing other things. Another one was a basketball player in Alexandria, but they responded and everything went well. Yani she had syncope. The parents felt the grave situation and they responded and everything was done and she was free afterwards. Dr. Peter was presenting last time, let's say, dangerous case where he let the child resume sports after having syncope, and he was confident to do so. I will not be that confident. Anything? يعني it will be يعني there will be doctors who will say not to intervene, and I have seen for example Professor Nadir Saoudi not intervening in patients like this, but I will let the decision be the parents' decision. put the data in front of them. There is a risk of sudden death, particularly in the presence of a family history of sudden death, and that the procedure itself is a safe procedure with very high success rate, over 90%, and we do not have to run into this risk, but it's their decision.
What would be your very short message in 2 sentences to the young doctors regarding the arrhythmias in general? What would be your advice, bullet advice?
The most important thing is to consult and refer. Whenever you see something that you're not fully aware of, either consult or refer. And EP ablation, EP test study, and RF ablation is available for almost anybody over 4 years, almost most forms of arrhythmias, and it's a cure for life, avoiding medications, avoiding surprises, avoiding risks. That's it.
Any question from the floor? I think we should finish our first session and the opening ceremony. Now, Professor Dr. Ahmed Osama Addah, Professor Dr. Amal Sisi, and Professor Dr. Wael Lotfi.
We are waiting for the dean coming back. Anybody wants any questions for to any of the other speakers?
صباح الخير، ازيك حبيبتي؟ اخبارك ايه يا رانيا دلوقتي؟
Oh, you were there for HRS? How was it? I have a research there. Ah, okay. Yeah, I just come this morning yesterday. Yeah. I don't sleep. Well, after I didn't sleep, brother. Yes, yes, yes. Welcome back. It was a good meeting. And they can't follow you. أيوة بالظبط هو ده HRS. Oh, like it's like HRS. Yeah. Have you ever been to nothing. There's the AP HRS and there's a Latin America. It's not on the future. Simulated وحاجات زي كده. يا انت معانا بكره وبعد خلاص يلا ان شاء الله. حلو. لا اتفضل. هاي اهلا بحضرتك. Thank you so much for having us. Thank you so much. We're so excited that you guys are putting this together. Thank you. See you again. Sure, of course. My pleasure.
Do you agree with me that arrhythmias became more common with all these phones and all these technologies? I think, or are we getting more aware of it?
I think it's the latter. Hi, how are you?
Nice to see you.
أخبارك
ايه انت والعروس الصغيره؟ قال على طول هو لا بنت الصحراء بتزعل لكن هي ما شاء الله هي خدت است يعني
الله يخليك. كمان تكلمني من عند حضراتكم على يوم 30
بنات
والله؟ خلاص تمام. الولاد
وانا اللي معازمين نص ساعة جاية صرف خدوني معاك خدوني. ايه الأخبار؟ عامل ايه؟ كله حلو؟ ليه بس الحالات بكرة وبعد كل خير إن شاء الله. The Soren mapping system, we've never used it before. Is it good or not?
It has a clear signal, sounds nice, but I think that they will be more comfortable with the heart of the heart.
Have you used it? How long have you used this sort of system?
Around 6 months.
You guys have liked it or
No. Well, actually, we have laid a lot of SVTs,
not VTs? Yeah. I'm a little bit worried about doing the VTs with us.
so I think that the heart will be
Let's see how the days go.
Yeah, we will discuss it and then I think today about triaging the cases again.
Yeah, we should. We should, yeah. I mean, I guess we can have some cases run simultaneously, maybe some cases we shouldn't do simultaneous.
Yeah.
صح؟ في some cases more challenging لازم نعملها لازم نبدأ فيه الأول وبلاش نبقى ماشيين في أوضتين يعني كلنا مع بعض. وفي some cases مثلا هي less complicated ممكن نعملها في أوضتين في نفس الوقت.
I heard they prepared some adrenaline for you. When they were preparing, they were telling me they're giving you the most complex.
Oh, yeah.
Hussein is doing some surprises for you guys.
We had a meeting الأسبوع اللي فات. We had a Zoom call.
Okay.
ربنا يستر إن شاء الله.
Inshallah, great results and would be a rewarding experience to visit yours. Again, we
You have no idea,
really,
yeah.
apart from the talk, really appreciating your visits.
You have no idea احنا we had so much so much fun when we came last year. We were talking about it for a long
Getting
time.
time out of there and driving and working and then going back. It's a lot.
Hi, how are you? It's a very nice talk. I really like it.
Dr. Wayne, ازي حضرتك? How are you? Good to see you. Dr. Rani had a question.
Oh yes, consulting with Dr. Wael about it. I have a few patients with long QT that are very well controlled on beta blockers. Their QTs are like in the range of 70 or 80, nothing above 500. Should we or should we not put an ICD in these patients?
If they're well controlled on beta blockers, then you should not. Yeah. Do you know have the genotype of their lung?
No, we do not have the genotype.
Yeah. Sometimes that can help in terms of risk stratification, but generally speaking, if they're doing well on a beta blocker, even if they've had symptoms before, you put them on a beta blocker and they stop.
Should they go back to exercise?
Very courageous, very courageous.
Can they go or can they not go
Well,
back to
the problem
exercise?
is that defibrillators in somebody who, let's say, is 15, who
They're
has
4 and 5.
4 and 5, even worse. For somebody that age, the risk of a defibrillator long term is probably higher than the risk of one
There's a point of debate between so many colleagues and should they go back to exercise or not?
Yes.
Yes?
That was
No,
easy.
you would say yes, so that's why I asked you. So, okay.
I think you're saying yes because you have it in every place. You have it only in the airport.
Yeah, so
Airport and in the cash and the cash and the cash.
So we say yes reflexively, but it's a long conversation. Even for the patient that I presented last year, this is a very difficult decision. Where we had to talk to the school and we talked to the coach and we made sure that there was a defibrillator around. So we don't just say yes and good luck.
I mean, would exercise stress ECG? Would an exercise ECG for them on both the doctors?
Yeah, but
would you do that?
they're not going to have an arrhythmia on the exercise test. What the exercise test really is for is to see if the heart rate is adequately suppressed with the beta blocker.
قاعدين في البيت لو جربوا حاجة هيكسبوا
Stay at home.
Yeah, I guess
go to school, do the morning exercise in school and that's it.
I have some patients.
It's so hard, and I'm so happy also to not be peds. I don't have to deal with these. I'm a adult.
Yeah, it's tough,
But you do agree with me, I was just asking Dr. Peter now about the arrhythmia, how much it became more frequent nowadays. related that to, are we more aware of it, or the service became better, or because of the new technologies, devices, and the watches and the phones?
We have some amazing success stories with fetal arrhythmia.
Yes, well, I've seen much more common now. Yes, yes.
I mean, even on the adult side, there's so much, because of the automated algorithms, so much AFib. I was مش عارف ايه كذا, and then the thing said I had AFib. And the patients now, they come and they read online and they say, my watch said I had AFib, I'm here for an ablation.
And they don't even feel anything.
They don't feel anything, and it's like طب فلكنايت شوية بس يعني.
أيوة, let's start something.
Just, yeah.
Going to ablation. Yes.
There were no
Yes, he had the clinic one day, exactly.
To ask for separate clinic for
A whole day to be dedicated only
One
to
day
the
a week.
arrhythmias, kids with arrhythmia. He would stay for a while. Yes.
there, and he was
Telling me, what are you saying? Yes. There are no kids with arrhythmia.
Thinking about the good old days when the two of us visiting.
What are you asking for? What is this?
With an ECG.
But your point is good. If there's one take-home lesson, it's if you don't recognize it for yes.
صباح الخير, ازي حضرتك؟
How you doing?
مش هتعجز ليه فجأة.
No, he's always. The spirit comes out. So what's inside comes out. Yes.
Yes, we were seeing patients, for example, a patient with cardiomyopathy. They brought him to the arrhythmia clinic just to do an ECG, we presented him with that round. And while doing ECG, it was an atrial and he was living on the upstairs and nobody recognized him. And then when ER was open, the monitors had bed. And then the referrals were doubled 5 times. 5 times as much because of the practice.
People started to see, started to see regular.
They were just saying it's
عشان
he has whatever else issue. And things gradually. It's such an immense effort اللي عملتيه. Yes,
She was the first one. Yes, the first one to join behind Dr. Wei.
Yes.
He's been my mentor forever.
Yes. When I started the clinic, we had only one ECG machine that was nobody wants it.
Yeah.
It was a one channel. We used to put it in P1 and then move it to and one nurse. And I was doing this to everybody to raise the awareness and to find things. And then gradually, Rania was the first one to join. She was due to travel to Chicago, I think. She had she was interested in neonatology, but she was due to travel on the 9/11. Oh, yeah.
Lucky me. I'm here.
Yes. So she did not. Yeah. And she joined.
No regrets.
And then after 3 years' time, we got a first photo. And then good ECG machine. And then another ECG machine. And then in 2001, I put the first pacemaker. Wow. Now multiple mapping systems, routine.
Now we're on the map. Yes. I mean, it was a very long success. I'm coming for a very long time.
Putting the first pacemaker was extremely. Leads were not present. Companies were not interested. We did not have money. Insurance that
who
time
would sponsor
did not
the
pay
things.
for it.
Up to now, they work through charity. They work through charity. Rodina had some efforts with NGOs to give them, but up to now, yes, they don't have. And now, doing pacemakers from units. How many do you do up to now? Yeah, but how many are? Yes, 1,000. And they're all not sponsored by the government. They're all NGOs donations. So the financial part is hindering. It's a hindering thing. Very big. That's why I mentioned you paying your air flight. Because if you didn't, maybe you wouldn't. This is only the Egyptians would understand what it is, because maybe we wouldn't have been able to pay it for you.
We're happy to, so happy.
Once we had a few patients done, we were able to go for sponsors to ask them for more.
To say we're good in this.
We've done it, it's successful, it's life-saving.
That's the way I see, if you agree with me, it really depends on the expertise in convincing parents with ablation. Parents في الkids, they're so scared. Yes, you have to have a very good relation and very good pacemakers أسهل. بس ablation is like, what if you perforate? What if you...
And getting syncope, and the father is refusing.
I have many and I have
The child will die.
the father is a doctor. He knows the risk of not the heart rate goes down to 28.
Yes.
He's still not patient.
And when the sister died, then you want to do something about it.
الأحسن الثانية تكون I want to tell you something. In Egypt here, kids move around with heart rates of 35, 40, and they're moving around. I was telling Gwen, how come? They go around.
حلو قوي.
ده كويس
ايوه وانت بتقولي 51 وبالذات اداء حلو جدا.
لا هو عشان الاهل قلقانين قوي لما لقوا ان في فانتونيا and goes down to 51.
And she was treated for cardiomyopathy with anoxin, Lasix, and Capoten with a heart rate of 35. Yes. And at that time we did not have the pacemakers ready, so we admitted her in the ER, put her on the temporary pacemaker until we could get something. And sometimes we did not have the money to pay the pacemaker. We get the pacemaker and we arranged the company, we will pay you in 2 to 3 months.
Till they got the money. And when he started for the post-operative arrhythmias, surgeons would tell him, what do you want from here? Go out of the operation theater. Come on, leave the patient.
What are you doing?
What are you doing? Yes, wallahi, it was very
Leave my patient alone.
Yes.
The surgeons, they would like, if he has the arrhythmia, they just contain it. And he would say like this.
Like 20 years ago, when they had a post-operative complete heart doctor,
yes, and like just stay in around
what are you
doing here.
Get
out of here.
Inventions that you see, what is this? Don't need this.
I've seen it once when it was going
doing
in
this
and the
forever,
surgeons tell
bizarre.
me, go out, go out.
That's so tough.
Things have been a long
Then
journey.
when the younger generation came, we used to take the patients. If we put the patient in the cardiology department, the surgeon will see him and will expel him from the pacemaker. So we
You
used
put
to
him in a
place
different
the patient
department?
in the general ward so that they cannot see him. And I take him from the general ward to the cath lab, put the pacemaker, and back to general ward, not in the cardiology. So nobody can see him.
It was very, it wasn't an easy thing to...
Different level of stress
And other things, patients with post-operative complete heart block, and we do not have money to get the pacemaker, like 20 years ago. And we all donated money, the nurses, the younger doctors, me, the others, and everything, except the surgeon.
The one who did it.
It's your fault.
They're in
When they
denial.
went to him, this is where it's problem. Go to
It's not me. Did I do this?
Right.
I'm trying to help. At least help us. Things like this, يعني.
So you've been missing some sun like this, huh?
لا هو so far actually it's been a good summer in Phoenix.
Online?
Yes,
It's been a very hot summer.
Here, very hot. Yeah.
It's just starting to cool off now.
Just today and yesterday.
Oh, really?
Just
Weekend.
welcoming you.
Yeah, the weekend was hot.
see what the temperature, yes, temperature was very hot. امبارح بس was a breath of air, just yesterday. Yeah, evening. Yes, only, that was the first evening we had a good breath of air.
Up till now, those wonders if I see they do not put atrial wires. بجد؟ طب let me tell you that عندنا they don't all put atrial wires. Yeah. And I tell them like please, beg, please just put atrial wires and so on.
Pediatric surgeons do. This is the
Why? They do, huh? They have to. Okay, so
we
you're
made a
secured.
protocol. We said, if these are the things you're operating on and these are the outcomes, you have to put wires in and then breathe. So now they do it for the cases we agree, which is
They
nice.
first told me we do not have money for it. So I got atrial wires, I bought them myself.
Yeah.
And gave it to them. Yeah. They put it in the ventricular position and they did not stick to the atrial wire. It was just an excuse. They would not. And I remember one of the patients that was a drastic one. I don't know if you remember him or not. We used to put the left atrial esophageal probe, particularly for the postoperative failure, the right ventricular dysfunction, to do a sequential pacing. And we had a patient like this, being hooked greatly after putting the DDD pacemaker with the atrial probe, and then the surgeon came to look after this patient, and we saw this. What is this? This is an esophageal probe for so and so. We do not need these inventions until we need it. And the child died in 10 minutes. Yeah. Before he finishes now, the child died. Yeah.
Big challenges.
Yes.
But you've come a long way, it sounds like.
Yeah, you guys, يعني فعلا it's so we were so impressed يعني لما جينا قوي يعني.
It's كمان the team it's well known for them that honestly they never let anyone down. يعني for consultations they're always there, for a second opinion they're always there, for intervention and they're known for a very cooperative supporting group for all the patients.
That's incredible.
We're still waiting for the deal. We should have come at 10 and then said 10:30 and then we are here 11.
Now it's 11.
I would suggest if he's not here give a talk يعني start with the talk عشان it's all backing up.
We should
yes,
just continue.
yes, do ولو هو جه وقف.
Yeah, we stop. That's right.
قول لهم كده خليهم يبدأوا بواحدة.
Dear guests, معلش, we're just waiting for the Dean of the Faculty of Medicine, Professor Hussein Salah, to arrive in 5 minutes, inshallah, and we will start the opening ceremony.
It makes sense. Just to move along with the day. They have all the speakers wrong. This is your talk, right?
Yeah, right. Hopefully they're not going by that.
definitely feel like my the topics are not going to sit well with the audience.
Yeah. So it seems like that's not even the point anymore. It's just kind of like
We're doing
sit
this.
there, talk
We're
about
doing this.
something
Yeah.
like, you know,
I think so.
check the box, move on. That's the deal.
I don't get that sense. Is he? Maybe. Okay,
right.
of the medicine. Okay.
السلام عليكم. بنعلن بداية حفل الافتتاح للمؤتمر المصري لاختلال ضربات القلب في الأطفال الأول. بداية نرحب بأستاذ دكتور حسام صلاح، عميد كلية طب القصر العيني جامعة القاهرة. أستاذ دكتور أحمد قداح، رئيس أقسام طب الأطفال جامعة القاهرة. أستاذ دكتور حسن خالد، أستاذ القلب وطب الحالات الحرجة جامعة القاهرة. أستاذة الدكتورة أمل السيسي، أستاذ طب الأطفال ورئيس وحدة قلب الأطفال جامعة القاهرة. أستاذ دكتور وائل لطفي، مؤسس وحدة اختلال ضربات القلب في الأطفال بجامعة القاهرة. ندعو دكتور وائل إلقاء كلمة في حفل الافتتاح. اوكي سوري دكتور، ام سوري. هنعزف الاول السلام الوطني وبعدين حضرتك اتفضل. ندعو أستاذ دكتور وائل لطفي لإلقاء كلمة في حفل الافتتاح.
بسم الله الرحمن الرحيم. طبعا أحب أرحب بالسيادة العميد وبالسادة الضيوف وبأساتذتي وزملائي. اليوم ده الحقيقة يوم فخر إننا أول مرة عملنا مؤتمر متخصص فقط في الأريثمياز، مش ملحق بأي تخصص تاني. البداية كانت الحقيقة فكرة من الأستاذة الدكتورة فادية محمود أستاذتي، اللي أدين لها بالفضل والشكر، اللي توجهت للأستاذ الدكتور شريف مختار والأستاذ الدكتور حسن خالد، قبلوني كطالب ماجستير ثم دكتوراه، وربنا كرمنا جميعا ب younger generations شاركتنا وكبرنا كلنا سوا وربنا بارك وقدرنا نقدم سيرفيس بعد ما كنا ممكن نعمل one intervention per year. أول ما ابتدينا في صعوبات بالغة وصلنا إننا عملنا أكتر من 1000 حالة تركيب منظمات بنعمل حالات اي بي وابليشن كل اسبوع، على الاقل 2-3، ولو في ورك شوب ممكن نعمل 15 حاله في 3-4 ايام. بنعمل كل حاجه موجوده وورلد وايد بمساعده زملائنا من كليفلاند ومن كل مكان. الحقيقه الحمد لله ارجو اننا نكون بنأدي خدمه جيده في جامعه القاهره وفي كل مصر. احنا the only pediatric arrhythmia dedicated section و intervention center في كل مصر، وعلى حد علمي في كل افريقيا. شكرا.
والآن أدعو أستاذ دكتورة أمل السيسي لإلقاء كلمة في حفل الافتتاح.
بسم الله الرحمن الرحيم. أنا سعيدة جدا أن أنا موجودة النهاردة. برحب بسيادة العميد، بسيادة الأستاذ الدكتور حسن خالد، بزملائي، بأساتذتي، بأبنائي الطلبة. أحدثكم اليوم وكلي فخر وسعادة وانتماء لمدرستنا العريقة القصر العيني وأبو الريش التي خرجت هؤلاء المبدعين. دكتور وائل، من أول دكتورة فادية ما وجهتنا للدكتور وائل وكل أعضاء عيادة الأريزميا في قسم القلب، أدخلوا في جمهورية مصر العربية تخصص الكهرومغناطيسية في الأطفال وعلاج اضطراب ضربات القلب التي تودي بحياة أطفالنا سنويا بأعداد لا نعلمها بالتحديد، ولكن نعلم أنها ليست نادرة في بلد تعداده 106 مليون يولد به طفل كل 30 ثانية. طوبى لكم وطوبى لكل مجتهد ولكل عالم ولكل طبيب ولكل من يعطي بلا مقابل. إن بلدنا تحتاج إليكم أنتم الأطباء والعلماء، فلا تبخلوا ولا تترددوا، وتذكروا أن العلماء هم ورثة الأنبياء، وكل طريق سلكتموه في العلم هو طريق إلى الجنة كما قال نبينا عليه الصلاة والسلام. ما أعظمها من مكانة، فتحملوا وجاهدوا وصابروا ولا تتوقفوا عن العطاء والاجتهاد والكد والكفاح. أنتم القصر العيني. اللي فاكر عمدنا الدكتور هاشم فؤاد الله يرحمه كان بيقول لنا كده، كان بيقول لنا اضرب رجلك على الأرض، أنت القصر العيني. فأنا عايزة كل الناس تقوم، تلامذة القصر العيني وأعضاء القصر العيني يضربوا رجلهم على الأرض، إحنا القصر العيني. شكرا.
والآن أدعو أستاذ دكتور أحمد أسامة قداح، رئيس أقسام طب الأطفال جامعة القاهرة، لإلقاء كلمة في مؤتمر.
بسم الله الرحمن الرحيم. برحب بسيادة العميد وحضرات السادة الموجودين. طبعا مش هطول على حضراتكم عشان يعني في جدول مزدحم جدا، بس أحب أقول إن زي ما قال الدكتور وائل إن البيدياتريك أريزميا أول مؤتمر ليها. بالنسبة للجنرال بيدياتريكس نقدر نقول إن التركيز على سلسلة المحاضرات في البيدياتريك أريزميا حطيناها في سلسلة المحاضرات العملية التعليمية، وأول امتحان للجنرال بيدياتريكس ماستر نزل فيه اي سي جي واي اي جي، يعني امانج حاجات تانية. يعني عملنا تغيير في شكل الامتحان بحيث ان نبدا على مستوى الجنرال بيدياتريكس سواء في الماستر او في الام دي الاثنين مع بعض. ف يعني ان شاء الله بتكون في يعني كمان شفنا النتائج الحمد لله كويسه جدا. يعني الموضوع ما كانش يعني صعب ولا حاجه، قدرنا ان احنا ندخلها، وقدرنا ان احنا ممكن ابتدينا بحبه فرايتيز، ممكن نزود الفرايتيز بحيث الاويرنس قصه السينكوب اللي بتحصل دي محدش بيقدر يفصل الاي سي جي والاي اي جي والريزون اوف سينكوب في مرحله الجنرال بيدياتريكس الا لو كان هو ويل تريند للقصه دي. شكرا جزيلا، وبشكر سياده العميد اللي شرفنا، وبديله الكلمه. اتفضل.
والآن كلمة أستاذ دكتور حسام صلاح مراد، عميد كلية الطب جامعة القاهرة ورئيس مجلس إدارة مستشفيات جامعة القاهرة.
صباح الخير، أهلا بحضراتكم. في الحقيقة أنا سعيد بوجودي معكم اليوم في هذا الجمع العلمي الاستثنائي وفي تخصص دقيق، ويشمل تخصص هذا التخصص الدقيق علاقة بينية ما بين العديد من الأقسام. قسم القلب طبعا حالات الحرجة متمثل فيه، وقسم الأطفال. وطبعا يعني ما أسعدني هو أن في ثمرة منذ عدة أعوام نبتت في أحد الأقسام الأخرى وترعرعت في قسم آخر وهو قسم الحضن، قسم الأطفال. في الحقيقة كلية طب قصر العيني كان لها الريادة منذ ما يقرب من 197 عاما، وهذه الريادة هي تحدي ومسؤولية، ليست فقط فخر. والتحدي والمسؤولية يدفعنا لنعلم ما نحن فيه وما هو موقعنا وما هو المستهدف والذي نستشرفه في مستقبلنا القريب والبعيد. وإن اليوم وجودي مع حضراتكم مع المنصة الكريمة التي أحب أن أرحب بها كل بصفته واسمه، الأستاذ الدكتور أحمد الداح رئيس قسم طب الأطفال، أستاذ الدكتور حسن خالد الرئيس الأسبق للقسم وأستاذ طب حالات الحرجة، أستاذ الدكتورة أمل السيسي رئيسة وحدة القلب الأطفال، والأستاذ الدكتور وائل لطفي مدير وحدة اختلال ضربات القلب، والسادة الأجانب المدعون من الخارج لحضور فعالياتنا اليوم. في الحقيقة قصر العيني عليه مسؤولية، هي مدرسة الطب ومنبع العلماء، والعلم ينقسم بمحوريه: العلوم الإكلينيكية والخدمات الطبية التي نقدمها ونستحدثها يوما تلو الآخر، والابتكار. وخليني أقف عند كلمة الابتكار، يمكن هذا أمر لم نتقرب منه من قبل، وهو تحدي عالمي، وما نشهده من طفرات سريعة وثبات سريع على مدار الأعوام السابقة يدعونا للقلق ويدعونا للاهتمام، لأن وضعية كليات الطب ليست فقط تقديم خدمات علاجية. نحن لسنا مستشفى، ولكننا علماء. دورنا أن احنا نبتكر ونبحث ونعلم، وإن لم نفعل ذلك لم نصبح كلية أو مدرسة للطب. في الحقيقة أنا سعيد جدا بوجودي في تخصص دقيق كهذا، وما يسعدني أكثر إن هو بدأ يبقى فيه تبادل علمي وخبرات علمية نصبو أنها تصدر توصيات من خلال هذا الاجتماع المتميز اليوم، لتكون لها أثر تنفيذي داخل كلياتنا ومستشفياتنا وعلى مستوى الصحة بمصر. في الحقيقة الدكتورة أمل لسه قايلة احنا ما نعرفش عددهم قد ايه وارقامهم قد ايه، يبقى أول حاجة تستدعينا إن احنا نعمل ناشونال ريجستري. دي أول حاجة. طبعا لما نتكلم بهذه اللغة، وأنا لسه جاي من أحد دول أوروبا ولسه ماضيين اتفاقية، طبعا نعرف الجابس اللي ما بيننا شوية. فاحنا أول حاجة نعملها نعمل ناشونال ريجستري، ونوصي بذلك في مؤتمرنا، ونبدأ نعملها داخل كلية الطب قصر العيني ومستشفياتها، وندعو السيد أمين مجلس الأعلى للمستشفيات الجامعية ونرفع تقرير لمعالي وزير التعليم العالي لبدء الناشونال ريجستري من خلال المستشفيات الجامعية، ونخاطب معالي وزير الصحة بهذا الأمر. ثانيا، نحفز أكثر العلاقات ما بين الكلية والمستشفيات الأخرى التي نستطيع أن ندعمها، لأن صحة الطفل المصري هي من أولوياتنا، لأن هو طول عمر قصر العيني بأبو الريش مدرستها مدرسة الأطفال هي الراعية والحاضنة لصحة أطفال مصر، فيجب أن تبقى وتستمر وتستديم على احتضان هذه المسؤولية. وهذه المسؤولية لا تمتد فقط لتقديم الخدمة داخل أسوار القصرين، ولكن تمتد إلى تقديم المعونة العلمية والتدريبية والتعليمية لزملائنا في قطاع الصحة والمستشفيات والجامعات الأخرى. فبالتالي يعني اتمنى دكتور وائل ان احنا ندرس هذا الامر دكتوره امل، ونشوف هنقدر ازاي ندعم المستشفيات المجاوره داخل. ثالثا، عندما سافرت بالخارج وجدت الابتكار، ووجدت رئيس اسم القلب بجامعة كيل هو ابن من أبناء كلية طب القصر العيني، دكتور حسن هو رئيس اسم القلب هناك بيفتخروا بيه. وحضرتك تعلم ان هم هناك بيبتكروا ويصنعوا اساطر داخل كلية كيل، وبيصنعوا الصمامات، وبيصنعوا خلية دي بتاعتي الكويلز، برين كويلز ب 3 دي تكنيك. ده يدعونا لنقف امام انفسنا ومسؤولياتنا ونعلم ما هو دورنا. هل سنبقى اطباء ام سنبقى علماء؟ عشان كده انا قلت العلماء ليها محاور، تمام؟ هل سنبقى علماء ام اطباء؟ لو عايزين نبقى اطباء ده مسار، انما لو عايزين نبقى علماء، العلماء يشملوا الاطباء والابتكار والبحث العلمي. فمن هنا أنا بطلب من حضرتك توصية الدكتورة أمل في مجال ابتكاري نستطيع من خلاله أن نحدث تغيير في المنظومة الصحية في تخصص الكهربائية للأطفال وتفيد العالم والدولة المصرية. في الحقيقة أنا لا أريد أن أطيل على حضراتكم، وأنا سعيد بوجودي مع حضراتكم اليوم. إن شاء الله أتمنى لكم مؤتمر علمي موفق، وأتمنى لكم دائما الدوام والسعادة والاستمرارية والاستدامة. شكرا. شكرا.
والآن يشرفنا أن نقدم درع تكريم لأستاذ دكتور حسام صلاح، عميد كلية طب جامعة القاهرة ورئيس مجلس إدارة مستشفيات جامعة القاهرة. كما يشرفنا حد مش مشكلة. كما يشرفنا تقديم درع التكريم لأستاذ دكتور شريف مختار، مؤسس وحدة طب الحالات الحرجة كلية طب قصر العيني، ويتسلمها نيابة عنه أستاذ دكتور حسن خالد، أستاذ القلب وطب الحالات الحرجة. كما يشرفنا أن نقدم درع تكريم لأستاذ دكتور أحمد أسامة قداح، رئيس أقسام طب الأطفال جامعة القاهرة. نعلن اختتام حفل الافتتاح، وإن شاء الله نتوالى تقديم باقي سيشنز المؤتمر. نتواصل مع السيشن رقم 2، وأدعو السادة chair persons للحضور على المنصة.
دكتور وائل فين؟ دكتور بيتر عزيز الحقيقة؟ اوكي.
هو البروجرام غلط.
دكتور بيتر عزيز.
البروجرام غلط.
مكتوب غلط.
سنة.
بعدين انا؟
يعني دي بيتر.
بعدين بيتر وبعدين
PDF اللي بعتوه مش صح. يعني انا عليا انا I'm giving the star. Peter is giving the star.
So they mixed the sessions?
I don't think they mixed the sessions. I think that the speaker assignment is just. I think the next session is Peter.
ودينا خلاص نبتدي ها؟ Okay. بسم الله الرحمن الرحيم. I would like to welcome you all. Actually, this conference has a very special meaning to me. It's one of our dreams. I was just reminiscing with Professor Wa'el Lutfi, the founder of Pediatric Arrhythmias and a very prominent mentor for so many of us. I would like to thank you, Dr. Wa'el Lutfi, for everything that you've done for the Pediatric Arrhythmias and for establishing the Pediatric Arrhythmia Service at Cairo University. So many people would have accused you of being an illogical dreamer, but where are you now? So you've showed them. And thank you very much for everything that you've taught me personally and the entire team along the years. It's been quite a pleasure working alongside you and making so many decisions for so many patients. So thank you. And it's a chance to say thank you to my very dear friends and colleagues, Osama Abdelaziz, Rudaina Sobhi, Hussein Ahmed. These are the musketeers who have taken our arrhythmia service to the next level. They have shown relentless diligence, and their amazing efforts have really provided all the difference that where we stand now in the Pediatric Arrhythmia Service at Cairo University. So it's quite a pleasure to be among this great team. I would like to introduce our next speaker, who really does not need any introduction, Professor Peter Aziz. He's the Director of Pediatric Cardiology and Electrophysiology in Cleveland Clinic. Thank you, Professor Peter, for everything that you've been cooperating with. And he's going to be talking with us about diagnostic evaluation in children with a family history of sudden cardiac death.
Thank you again for the kind introduction. Okay, thank you. Again, nice to be here and nice to be with old friends and making new friends here in Egypt. We're going to be talking about sudden cardiac death in the young. I want to present to you our first case here is a 14-year-old. This is a patient of mine that was running on a treadmill at a gym and had a cardiac arrest. While he was unconscious, there were people at the gym, including an emergency room physician, and there were 2 nurses there that resuscitated him. They put a defibrillator on, and he was appropriately shocked for ventricular fibrillation. and he actually had a normal recovery. And this is his electrocardiogram, which I'll admit to you has very subtle findings here in the inferior leads of T-wave inversions. But when we perform an echocardiogram on him, you could see the obvious finding here of hypertrophic cardiomyopathy. And that was his diagnosis. To provide some perspective, this is a paper that Barry Marin wrote in Circulation, one of the historic papers that we look at in the United States, looking at autopsy-related diagnoses of sudden death in athletes. And you see here that hypertrophic cardiomyopathy is the lion's share of the diagnoses when it comes to autopsy. If you look at the ion channelopathies, including long QT syndrome, it's a very small proportion of the sudden deaths, though we have to remember this was an autopsy study, not a molecular study. So clearly there's limitations in this. But at least in the United States, HCM is most certainly up there in terms of the leading causes of sudden death in the young. This is his asymptomatic 15-year-old sister. And if you look at this electrocardiogram, it looks pretty normal. Turns out, though, that she had the same TNNT2 variant, HCM genetic variant that her brother had, and her echocardiogram showed the same degree of septal hypertrophy. So she also had the diagnosis of hypertrophic cardiomyopathy. And after discussions with her and relying on our diagnostic criteria indications for ICD implantation, she most certainly met criteria having a first-degree relative that had sudden death for a defibrillator. So we implanted a defibrillator in her after many challenging discussions with the family, given the fact that she was asymptomatic. And 6 months later, she was running to class, had sinus tachycardia that degenerated rapidly into ventricular fibrillation, and she received a shock from her device, an appropriate shock for VF, and converted to sinus. So this is a story of success. There were wins in this case, a brother who had a successful resuscitation for a cardiac arrest. His sister, who was asymptomatic at the time, was identified as having a substrate for a life-threatening disease and appropriately had a defibrillator. And this is when we feel good about ourselves. But unfortunately, not all cases are like that. These are 3 examples of pediatric patients in the Cleveland area that all had passed away from presumed sudden cardiac death. So putting this into perspective, this is a paper that examined Google searches from causes of death in the United States. So what do the common population look up when they're looking up health-related causes of sudden death? And just by way of statistical analysis, heart disease is the leading cause of death in the United States, followed by cancer, and then followed by the rest of these diseases, which really have a very small share of the causes of sudden death. Heart disease and cancer are the leading causes. When we look up what people search about in Google, cancer really is the leading Google search topic, and then heart disease falls towards the bottom. And if we look at what's covered in the media, terrorism, which kills very few people in the United States, is one of the most commonly searched topics as far as death-related incidences. So there's certainly a discrepancy between what is real, what is perceived, and what people are interested in. If we look at CDC data, the Center for Disease Control in the United States, for the last 20 or so years, they looked at the 10 most common causes of death in pediatric patients, 1 year to 19 years of age. And this is what they found. They found motor crash vehicles have always been the #1 killer of young patients, up until laws implemented, seatbelt laws, airbags. Safety has really changed the metric there for death-related motor vehicle crashes. Firearm-related injuries, unfortunately, have increased quite a bit. And drug overdose here has crept up. We have an opioid crisis that we're dealing with in the United States, so this has gotten better recently. And then heart disease is here in blue, and heart disease has been flat for decades. So the incidence of sudden death related to heart disease in the young is low and certainly hasn't changed much. So what do we do to evaluate patients First is the screening. This is an example of a pedigree that you're all familiar with. A patient that we saw is this patient here. She was referred for non-cardiac chest pain. We discovered that her paternal, this is her father, her paternal uncle is this patient here who died while he was in college after his alarm clock went off. Certainly had the story to suggest long QT syndrome type 2, and of course our patient was diagnosed with that disease. So getting a detailed family history and understanding how things relate, this father was also the carrier of long QT syndrome, is crucial in terms of screening. The American Academy of Pediatrics, along with PACES, published a consensus statement that's seen here that really starts the evaluation with the primary care physician. If the primary care physician feels that there is some issue that requires referral, then they do. Otherwise, the primary care physician can screen somebody and say that they're normal and don't need to be restricted from sports. And then there's the community advocacy side of things. Emergency action plans, public education, having AEDs in schools. In Ohio, the state that Cleveland is in, there's a lot of legislation now that focuses on having AEDs present in schools that are government funded, which is something that's relatively new for us as well. How do we assess the symptomatic relative? So once somebody experiences a sudden death, you really want to look at all first-degree relatives and find, is there somebody that has some phenotype that we can explore? This is an ECG. Of course, there's echocardiograms. This one shows a dilated LV, genetic testing, and then exercise testing. This is really what's in our armamentarium in terms of diagnostic testing for sudden death in the young. What about after the event happens? So in the post-mortem phase, this can be very, very challenging. After somebody suffers a cardiac arrest, how do we figure out what happened to them? This is where we start digging. We have to get creative, examine the medical records, look at ECGs that may have been performed years ago for this patient, try to use our electronic medical record to get diagnostic clues for probably was not diagnosed at the time. And then a cardiac autopsy can help in certain ways, so it can evaluate for evidence of cardiomyopathy, myocarditis, anomalous coronary arteries, even ischemia, which is pretty rare in children. But what it does not evaluate for is, of course, the genetic causes of sudden death in the ion channelopathy world, long QT syndrome, CPVT, and Brugada syndrome. And that's where the molecular autopsy can actually help, though you need a specimen to do a molecular autopsy, and we don't always have that when somebody dies suddenly. And it also has to be appropriately captured in these purple top tubes, which isn't always done. So we don't always have a molecular autopsy specimen. When we do the best we can do in terms of diagnostic yield, where are we? What does this all look like, practically speaking? So this is a study by Bagnell et al. In the New England Journal of Medicine in 2016 that looked at sudden cardiac death cases for patients that were 1 to 35 years old in the Australia and New Zealand region. And they identified 490 cases, and this is what they saw. The vast majority were in the unexplained category, and then few had coronary artery disease, and then a smattering of other diagnoses here. You could imagine that the coronary artery disease were in patients that were on the older side of this age range, and the younger patients were more likely to have unexplained disease, which is what this graph shows. So if you look at patients that were young in this box, the same amount of patients that have sudden cardiac death, most all of them were unexplained. So the younger that you are, the more likely it is to be unexplained. And as patients with sudden death are older, we find that this graph diverges, having an explained cause of sudden death, which is what this blue line is much more common. And that's likely because coronary disease becomes more prevalent in the older population. This is a study by Elijah Baer in the European Heart Journal in 2008, looking at 57 families with an unexplained death in the family, and they evaluated family members, so first-degree relatives, there were 184 of them, to try to find whether there were diagnostic clues. And what they found is in about half, they were able to identify a cause through either genotyping or phenotyping. So they sent molecular autopsies on these patients. So half of them, though, did not have a diagnosis, even after a relatively thorough genetic evaluation. So even with genetic evaluation, as sophisticated as it can be, we're still not finding out the causes of sudden death in the majority of patients. And another study here showing similar data, the amount of sudden deaths that were diagnosed were only 11% in this study, and these are the diseases that they had. You see CPVT, dilated cardiomyopathy, ARVC as examples of causes. So ultimately, I think our struggle here is that these patients, despite the fact that they're young, that they're otherwise healthy, even with cardiac autopsies, molecular autopsies, family histories, examinations, we're still missing several patients that are dying suddenly, unfortunately. So what have we learned here? Sudden cardiac death in the young is rare, but of course devastating. Causes are not frequently identified in the post-mortem. Screening patients has its limitations. And secondary prevention, probably of all the things that we discuss, secondary prevention is having AEDs around and having CPR-trained providers around is probably the most cost-effective way of preventing sudden death in the young. Thanks for your attention.
Was resuscitated and then arrested again after being resuscitated. So what would you expect that this would be? What kind of arrhythmia was that?
Well, if anybody that arrests that...
Because everyone is asking me all over the world, you're athlete that do you know what did he die of? I say, no. So what do you expect?
Well, I don't know
People
either.
are asking.
I don't know either. But I think in a situation like that where somebody arrests and they have a ventricular fibrillation and the myocardium hasn't been perfused for some time, even if you just successfully defibrillate them, regardless of what the disease is, the recurrence of ventricular fibrillation can be very common. Whether it's long QT syndrome, hypertrophic cardiomyopathy, any of them, once the myocardium is unstable and there's acidosis and all the electrolyte derangements that happen after an arrest, it's very common to have arrests continue in that immediate period.
But not after 2 weeks of recovery.
Oh, it's 2 weeks after.
And recovering and having a TV show and talking about his arrest, and then he arrests again.
Yeah, that is a little unusual. Yeah, but that still doesn't probably point to a specific diagnosis, but that is atypical for sure. Yeah.
When people ask, we don't know. It didn't prove to be long QT or anything that we know of.
That was it. Yeah, interesting. He's had a thorough evaluation, and there's still not a diagnosis.
He must have, because he was in hospital for a few days, and
Yeah,
then
sure.
he went home, and he had a TV show, and then arrested.
Arrested again. Yeah. Unfortunate.
Thank you, Professor Dr. Peter, for very nice presentation. And now I'm very happy to introduce my dear colleague, Professor Dr. Rania Hijazi, Professor of Pediatric and Pediatric Cardiology. Really, it's a very important and topic in our practice, pediatric syncope when to worry.
Thank you, Professor Faten, for the introduction. Can I have the presentation, please? Wow, what a view. It's quite interesting that so many people are interested about pediatric arrhythmias. I'm going to be talking about pediatric syncope and when to worry. Actually, there are fewer clinical presentations in pediatrics that are more confusing or troublesome than syncope. And anyone who does not believe that probably does not know enough about syncope. So let's revise the facts. Syncope is very common at all ages, and approximately 30% of children will experience at least one episode of syncope before the end of their adolescence, and they account for about 5% of the emergency department visits. The syncope care is inefficient, inappropriate, costly tests and admissions are being made, which is quite a burden on the healthcare systems, and the diagnosis is often not made because guidelines are not followed, and we do not really have specific pediatric guidelines that we adhere to, and many of those who care for syncope patients are not sticking to the algorithms that are out there. So what is syncope? Syncope is actually defined as the sudden transient loss of consciousness where the patient is not able to maintain his postural tone and he will spontaneously recover without any need for resuscitative efforts. It is secondary to a global cerebral hypoperfusion. If the patient does not lose consciousness, then he is only a pre-syncope or near syncope. And this is a very common presentation that everyone who deals with pediatrics has seen. You will get a patient that tells you she has a 9-year-old son who fainted yesterday, and she will want to know, now that he's completely fine, should she worry? Is it serious? Can she take him back to his practice? Should she be doing any further investigations? So these are the questions that you're going to be faced with when you see a patient who's now totally fine, and it's up to you to direct the further and where the patient is going to go next. So when you're faced with a patient with syncope, and that is the transient loss of consciousness, we can all refer to the European Society of Cardiology that put the syncope in this context, where you think of transient loss of consciousness. Is the patient, is it a traumatic case? Is it a non-traumatic case? If it's non-traumatic, then you're left with syncope, epilepsy, psychogenic, and some of the rarer causes like breath-holding spells. And syncope can either be reflex syncope, orthostatic hypotension, or cardiac. And this table that was mainly extracted from the guidelines of the American College of Cardiology that was talking about the guidelines for evaluation and management of patients with syncope. We have the vasovagal syncope, which is the most common, where the patient will have a very typical prodroma. Usually it happens while the patient is either standing or sitting, and then after he may be fatigued after the episode, but will definitely be very alert. It might be an orthostatic hypotension where the patient is not tolerating or not maintaining his blood pressure during standing, and we have the very common initial orthostatic hypotension where the patient may not maintain the blood pressure for the first few seconds after standing, or the classic orthostatic hypotension where the diastolic blood pressure of the patient will drop around 10 or more, or the systolic blood pressure 20 or more within the first 3 minutes of standing. And we have, of course, the nightmare of the cardiac syncope. And this paper this is a review article, systematic review article that looked at what were the final diagnoses of patients who presented with syncope along a 5-year period. And we can see now that the vasovagal syncope is the vast majority, and the nightmare of the cardiac syncope represents around 4% of our patients. It's a nightmare, but it's still there. So why is syncope so challenging? It's challenging because, as we can see, the etiologies are spanning so many various disciplines. Do we refer to a pediatric cardiologist? Is it a neurologist? Is it a psychiatrist who should be treating the patient? And the vasovagal syncope, which is by far the most common of the diagnoses, is an orphan diagnosis that really is not adopted by any particular discipline. And the causes range from the completely benign to the potentially fatal, and it's up to you to decide which is which. These are the causes of the cardiac syncope in general. We have either the arrhythmias, whether they are the bradycardias, the tachycardias, the long QTs, the brugadas, or the arrhythmogenic right ventricular dysplasias, the congenital long QT. So potentially most of the arrhythmias may present with syncope. And we have, of course, the structural heart disease, mainly the LVT obstructions, the patients with HOCM, with aortic stenosis, sometimes with severe pulmonary hypertension may present with syncope. So before you see the patient, you need to know that the ESC has put 3 obligatory features that the patient should be fulfilling to make the diagnosis of syncope initially. He has to have had loss of motor control, no response to touch or speech during the episode, and when he wakes up, he is not remembering the episode, so total amnesia. You have to have the 3 obligatory features to be able to make the diagnosis of syncope. And once you make it, you start thinking, your mindset should be, is it the heart? Because although it is only 4%, it is the potentially fatal one, and you need to go through this should be your mindset when you are examining a patient of syncope. You need to get that out of the way. Is it the heart? Or is it not even a syncope? Is it seizure? Is it the common vasovagal? So we need to go through a process of how can we reach the diagnosis in a patient with syncope. You need to do a very proper initial evaluation that we're going to discuss in detail, and that will help you to risk stratify your patients and maybe order further investigations if they are needed. So the initial evaluation is the history taking, the physical examination, and the ECG. I can't really emphasize how important the history taking is, so please take the moment. I know in our clinics everything is so busy and everything is so crowded, but taking extra moments to know and knowing exactly what to ask your patient and properly interpreting the symptoms and the signs that he is presenting with will make a lot of difference. So history taking is very important, it's very crucial, and you should be asking things like questions about the prodromal symptoms. What was the patient doing? How was his position? Because as we know, standing and the gravitational effect on the blood makes it much more likely for the vasovagal syncope to occur during standing, maybe sitting. But if the patient is complaining of a syncope during the supine position, it is much less likely to be a reflex syncope. It's not impossible, but it's much less likely. And this is one of the red flags for either a cardiac syncope or a seizure. And then the activity. And please do not confuse a mid-exertional syncope from post-exercise syncope. So if the patient is complaining of syncope during exercise, before the child had time to recover from the exercise, this is one of the most important red flags for pediatric syncope that is caused by a cardiac etiology. However, a post-exercise syncope after the patient has had the time to relax and rest after the exercise has a very similar mechanism to a vasovagal syncope, and that is benign. So a mid-exercise syncope is one of the most important questions and the most important things to look for in a patient who's presenting with loss of consciousness. And then you ask about the onset of the attack. Please take a moment to ask about the prodroma. Did the patient feel anything before collapsing? Because we have prodromas either due to autonomic activation of the sympathetic and the parasympathetic activity, or due to consequences of the retinal and cerebral hypoperfusion. So the patient will be complaining of lightheadedness, some blurring of vision, some dark tunnel vision, sweating, facial pallor, and nausea. However, the recent studies have suggested that there are so many inconsistencies about the value of prodroma in really classifying a cardiac and a non-cardiac syncope. And that is because sometimes patients, about 50% of patients with cardiac syncope will complain of a prodroma, and the most important part of the prodroma is the palpitations. And that is why asking about palpitations in its own should not be considered a part of the prodroma. Please ask about palpitations specifically, because palpitations before the attack of the syncope has been found as an independent clinical feature that really predicts, that has a high sensitivity and specificity for cardiac syncope, because we have patients who will have ventricular tachyarrhythmias. They will have up to 2 minutes before they go to syncope. During these 2 minutes, they will probably be complaining of palpitations. The fall type, if the patient was flaccid or the patient was spastic during the fall, usually flaccidity is against seizures. The movements. And actually, I'm mentioning this slide because convulsive movements do happen with vasovagal syncope. They are related to the degree of cerebral hyperperfusion that will happen with vasovagal syncope. And owing to the convulsive features that some of these patients have, they may see tonic, myoclonic muscle activities, sometimes even eye deviations. Unfortunately, 35% of patients with the reflex syncope have been prescribed at some point of their life some form of an anti-epileptic. And that is a very high percentage. And one of the most important confusing features is that you think, well, any pediatrician would believe, if the patient has abnormal movements during the episode, then this is epilepsy. Well, this is actually not the case. Sometimes vasovagal syncope may have abnormal convulsive movements. It is related to the cerebral hypoperfusion. The duration of the loss of consciousness is very important. Usually patients with benign syncope will have a very short duration that is usually less than 30 seconds. However, if the patient, after he falls, people are trying to help him to sit rather than lie down, this may prolong the duration of loss of consciousness. And eyewitnesses are not reliable because a mother would tell you he's been out of it for more than 5 minutes and it was only like 30 seconds. So it's a bit challenging trying to find out the duration, but if you simulate it and the patient faints for less than 30 seconds, this is quite benign. Tongue biting has been very strongly related to epilepsy. And urinary incontinence has no relevance and no value in the differential diagnosis between epilepsy and syncope, because it's been a myth that we really follow. If the patient is incontinent during the attack, you would spontaneously think that this is epilepsy. However, it has no value in the differential diagnosis between them. Questions about the end of the attack are very, very important. What did the patient do when the attack ended? Any post-ictal disorientation that lasts for more than 30 seconds suggests an epileptic seizure. Any patient who suffered an attack of syncope may show fatigue, but the patient is mentally alert, and this should not be confused with any mental disorientation or confusion. So any confusion post-ictal suggests highly that this was an epileptic seizure. Do not forget to ask about the family history. It is very important to know if there has been family history of any sudden cardiac death, of any arrhythmias in the family, if the patient himself was treated for a heart disease years ago, and any medications that he's been keeping on. So from the history, these are the red flags. If the patient had a mid-exertional syncope, a family history of unexplained cardiac death, palpitations prior to the attack, syncope without prodromal symptoms, you need to put cardiac syncope up there as a priority. If the patient had a prolonged loss of consciousness for more than 5 minutes, he had a post-ictal or a post-attack confusion, motor activity prior to the transient loss of consciousness, and if it happened in the supine position, maybe seizure is the way to think. This is a very interesting review article that discusses the pearls and the pitfalls in history taking. I invite you to revise it. It's quite important to know what to think so as not to put a large burden on history taking without really knowing what to interpret. And they were talking that sometimes we see vasovagal syncope in the supine position, although it's not common. All mid-exertional syncope should be considered cardiac until proved otherwise. And if the patient is flaccid during the attack, this is probably not a seizure. They were stressing that the fact about urinary incontinence having no bearing in the differentiation between vasovagal syncope and epilepsy. However, the confusion is very important to rely on and strongly ask about. Physical examination, if a patient comes to you for the first time, you should listen properly to his heart. You need to properly, carefully perform a very full cardiac examination, looking for murmurs, particularly of the LVOT. Any dynamic murmurs would be appreciated. Properly measure the blood pressure during the sitting and the standing positions, the heart rate as well. Examine the patient properly for any signs of intoxication, injuries, pallor, dehydration. So just perform a good cardiac examination and make sure that clinically the patient is free. And of course, the ECG. Actually, an ECG should always be included in the initial evaluation of any child who suffered a syncope. And we, of course, will find many of the ECG findings not common to see. It's not a very high yield test, but it's cheap, it's inexpensive, and it should be a reliable test to exclude some of the very important causes of cardiac syncope. You can look for the lung QT, for the voltage criteria that would suggest LVH, and then you can ask for an echo. You can see manifestations of pre-excitation, WPW, ST elevation in the anterior precordial leads that would suggest a Brugada, any ectopies or manifestations of WPW, any bradycardias. So the ECG, despite being a low-yield test, it's still one of the most important investigations to be asked for in a patient with syncope. And studies have shown that if you perform a proper, detailed history, properly examine your patients, and then do the ECG, you will have a 96% sensitivity of not missing cardiac syncope. Of course, the interpretation of the ECG does have its challenges. Not everyone is going to be able to read it, but this is the guidelines. And as Professor Wael said in the morning, if you do not know, then refer and ask. I'm not going to go through the details of how to diagnose these. I'm sure you all know them because of the time. So this is our mindset in seeing a syncope. Is it cardiac? Is it a seizure? Is it psychogenic? Is it vasovagal syncope? And please remember the red flags. If you have a patient with a structural heart disease, a mid-exertional syncope while supine, if it's preceded by palpitations, a family history of sudden cardiac death, cardiomyopathy, or deafness, surgery for congenital heart disease, life or limb-threatening complications of syncope that would indicate that the patient did not have the time to protect himself during the fall. These are some of the common pitfalls that I've seen in my practice, and I'm sure you've all missed. These sometimes are really followed by catastrophes. So I would just like to, can I have just 1 minute, please? 1 minute. Sometimes we see patients who were misdiagnosed as a neurocardiogenic syncope because an ECG was not asked for. People forget to ask, that long QT does have a very variable presentations. You would see a child who's deaf with a completely normal QT, and his sister would have a very long QT. Do not forget to ask about deafness in syncope. Sometimes you're being pressured by patients. You know that this patient suffered a mid-exertion syncope. As Dr. Wael was saying a story, I have many similar stories of athletes who were not, and they were very resistant to stop practice and very resistant to go for the further step. So please try to resist the patient's reluctance to go further if you have a mid-exertional syncope. And do not overestimate the value of the head tilt test in a patient who has all the red flags. Sometimes you do have a positive head tilt test, the patient will be diagnosed as a vasovagal syncope, but still he has the red flags. Do not ignore them, because sometimes you have combinations of vasovagal syncope with other really serious problems. So my key take-home messages are, syncope is a very common problem in pediatrics. It is usually benign. History taking, physical examination, and ECG have the highest yield if they are properly interpreted. Please always look for the red flags, and let's raise awareness about syncope with general pediatricians in particular. And these are my references if anyone is interested in going back to them, and thank you very much.
Thank you, Professor Rania Hgazi, for your informative and updated presentation. Important topic between us and the neurology. You highlighted very important key points. I have the pleasure to introduce Professor Ahmed Taher, Assistant Professor of Critical Care, Cairo University, will present asymptomatic WBW to ablate or not.
Thank you very much for the introduction. Thank you for inviting me. I've been given the task of talking about the asymptomatic WBW, what to do to ablate or not. So can I have my slides up? Thank you. So yes, so WBW, as we all know, is a developmental annular defect that causes abnormal connection between the atria and the ventricle and manifests itself as in the ECG as short PR, delta wave, and YQRS complex. And we all know that it is a substrate for a multitude of arrhythmias, be it antidromic or orthodromic AVRT, and there's also an increased risk of atrial fibrillation associated with it, and it's been in the guidelines since 2019. It's +1 indication that whenever you have a symptomatic WBW, you are justified to go straight for ablation even without trying medical treatment. But the question comes with what to do when the patient has the ECG criteria of accessory pathway, the WBW, but without manifesting any symptoms. And I think we're now becoming to realize that the symptoms are not only palpitations, but they are now appreciated as substrate for dysynchrony and cardiomyopathy, accessory pathway, and this could be also contained within the definition of symptomatic WBW. But what if the patient doesn't have any of these? So on one side, we know we've been doing it for a long time. It's easy, it's successful, it's low risk, so why don't we ablate it in all patients? Obviously, it works for most of them, but there is a risk associated with ablation, and you don't know if your patient is willing, or at least you are justified to offer him this risk in case he doesn't manifest with any problem. And on the other end is, why not to wait until he becomes symptomatic in any form, and at that point offer him the procedure and do the ablation. The problem with waiting is this. Unfortunately, a portion, not big portion, but a significant, but a portion at least, of patients with WPW may present with pre-excited AF, which could lead to a potential life-threatening arrhythmia. So the question is, should we do something to tell which patient may develop these life-threatening arrhythmias who may benefit for ablation or not? And obviously, you need to calculate this balance. On one side, you need to know what is the risk of ablation, and on the other side, you need to see if the patient has risk features that put him in danger of life-threatening arrhythmia. Now, the risk of ventricular fibrillation is there with WBW, and we know that for many times. This is 1979, and it's been reported that ventricular fibrillation is associated in patients with pre-excitation. Now, interestingly, starting from that point in time, little by little signals started to come up in the literature about this situation in children. In this particular publication, the 15 patients who experienced ventricular fibrillation, they had previous arrhythmias. They were not absolutely asymptomatic. They had some sort of symptoms. But the 3 patients who did not experience any form of arrhythmia prior to ventricular fibrillation, they were all children. Yeah, and keep that in mind. We will come back to it later. Now, reports started to come after that in the following year about the risk of life-threatening or ventricular fibrillation in patients with asymptomatic. This is one of the early publications, 1968, about 128 males. 3 of them died, but none of these deaths were attributed to arrhythmias, and the authors were keen enough to see that one of the patients who died was in a plane crash, and he was in the pilot, so they didn't experience it. So yes, it was at a time very low risk, and reports start to come after that. Same message over and over again. Yes, there is a risk, but the risk is very low. And in this review of like 30 years work of asymptomatic WBW, no sudden cardiac death, and again, 4-year follow-up, 157 cases. No cases of sudden cardiac death. Now, bear in mind that most of these patient population is adults, okay? And actually, when they started to pull up the studies, whether in EP studies or epidemiological studies, again, the risk of sudden cardiac death on a variable period of follow-up that spanned up to 6.6, 7.5 is the longest, and up to 18 years or maybe 20 years in epidemiological studies, still very low. But now other signals start to appear in the literature. Again, is there a way to predict those people who get VF in WBW and asymptomatic WBW? Most of them who experience VF, they have previous atrial fibrillation, but now we are starting to pick up when we're trying to predict which patient. That reports that showed VF in this large registry, 15 patients who had VF and asymptomatic, 13 of them were children. So the pattern is recurring. And that warranted to look particularly about the risk in children. So we know that the risk is low in adult, but is it the same in children? And now they started to look in registries and long-term follow-up, and lo and behold, it is higher. In this publication, it's almost 1% in asymptomatic WBW children who experience life-threatening arrhythmia. Again, the intra-cath parameters or markers still the same, so we're still looking at the shortest pre-excited RR, the antegrade refractory period. The numbers and the cutoff points are the same, but the risk is higher in children. And a meta-analysis clearly separated the population into adult and children and identified at least twice the risk in children. The risk of developing ventricular arrhythmia and life-threatening conditions is almost, in this publication, twice the risk in adults, and this was also confirmed in multi-center study that among patients among children with asymptomatic WBW who experience a first arrhythmic event, 65% of these first arrhythmic events are life-threatening. And again, the predictors of these life-threatening conditions in this multi-center study were found to be male 6 Epstein anomalies, multiple and similar intracath markers like the adults. So we know that there is a risk of sudden cardiac death in those patients. We know that children in particular at higher risk than the other, and we may discuss the rationale behind it. But what is the risk of ablation? Again, the ablation of WBW is not new. It's been there for a long time, very low success rate, and one of the most recent registries from Spanish operators, they looked at the risk of major complication in WBW from 2009 to 2017, and it's almost stable. Now, regardless of our experience, regardless of how good we became with ablation of these accessory pathway, the risk is almost still the same. So what is the conclusion? What do we do? And I don't know if you've seen it, it's not very popular, but actually the European Heart Rhythm Association back in 2019 published 2 documents. One of them for the management of supraventricular tachycardia, but there was another consensus statement that was dedicated particularly to asymptomatic arrhythmia. And in this document, there was a section talking about asymptomatic WBW, and I think the recommendation in this document were a bit more bold than the recommendation in the statement for SVT. And I think they were ahead of their time as well, because it was clearly indicated that being young is a high risk for ventricular arrhythmia, and that was 2019. And they recommended invasive assessment over non-invasive assessment for characterizing or selecting patient with high-risk features. Again, the same thing applies to the cutoffs. And the third recommendation is not to rely on just the recommendation, and if you have intra-cath criteria of low risk, you need to administer isoprel or at least catecholamine, so that we know that many of accessory pathways are very sensitive to catecholamine. So a more recent expert opinion from the JAC actually highlighted all these findings since the last publications, and suggests an approach of non-invasive assessment of patient with asymptomatic WBW, be it an ECG that shows intermittent pre-excitation or a stress ECG that shows abrupt loss of pre-excitation. But take this with a grain of salt. I will show you why in a minute. And any patient with high-risk features, and in this publication we talked about the male sex, the multiple accessory pathway, participation in competitive sports, especially in children, and risk of sudden cardiac death in the family, and familial WBW. All these patients should undergo an invasive EP characterization with administration of isoprel to identify if these accessory pathway at risk or not. And going back, this is 2024, few months ago, publication about the utility and value of non-invasive assessment in patient with WBW. And in this, it was clear, although this was mentioned before in the guideline, it was the non-invasive assessment back in 2019 was class 2B, but it's clear now that even patients with features of low risk in non-invasive assessment by stress ECG, when you bring them to cath lab and study their accessory pathway invasively, some of them still exhibit high risk features. So despite that non-invasive testing was positive for low risk, the invasive testing said the opposite. And according to the author, the conclusion is that the specificity and sensitivity of non-invasive assessment of asymptomatic WBW is not that high, and you shouldn't rely on it solely. Thank you very much.
Thank you very much, Dr. Ahmed. شكرا جزيلا. Any questions? تفضل دكتور تامر.
This elegant presentation, as usual. I find it very awkward that I was thinking about what Kalapoponi did in back in 2003. I was at that time with my friends in Osama Wazni, and we were talking, how could a patient put 3 diagnostic or 2 diagnostic catheters with a definite CS in place, and you have to, you know, study the accessory pathway closely. So you have to diagnose where it is, not on the surface ECG, of course. So you have to be very crucial in, very critical in your assessment. And 2,000 patients, almost 2,000 patients, you enroll, and you just stand in front of the accessory pathway and you just don't push the pedal for ablation. This was really astonishing to me, and I don't know how they got the acceptance from the patient's family, even if there are financial issues for getting a $2,000 or $1,000 catheter, but it was very astonishing. So where is that from the ethical point of view?
Well,
ethical.
Now, when we
I mean, if
talk
your
about the
child-
complication, yes, when we talk about the complication of accessory pathway ablation, we know we do it frequently, we know we do it effectively, and the results are good, but it is not just heart block. I mean, any ablation carries a potential risk. It's a very small risk of other complications, be it precordial effusion, be it pulmonary emboli, be it vascular be it coronary affection from ablation deep on the system. But even if you are in theoretically safe place in terms of being far from the AV node, there is associated risk with the ablation. This is on one side. On the other side, I think and I believe that most of the pathways that we deem at low risk during invasive assessment, we reach this conclusion before giving isoprel. And most of those accessory pathways, if you give catecholamine stimulation, you will reach the cutoffs of high-risk patients. So it is essential, and there are many reports published and presented about cases that on initial evaluation, the shortest pre-excited or at least the accessory pathway effective refractory period were longer than 240, 250, and after the administration of isoprel, it went down to 220 or even less than that. So you have to be very careful if you bring the patient to cath lab about determining that this accessory is absolutely at low risk. And again, there is a shared decision at this point. I mean, there's a prior agreement or a prior discussion with the family that if the accessory pathway is in a relatively far or relatively safe place, okay, then we would go with it. Now, again, this discussion is based on this balance, and this balance is based with the current technology we have right now. And theoretically speaking, if you develop a safer and more efficient technology with very low risk, these complications will be lower, be less, and accordingly our ambition or our desire to ablate these special pathway will grow. So I think this is, yes, this discussion, accurate assessment, and maybe in the future things will change.
Okay, شكرا دكتور أحمد، شكرا جزيلا. تامر الوقت لو سمحت. طيب يعني
It's a balance event.
Thank you very much. شكرا دكتور أحمد. I would like to introduce the last speaker, Dr. Michael Sobhi. Dr. Michael Sobhi is a lecturer of critical care medicine and EHRA certified electrophysiologist at Critical Care Department, Cairo University, and El Qasim Hospital at United Arab Emirates. It's a recorded presentation. He will talk about the PVCs in children, when to ablate.
Good morning, dear professor and dear colleagues, and the honored chairman session of my sincere dear professors and dear colleagues. In the beginning, I'd like to thank the scientific committee of the first Egyptian Arrhythmia Pediatric Congress for inviting me to chair in the Congress agenda. And it's my utmost pleasure to chair and to contribute to all these great efforts that is done by my colleague in the Pediatric Arrhythmia unit in our beloved hospital, Qasr Al-Aini Abu Rish Pediatric Hospital. Actually, it has a special interest in my heart to see this unit growing up and providing international standard of care and service for pediatric arrhythmia patients, guided and led by my professors and my colleagues, Professor Dr. Wael Lotfi and Professor Dr. Tamer Fahmi, and my colleague Dr. Osama Abdelaziz and Dr. Rudaina, and of course my sincere brothers and colleague Dr. Ahmed Tahir, Dr. Ahmed Mustafa, and the whole EP team and professor at the critical care department. My congratulations for the work, for the Congress, for the success, and wish all the success usually for the unit and for all the service of our pediatric arrhythmia patient. Well, when we talk about the topic of PVCs in pediatric patients, this is a common scenario. It's a daily encounter, everyday practice. However, the management approach still carry dilemma, and there are different options about how to manage a patient pediatric who has PVCs. Over the next few slides, we are going to try to focus the light on what is the current evidence we have so far for the management of PVCs in pediatric population, and what is the best practice and what are the standard approaches that's available for management this specific age population, pediatric patient who have PVCs or ventricular arrhythmia in general. Well, on my agenda over the next few slides will include what is the epidemiology of the PVCs in the pediatric population. Is it common or no? What is the pathogenesis of PVCs in the pediatric population? Is it correctable? Is it inheritable? Is it a family factor or no? How we are going to evaluate the patient, pediatric who has a PVC? What is the diagnostic workup you will do for him? And finally will be how we are going to manage the patient, what is the management options, and whether you are going to conserve or observe, or you will proceed for ablation. And if you proceed for ablation, are there special tips or pitfalls that you should take care during the catheter ablation of this patient or no? Well, the first thing is the epidemiology of the PVCs, and of course PVCs are relatively common in the age population, the pediatric patient. However, when we talk about sustained VT or non-sustained VT, it's not that common. It's a rare entity in the pediatric population. In a large school-based study that was done in Japanese child school, it was found that the incidence of non-sustained VT or sustained VT was very rare. It reached to be between 0.2 to 0.8 every 10,000 child. Is the incidence of PVCs in the pediatric related to age? Yes, the answer is yes. We find variation in the incidence among the different age group of pediatric. In the neonates, it's very common. It found 20% of the neonate will have some form of PVCs. However, once age of the neonate grow up, and this decrease to reach 10% in the toddlers and the school age children, and then by the passage of the first decade of life, it starts to increase again to reach 20 to 30% of the normal adolescents. Is the incidence of PVCs related to the presence of underlying structural heart disease? Yes, the answer is yes. The more the presence of structural heart disease, the more presence of fibrosis or scar tissue, the more the incidence of PVCs, as we see in the congenital heart disease like Fallot or in post-operative scar related. Is there is a relation about the epidemiology of the PVCs with the gender? This area is controversial, although some data may suggest a prevalence or preference for the incidence of PVC among male as well as to female. And on the other hand, for the RVOT PVCs in girls, we can find variation in the incidence of PVCs related to the hormonal changes during the different phases of the menstrual cycle. Whether race and ethnicity affect the epidemiology of PVCs, this has not been reported in pediatric yet. However, studies from the adults show some relation of the epidemiology of PVCs in relation to gender and race and ethnicity. When we talk about the pathogenesis of PVCs in the pediatric population, it's important to know, of course, the pathogenesis in order to determine the different management approach. From the cellular level, like any arrhythmias, there are three mechanisms for the PVCs. It could be due to increased automaticity, more extent it could be due to triggered activity, and lesser extent it could be due to entry. Increased automaticity, we see it if there is injury in myocardium. This could explain the PVCs that can be seen in the left ventricular non-compaction. Triggered activity contributes the majority of the original PVCs mechanism, especially the delayed after depolarization, which is responsible mainly for the out-of-flow tract PVCs, and also can be seen in the catechol-menergic polymorphic ventricular tachycardia. And early after depolarization, triggered activity can explain long QT related PVCs, whether congenital or acquired. Re-entry can happen if there is underlying scar or fibrosis, as in cases of myocarditis or post-surgical repair. It's of course there is association for the pathogenesis of PVCs in the pediatric in genetic predisposition, and it can run some familial factor, especially if there is mutation in the genes that is encoding for ion channels like sodium, potassium, or calcium channels, or mutation in the genes that respond encoding for structural like proteins, as in case of arrhythmogenic right ventricular cardiomyopathy. How you are going to evaluate a patient pediatric has a PVC? What is the diagnostic workup that you are going to do to it? Actually, there's a big spectrum, including non-invasive, modalities and non-invasive diagnostic workup, or to go to invasive maneuvers like an EP study and catheter ablation if needed. Actually, many studies and many reviews, articles, as well as expert consensus statement try to put a framework for about how to proceed or how to go for workup and diagnostic evaluation of pediatric patients who have PVCs. And the main core of most of the consensuses is that there is 5 important considerations to be in order to proceed. First of all, you want to know what is the symptoms. Is it symptomatic or no? What is the frequency and the PVC burden? And where is the origin of these PVCs coming from? Is there any complex form of the PVCs like couplet, triplet, polymorphic? Is it associated with structural heart disease or no? These are the 5 main considerations that you need to answer in order to determine the management plan of the patient. So, to evaluate a child with a PVC, the step 1 will include initial routine workups that you do in most of the pediatric PVC patients, which include history taking, as well as 12-lead ECG, echocardiography, and long-term monitoring Holter or telemetry. History examination, of course, will include what is the symptom of the patient, and you will find yourself either you are dealing with asymptomatic pediatric patient in which the PVCs has been discovered incidental finding, or the patient have symptoms. For those who are asymptomatic as an incidental finding, this is common, and these patients usually need frequent monitoring because if they have a high burden of PVCs, these patients may suffer from declined cardiac function, though this is a rare possibility. Different cutoff values has been proposed to say whether the patient is at high risk for LV dysfunction related to the PVCs or not. The most common accepted value is 10%, although higher value is usually required in order to have this possibility of PVCs-induced cardiomyopathy. For those patients who have symptoms, pediatric patients, this could be a range of palpitation or near syncope, which is the most common complaint of this patient. Syncope actually is uncommon in the pediatric population, and if you have a pediatric patient with PVC who have syncope, you should raise the suspicion whether it is an alternative diagnosis, is it associated cardiomyopathy that is causing the patient syncope or no. Of course, it's very important and crucial to take a detailed family history in order to exclude underlying channelopathies in these patients. The second routine workup is 12-lead ECG, and it's mainly to determine what is the site or origin or focus of the PVCs, whether it's the most common, which is outflow tract representing 90% of the PVC's origin, or other rare sites of origin. The third workup routine is the echocardiography, of course, to evaluate the cardiac chambers, valves, and exclude underlying structural heart disease and evaluation of the cardiac contractility. Fourth is the Holter telemetry or long-term monitoring in a trial to estimate what is the burden of the PVCs of the patient. Is there evidence of any high-risk form of PVCs like complex PVCs, bigymny, multiform, or triplets? Or is there association of the PVCs with exercise or certain times in the day? In those patients who have high burden of PVCs, more than 10%, or complex form of PVCs, these patients you can escalate the level of workup for higher or more advanced workup, including exercise testing, speckle tracking, or cardiac MRI, and genetic testing. Exercise testing is crucial in order to evaluate whether the child can go for physical sport practice or no. The most common form, which is outflow tract PVCs, is usually characterized by having more frequent PVCs during rest or during recovery from exercise, and usually these patient PVC suppress what's going on for exercise. On the other hand, if you find that the patient has exercise-induced PVCs, you should suspect underlying serious condition like catechomenergic polymorphic ventricular tachycardia. Speckle tracking cardiac MRI is useful in this patient to exclude underlying structural heart disease or infiltrative heart disease, and especially if you are suspecting ARVC. Genetic testing, of course, is of crucial importance in some patients in whom you are suspecting channelopathy in order to elucidate whether the patient have underlying serious arrhythmias or no. To manage a patient, pediatric patient who has a PVCs, there are different options of management of this patient, and the spectrum actually is big. It includes either you go for conservative management or use antiarrhythmic pharmacotherapy, or you proceed for invasive intervention EP and catheter ablation. The main factors that determine which line of approach you are going to proceed is what is the arrhythmic risk of the patient, what is the symptomatology of the patient, and whether the patient have a potential for hemodynamic compromise from the underlying PVCs or no. And it's very important and very beneficial is to know the natural history of the PVCs in order to determine the optimum line of management. For the most common type, which is RVOT PVCs in children who have normal structural heart, this type of PVCs is usually benign in its course and have a good long-term prognosis. Actually, spontaneous remission may occur in 5 to 65% of the patient. In a large study that was done on 135 child with structural normal heart and high PVCs burden more than 10% that were followed up for a period of 3 years, they concluded that the patient who had these criteria had PVCs that's coming in structural normal heart, they associated with a relatively benign course trend towards spontaneous resolution. This spontaneous resolution will depend upon what is the age in which the disease has presented. The more the younger, the more the infancy, the more likely to have spontaneous resolution of the PVCs. On the other hand, for those patients who has complex forms of PVCs like bigymny, polymorphic couplets, or non-sustained VT, these patients are at increased risk, of course, of serious adverse events, and these patients need careful observation in which you may elucidate that the patient have underlying cardiomyopathy or channelopathy, especially if they have bidirectional PVCs or tachycardia. In a trial that was done by the Italian group in order to try to find what are the red flags for the PVCs in patients who have cardiomyopathy, they found that benign PVCs could be anticipated in the patient who have negative family history, if they are not symptomatic or have mild symptoms, and if they are monomorphic in their morphology, and if these PVCs are characterized by suppression by exercise. And the opposite, of course, will indicate that this is a malignant form of PVCs. For this patient in whom decision is taken for invasive electrophysiology study and catheter ablation, it worth mentioning that catheter ablation has demonstrated over the past years increasing in the efficacy and safety. However, still data are scarce for catheter ablation in this age population, and accordingly many of the recommendation and data depend on extrapolation from the adult literature. According to the expert consensus statement for the management of ventricular arrhythmias in pediatric patients, catheter ablation is a class 1 indication for those pediatric patients who are associated with the PVC's LV dysfunction. Another form has class 1 indication with those patients who have verapamil sensitive PVCs. Class 2 indication is given for symptomatic PVCs refractory to pharmacological agent, as well as for patients who have polymorphic PVCs. Class 3 contraindication for catheter ablation is for very young infant and toddler unless it is associated with extreme hemodynamic instability, asymptomatic patient, as well as those patients who have transient reversible factor causing the PVCs, like in case of myocarditis or drug toxicity or electrolyte imbalance. Regarding catheter ablation PVCs, it's very important, of course, to determine what is the site of origin of the PVCs. Most commonly, PVCs come from the outflow tract region. This is contribute to 90%, and among this 90%, the outflow tract, 70% coming from the right ventricular outflow tract, and the remaining coming from the other side. As we know, it's very important to localize the PVCs using the ECG usually to know where it's coming from the outflow tract, whether it's coming from the right ventricular outflow tract or the left ventricular outflow tract. This mainly depends on the ECG criteria. Outflow tract PVC is characterized by having left multi-branch morphology and inferior axis. Then you are going to look at the transition. If you have a late transition, this suggests right ventricular outflow tract origin. Early transition suggests left ventricular outflow tract origin. So for those patients who have late transition beyond V4, right ventricular outflow tract origin is suspected. And among the RVUT, you can further determine through ECG criteria whether it's septal or lateral origin, whether it's cranial, caudal, or anterior septal origin. In a large initial American studies that were done on these patients who have RVUT PVCs, it was found that the success rate for catheter ablation is high in this patient population, approaching 90 to 95%, with a very low rate complication reaching 1%. For those patients who have early transition, less than V2, these patients will suspect left ventricular outflow tract origin PVCs. And some special tips when you do ablation from the LVUT is that here it's a little bit be cautiously. You have to avoid collateral injury. You have to localize where is the coronary artery. You depend on local activation mapping, and pace mapping is less beneficial. Avoid the catheter dislodgement through use of intracardiac echo, continuous fluoroscopy or 3D mapping system. Usually power setting is set around 30 watt. And avoid unnecessary application because PVCs from the outflow tract are characterized by early resolution. So if you deliver the energy and prolong PVCs beyond 10 seconds, usually you have to change the site. This is not a successful application. For those patients who show intermediate transition of the PVC at the area of V3, this is equivocal. It could be either coming from the RVUT or LVUT. And in a nice paper that has been published by the Marshniski group, which is the V2 transition ratio, criteria that can help differentiate whether it's RVUT or LVUT depend on the RS transition. If it's later than the sinus rhythm, this suggests RVUT, and if it is earlier than the sinus rhythm, then you will measure the V2 transition ratio, whether it's less than 0.6, pointing toward RVUT, or more than 0.6, suggesting LVUT origin of PVCs. A rare entity of outflow tract PVCs is the pulmonary artery PVCs. However, it's challenging in ablation. You can suspect it if you have pathological Q in limb lead 1, and if you have a deeper Q wave in AVL as opposed to OVR, and prominent R wave in the inferior leads. Some studies have tried to put criteria for predicting malignant RVUT PVCs, and one of the studies has put a cutoff value low as 245 to suspect malignant form of PVCs from the right ventricular outflow tract. In conclusion, for catheter ablation of PVCs from the right ventricular outflow tract and left ventricular outflow tract, surface ECG localization very important for pre-procedure planning and determining your approach and access. You must have profound knowledge of what is adjacent anatomy to avoid any collateral injury. You have to put in your mind that there may be potential unusual location, and you may need to go to map in the aortic sinus and the pulmonary sinus cusp. The other group of PVCs, which is less common, can come from different sites. We will go rapidly through them. For PVCs that's coming from the papillary muscle, usually characterized by right bundle branch morphology and transition between V3 to V5, and it could be either superior or inferior axis depending if it's coming from the anterolateral or the posteromedial papillary muscle. Papillary muscle PVCs are characterized by being refractory to verapamil and sodium channel blocker, and it's usually non-inducible by pace mapping or pacing. It's inducible more by isoprenolone or exertion, and it's usually of PVCs in nature rather than sustained VT. And you do local activation time map, you find that the earliest origin is coming from the papillary muscle. Pacing ablation of the papillary muscle ventricular arrhythmia is challenging, and some tips that can help is to use intracardiac echo guidance, because it will help you to assess stability of the catheter in good contact with the papillary muscle, and also you will assess the size and the location of the catheter in the papillary muscle. Access, you can alternate between transeptal and retrograde approach. The site that's the most usual for the origin of PVCs if the papillary muscle is mainly in the tip. In a study that was done on 35 patients with papillary muscle PVCs, in 67% the site of successful ablation was located at the tip of the papillary muscle. Regarding the energy sources, cryo versus radio frequency, in a trial that was done on 20 patients with papillary muscle PVCs, it was found that the cryo energy resulted in 100% success as opposed to 78% for RF. However, in an updated series with a larger number of patients, it was found that contact force guided RF resulted in the same success rate as that of the cryo-energy. A special entity is that the papillary muscle can be a source of PVCs that lead to ventricular fibrillation, and in these rare cases, catheter ablation of PVCs triggering VF will result in long-term freedom of VF. So, to conclude, ablation of PVCs or ventricular arrhythmia from the papillary muscle is challenging. Intracardiac echo proved to be very helpful. Cryo-energy may be better than the radiofrequency energy in such cases, and papillary muscle could be origin in rare cases of malignant form PVCs and ventricular fibrillation. Another site of origin of PVCs is the verapamil sensitive PVCs, and it's characterized by right band branch morphology that is induced by atrial stimulation without structural heart disease, and of course verapamil sensitive. This type of arrhythmia is more common in Poland.
Sorry for interruption. Let's close the lecture because we are very short of time. He should conclude earlier than that. Thank you very much, Dr. Michael Sobhi, and let's close the session and go for coffee break. Thank you very much.
Dr. Peter, did you have a comment or a question? Are you sure? Okay. Thank you very much. We close the session and we move on to the coffee break. See you after the coffee break. Thank you very much.
معايا محمود.
انت كنت فين؟ انت مش قلت لنا نازل للرئيس؟
محمود.
طب الحق نفسك.
محمود.
عدينا في التوقيت طبعا. عدينا في التوقيت. الكوفي بريك اللي شغال ده المفروض يخلص الساعة 12.
في اخر ساعه. ساعه. صح؟
نزل صح؟
ايه؟ صح طبعا. طب بقول لك بيقول لك شوف في الشنطه بتاعتك.
مش في الشنطة والله. أنا مفضي الشنطة هناك في السكن. مفضيها كده. تعال اقعد مكانك عشان تنور.
طب بسرعه عشان عايز افتح. طب وريني الدنيا ولا
لا
ايه؟
خش روح الكوفي بريك تعالى.
انا كنت عايز بطاريه صح؟
غيرت.
غيرتها؟ فينه؟
خدته له تاني. هو ده تقريبا.
حطيته يعني دي بقى كنت بتشتغلها ليه؟
شغالها من عنده هو، انا ماليش دعوه بيه.
عاملين ايه مع حضرتك برضه؟ وبعدين ما مش على حد منهم احمد مبروك كتير بس هو واضح من الشركات عرفوا حد ما تسمعش عن حد ويقول لك الشركه ممتازه هم اقلوا معاك وهتعرفي اكتر من الحساب هم الناس هم دي كلهم
عشان
مش فاهم اي حاجه مسكتها
مفيش حاجه غريبه. اقعد بس كده.
هو اللي بيعمل شغل
مش على الديسك. ثلاثة على 4 و16 على 9.
بس اول صف يبعد بس عشان لازم
مش فاهم
اطلع بس. ايوه كده بس
انت هتجيب الصف ده كده؟
اه هو الصف العادي يطلع كده شويه.
طيب لو سمحت بس ممكن نجيبها على الشاشة بقى اللي هو السيشن 3. اللي هم بتاع سيشن 3.
شادي نخلة، دكتور شادي نخلة.
طب خلاص
بص يا
ننوع
بص
بقى على بره.
السيشن زي
طب والسيشن 4 موجوده برضه؟
السيشن 4
ايه المغاوري ناقص؟ طب فين
دكتور المغاوري بره اهي، انا فاتحها له عشان هو اداها لنا في الاخر جاهزه. تمام كده؟
يبقى نبدا شادي.
شادي انا برضه فاتحها اهي.
طب عاوزين
هقول للهوا واحد.
مش عامل انت صورة.
يلا طيب.
Okay. I call for session 3. Chairpersons, please come forward.
ناصر طه
اطمن على حاجه بس اشوف حاجه كده.
هو متهيألي ناصر طلع معايا.
ناصر طلع معاه من زمان. اللي انت فاتحها دي دلوقتي.
انا بس كنت عايزه اقول لحضرتك لو الافيليشن بتاع اللي هم الانترناشونال سبيكرز مكتوب هنا لو فاكر.
هو شادي
نخلة هو بروفيسور كارديولوجي الكتروفيسيولوجي في كليفلاند. هم الافيليشن بتاعهم واقف في الصفحه اللي ورا اللي عند السير.
بس هو التانيين اللي هم مثلا حسام
انا هقدم محمد المغاوي ده معايا في المعهد.
طيب انا هقدم شادي
وحضرتك تقدم شادي اهو.
انا رحت المنيا من حوالي 10 15 سنه. لا ده فرق. كنت انا مشرف على رساله واحد بيشتغل الكتروفيسيولوجي اتعلم في ايطاليا مع كارلو بابوري. فرحت انا
محمد الشادي موجود والدكتور محمد المغاوي موجود.
Good afternoon, everybody. Please pay some attention. We will be starting this afternoon session in this conference about pediatric electrophysiology. The first speaker will be Professor Shadi Nakhla, Professor of Cardiac Electrophysiology in Cleveland Clinic, and he will be addressing an important issue about left bundle branch basing. تفضل يا دكتور شادي.
Thank you so much for the opportunity and the invitation to present today. So I've been tasked with the responsibility to discuss the role of conduction system pacing, specifically left bundle branch area pacing in EP. And so I want to spend the first half of the discussion today reviewing some technical aspects of the procedure, and then the second half of the discussion reviewing some of the literature and data that we have to support using this technique. Okay? And so I'll start with a case. This is a 31-year-old patient with a history of congenital AV block. He developed a pacer-induced cardiomyopathy due to right ventricular apical pacing. He had a prior infected epicardial system, and someone attempted to add a CS lead but was not successful. And so he presented in consultation. On the ECG, you can see clear evidence of RV apical pacing, QS across the whole precordium, and then a very superior directed axis. And on the echocardiogram, you can see sort of this apical wall motion abnormality that we commonly see in patients with pacing-induced cardiomyopathy. This was the EKG after the procedure, and here you can see the paced morphology has a right bundle branch block, a QR pattern in lead V1 and V2, S waves in V5 and V6, a superior directed axis in the inferior leads, most suggestive of the fact that we're capturing the left posterior fascicle with this pacing lead. And when you look at the echocardiogram, you can see that that apical wall motion abnormality has completely resolved and the EF totally normalized. And the LAO projection, this is what a sheath venogram looks like. The catheter up top is a catheter at the His position. This lead is in the apex, and this is kind of in the mid-septum. And in the LAO projection, it's pointing towards the left ventricle across the septum. And you can see that from the lead tip all the way to the beginning of the ring is embedded within the septum. This is what it looks like on a CT scan. And on a different patient, this is what the X-ray looks like. In the AP projection, it's hard to differentiate where these ventricular leads are oriented. However, on the lateral film, this middle lead here is the one that is in the left bundle branch area position, and you can see that the orientation of the lead is very posteriorly directed. This is 90 degrees LAO, it's a lateral film. And that's the orientation of most successful implants. They have to be very posteriorly directed across the septum to be able to capture the conduction system. And so really there are three main keys to a successful implant. One is you actually have a conduction system that's available for capture. The other is some certain technical hygiene aspects. But then the most important, and what I want to spend most of our time today on, is actually confirming capture. So if you think about a traditional CRT implant, and you look at an X-ray and you see that there's a lead in the posterior wall of the left ventricle, a lead in the RV, and a lead in the RA, no matter what, you know that you have a successful implant because you're sandwiching the left ventricle between the RV and the lateral wall. But with conduction system pacing, you really need to be very certain of your electrophysiologic result, what your paced QRS looks like at the end of your procedure before you close the pocket and leave. And that's a little bit more challenging. So in brief review, on the left panel is an RAO projection from the RV looking at the septum of what the conduction system looks like. Here you have the triangle of Koch. This is the septal boundary of it, and this is the tendon of Todaro between the apex of the triangle of Koch and the CS os. This is where the membranous septum lies, and this is where the conduction system penetrates. In the LAO and the left posterior oblique projection from the left side looking towards the septum, this is where the membranous septum is. This is where the distal His starts branching into the left-sided bundle with the anterior and septal fascicles and the posterior fascicle going down this way. When we take that RAO view of the right ventricle and superimpose it upon an RAO fluoroscopy image, this is what it looks like. Here's a catheter at the His position. The septal fascicles move in this direction, and the posterior fascicles move in this direction. And generally speaking, we're targeting the proximal left bundle or one of the fascicles when we're targeting someone for implant. So over the next few slides, what I would like to do is go through certain technical considerations where we adjudicate and ascertain that we have conduction system capture. And so the definition of left bundle branch area capture, number one, is that we have a paced QRS morphology that either has an RSR prime or a QR pattern in lead V1. The presence perhaps of a left bundle branch recording, a fascicular potential on intercardiacs. One of the most important features that we see in patients where we actually have confirmed capture is a time from the pacing stimulus to the peak in V5 and V6. That's the LV activation time. That's somewhere in the neighborhood of 65 to 85 milliseconds. There are certain pacing maneuvers that we can use to determine whether or not we have selective or non-selective left bundle branch capture. And again, with recordings at the His position and the proximal left bundle from the left ventricular side, we can see evidence for direct left bundle capture. An important note is usually in most cases, you can only get 2 or 3 of these different criteria as opposed to all of them. And so you're really looking very carefully to see if you can get at least 2 or 3 of these criteria to ascertain whether or not you have selective capture. Most importantly, having a right bundle or a QR morphology in lead V1. I use that as one of the most convincing pieces of evidence. So when we select an initial position, what we see here is in the REO projection, the left bundle lead is slightly distal to the His region. And the paste morphology, even before you screw the lead in, looks something like this. In lead V1, you have this W pattern, and in lead V6, you have an R pattern with a very late peak in V5 and V6, roughly 120, 130 milliseconds away from the pacing stimulus. And once you achieve a morphology like this while you're just mapping the septum, what you would usually do is then serially screw in the lead across the septum until you're able to capture the conduction system. An important question that we ask ourselves is how much do you spin the lead? How much do you advance the lead across the septum before you stop? And really there are several key important findings. One is to pause periodically every few turns to check what your paced morphology looks like, to see what your impedance looks like. Usually we see an impedance that rises as you start getting towards the mid-septum, and then it starts to fall as you start approaching the left ventricular subendocardium. And so a drop of about 100 to 200 ohms is a sign for you to perhaps pause and confirm that you have capture or not. Oftentimes, when you're able to achieve conduction system capture, you'll see a spontaneous right bundle branch block morphology PVC once the tip of the lead just irritates the conduction system slightly. So this is a patient that I implanted not too long ago, and this was with a system where you could continually pace from the lead as you're advancing the lead across the septum. You can see that on the far left, this is the morphology that we had started with, where you have a W in lead V1, and several important changes in the morphology occur as we're advancing the lead across the septum. And so if you look here, we have that W pattern. Right over here, the positive deflection in the paced QRS starts to go towards the terminal portion of the QRS. Here you think that we have a nice QR pattern, but there's a very, very small S wave just before the isoelectric period. This is immediately followed by a spontaneous conduction system PVC. This is not a paced beat. And ultimately, this is the morphology that we ended with. So again, this highlights the paced, the spontaneous PVC that happens as the lead just touches the conduction system. And this compares the very initial QRS that we started with and the very terminal QRS. And so here you have a W pattern in lead V1, and here you have a QR pattern. There's a very dramatic shortening in the lateral activation time of the left ventricle. The stimulus to the peak in lead V6 changes from 120 all the way down to 80 milliseconds. Oftentimes during this procedure, we can see very sharp pre-myocardial EGM, very sharp Purkinje potential looking signals. Again, this is another suggestion that we have capture. And during threshold testing, oftentimes you see the local myocardial EGM splitting out from the stimulus, and this suggests that you're actually just capturing the fascicular potential itself and not the fascicular potential and the local myocardial signal. In the interest of time, we'll skip the next few slides and really start to ask ourselves the question, okay, you're able to implant a lead that captures the left bundle branch network. There are a few questions that remain. How feasible is this procedure in the real world? Does capturing the conduction system actually provide adequate cardiac resynchronization therapy in patients with dysynchrony and LV dysfunction? How does this compare to conventional cardiac resynchronization therapy? And is there a role in congenital heart disease? So this was the very initial report of a multi-center experience using left bundle branch area pacing. And it looked at 305 patients out of 341 who were actually successful at the implant. And so an implant success rate of around 90%. This patient population, the majority had LV dysfunction with an EF less than 50%, and a very small minority had left bundle branch block morphology. And in an overwhelming majority of these patients, we were able to achieve a right bundle branch block morphology in lead V1, and we had very clear evidence of shortening of the lateral LV wall activation time down to 70 milliseconds. And as you can see in the bottom panel here, the stability of the electrical parameters on the lead were really, really quite excellent all the way up to 12 months of follow-up. And so clearly implanting these leads is a feasible expedition, but the question remains, does left bundle branch area pacing provide adequate CRT? So this was a prospective study, single arm, multi-center, where they looked at patients who had indications for cardiac resynchronization therapy, and they implanted left bundle branch area pacing leads. And so at baseline, the mean intrinsic QRS was 168 milliseconds. The overwhelming majority of the population had New York Heart Association class 3 symptoms, and the average ejection fraction was 33%. So this is really a true left bundle branch block mediated cardiomyopathy cohort. And what we see here is in follow-up, we see significant improvement in LV ejection fraction over time. We also see that the majority of patients develop at least an LV ejection fraction improvement by 10% or greater. And with that, we see significant reduction in LV end systolic volume. So far we've demonstrated that it's feasible. It actually does provide adequate CRT, but how does it compare to traditional cardiac resynchronization therapy? And so this was an observational retrospective study that looked at patients who received left bundle branch area pacing leads versus those a historical control that received traditional cardiac resynchronization therapy. And what this showed is that as a primary endpoint of a composite of death or heart failure hospitalization, patients who received left bundle branch area pacing leads did better. Okay? And this was primarily driven by a reduction in heart failure hospitalization as compared to CRT. And so the extrapolation of what we receive from this data is that the time to EF improvement in patients with cardiac with conduction system pacing appears to be shorter than patients with epicardial bi-V pacing. A few studies have demonstrated a similar signal. It takes a little bit less time to normalize your EF as compared to traditional conduction cardiac resynchronization therapy. Now, up until recently, there wasn't much data in congenital heart disease or pediatrics, and still there isn't a lot of data that informs us who and when within the pediatric population we should implant these leads in. But there was a nice report here that looks at conduction system patients in patients with congenital heart disease. The majority of patients in this study are those who had tetralogy of Fallot that was repaired, or septal defects of a variety of sources. The overwhelming majority of pacing indications was AV block, sometimes post-surgery and sometimes just congenital. And what this demonstrated is that patients with left bundle branch area pacing, as compared to conventional CRT, had far more superior narrowing of their QRS that didn't necessarily correlate with any significant change in ejection fraction compared to traditional CRT. And so the take-home message from this study is conduction system pacing in congenital heart disease is also an option, but it didn't seem in this very small study to demonstrate much superiority, at least in ejection fraction recovery, as compared to cardiac resynchronization therapy that was traditional. And so in summary, the take-home here is that left bundle branch area pacing is feasible, safe, and effective. There are certain very important parameters that confirm whether or not you have capture, and that's one of probably the most important technical skills to learn with this procedure. It's important to consider this technique in patients with left bundle branch block, pacing-induced cardiomyopathy, even those with normal QRS and normal EF, and patients with congenital AV block. And it's important to take pause and not jump to implant left bundle branch area pacing in patients with infiltrative cardiomyopathies like sarcoidosis, patients with septal scar, ischemic patients, certain congenital heart disease patients, and then patients that have a combination of conduction disease and intramyocardial delay due to fibrosis. And again, in pediatric patients, there's been very limited case series that have described single center outcomes, and we're enrolling in a multinational clinical trial that compares left bundle branch area pacing to traditional CRT, the results of which are still pending. Thank you for your attention.
Thank you very much for this informative talk. Any questions from the floor? Please.
Please, yeah. Thank you.
اديله ميكروفون لو سمحت.
Because we are apparently moving in that direction in a way or another.
Yeah. So your question was, you demonstrated evidence that compares left bundle branch area pacing to CRT, but is there any evidence that compares it to traditional pacing in pediatrics? So specifically in pediatrics, no. So there aren't a lot of case series. But if we extrapolate from the adult experience, so in Cleveland, we looked at our patients who developed complete heart block after open heart surgery. So patients who underwent aortic and mitral valve surgery and developed complete heart block and were pacer dependent. And we found that in patients who continued to have a pacing indication and a pacing burden greater than 40%, they had about a 20% chance of needing an upgrade to CRT within the first couple of years after pacing implant. And so I think just extrapolating from that data, it tells us that your risk of needing an upgrade to CRT after RV apical pacing in an adult population is about 20%, let alone a pediatric patient that has many more decades and chance to develop dysynchrony. So we really use the adult data to make those decisions. Thank you. That's a great question. Yeah. Yeah.
I always love this talk. I learn a lot every time you give it. I was wondering if you know of extraction data, and do you think that's going to be different for the very young pediatric patient? Should we be perhaps a little bit more judicious about implanting these leads?
Yeah. That's a great question. So when we initially started implanting these leads, there was a lot of concern about extraction. One, because you have about sometimes on average a centimeter of lead that's embedded within the septum, but then also because the lead that's implanted for most part is the Medtronic 3830, which is lumenless. And so it's difficult to insert locking stylets in it for extraction. But over the past few years, there's been a lot of techniques to be able to improve the rail and support during extraction for these patients. And we've had a handful of experiences that have gone really, really well. And so there's a technique where you kind of modify the insulation at the at the proximal end of the lead to be able to hold on to it with constriction knots. And that gives you plenty of support to be able to get sheaths over it for extraction. And I think that we just haven't been doing this long enough to really understand what the long-term consequences will be. But I suspect that we're going to end up perhaps leaving some amount of lead remnant within the septum and just cutting the lead at the tip and then leaving the screw within the septum. Thank you. Dr. Tim. Oh, sorry. Yeah.
Elegant presentation as usual. But is there any data regarding the possibility of leadless pacing, especially in pediatric population, with left bundle area pacing?
So specifically leadless, I think Dr. Maghauri is going to talk about leadless in general, but as far as leadless conduction system pacing, I think that Abbott, St. Jude, and Medtronic both have prototypes that they're trying out still in animal models to attempt conduction system pacing. So it ends up being a leadless device with a very long screw that allows you to bury in, but a lot of that is still in preclinical work. Yeah. Yeah, you asked me the same question last year. That's a great question. I think that the benefit of using the 3830 is that that's been the lead of choice in the US, at least, Peter, for pediatric patients for a very long time. And so what we've seen about it is that the lead has demonstrated excellent stability in non-bundle lead positions, at least as far as the lead bulk and the slack within the right atrium. And so I suspect that the stability should be the same. What we don't know, obviously, is not just the patients getting taller, but if their septum grows in thickness over time, will the lead still capture the conduction system? And we really don't have answers to those questions. It's a great question. I don't have an answer to it. Yeah. Thank you.
Thank you very much, Dr. Shadi. And now we will move to the next speaker.
Next speaker will be Dr. Mohammed Al-Maghauri, consultant of cardiology and electrophysiology in National Heart Institute and Al-Nas Hospital. Dr. Mohammed will speak about the role of leadless pacemaker in pediatrics and what its future will be.
Good afternoon, everyone. My name is Mohammed Al-Maghauri. I'm a consultant electrophysiologist at National Heart Institute and Al-Nas Hospital. Thank you very much for inviting me. I'll try to be brief and hopefully fun. It's 15 minutes. I thought it's 20 minutes. Okay, then I'll be extra brief. So the story with pacing actually starts from the pediatric cardiology department, not from the other cardiology department, and that's with the early work of Dr. Walton Lillehei, who is a pediatric cardiac surgeon. And that's back in Minnesota, where he first implanted a device to a child. However, that needed to be plugged in. And then, unfortunately, كان في تخفيف أحمال في أمريكا من 70 سنة. So the power shut off, and unfortunately, the child died. So the next day, the very next day, he called someone called Earl Becken and told him, okay, you have a startup company, something called Medtronic, maybe come and check what's happening. So that's Earl Becken, and that's the first Medtronic headquarters, by the way. That was back in 1947 to 1957. It was a garage shop. And at that time, their annual revenue was about $40, about a monthly revenue of $6. MashaAllah, مش هنحسدهم. This is the fiscal year results of last year comparison to this year. It's about $7 billion. Half of them go to Alfie. So Becken had a very interesting motto, which is ready, fire, and then aim. So he did a prototype, tested on a dog, and then the next day, actually, Lillehei inserted it into a child straight away. And that worked. It was an external pacemaker. And then 2 years later, there was the internal pacemaker, as we all know, in 1958 with a Swedish group of Elmqvist, who was the engineer, but he actually is a doctor turned engineer. And Senning, everyone knows Senning, he was the implanter, he was the surgeon. And Arne Larsen, who was the patient. Interestingly, the wife of Larsen is the one who did the consent, maybe for different reasons. So he did not consent for the pacemaker, his wife did. But anyway, it was, what's interesting is that the engineer died in 1996, the surgeon died in 2000, and the patient died in 2001 from cancer stomach. Has nothing to do with the heart. And what they used for the first prototype of the implantable pacemaker was a kiwi shoe polish container that turned to be inert, biologically inert. And so we've gone a long way from that to our leadless pacemaker. So pacing in children is quite peculiar and different to adult cardiology. I'm an adult cardiologist, so whenever I look at to a child and I'm trying to comprehend what should I do, what's the difference between a child and an adult, is that, as mentioned, the child will live longer, expected to live longer, expected to have many more years, expected to be more active. However, they're underrepresented in the pacing population in terms of studies. It's about 1% of the studied population in pacing is children. The rest, the 99% of the rest of the studied population are adults. However, there are not small amount of people who get implanted with a pacemaker in children. There are about 1 to 1,000 or 1 to 2,000 in the US children that get a pacemaker. We know that we have the epicardial system for very small children. We have the endocardial system for older children. And we have a particular group of individuals with congenital heart disease, different cardiac morphologies. So And that is reflected in many series. For example, Professor Wa'il Lotfi and Professor Osama and Professor Rudaina and everyone from this group, they published a very important article regarding permanent cardiac pacing in pediatric patients back in 2012, looking at 101 patients. 79% of them had endocardial system, and 25% had epicardial system. The percentage of complications on the long term was about 25%. That was similar to another study published a year after from the Ain Shams group, again about 100 patients, again about 25% complication rate. Most of the complications are related to infection or lead-related complications, either lead break or similar problems. For that reason, with the development in the industry, it was needed that we find a way out of the lead complications, of the pocket complications, and that comes with the leadless pacemaker. There are two brands of leadless pacemaker currently in the market, the Medtronic one and the St. Jude one. The Medtronic is a single device put in the ventricular, in the right ventricle, and that can function as a VVI, or like a sense the ventricle, pace the ventricle, or can work as a VDD, which is sense the atrium and the ventricle, but only pace the ventricle. And it's a very small device. It's about 18 millimeters in length, and the whole circuit is inside it. Whether the circuit itself that contains all the software, and the cathode and the electrode, and the anode, all fitted in the same device. And it catches the ventricle through these tines, these small tines. If I can show this. Okay, it doesn't work. Okay, but anyway, so these tines are the things that actually catch the ventricle and keep the device fixed. And basically, there is no difference in size between the Micra AV, which works as a VDD, and the Micra VR that works only as a VVI. And how it works as a VDD is it does not actually read the electrical signals. It reads the contraction of the atrial kick, the wave in the tricuspid inflow, and that's how it tracks the atrium. So to overcome this problem, which can cause loss of tracking on higher heart rates, and there's no possibility of pacing the atrium, the Abbott company, which came up with the AVEIR device, developed two types of devices, a bigger one for the ventricle and a smaller one for the atrium. And it has been published last year in New England Journal of Medicine, the success of dual-chambered leadless pacemaker. And our colleagues from Emirates, Professor Mohammed Magdi, originally from the critical care department here, have done maybe about 50 cases, and he's one of the world leaders in implanting such devices. Our hospital in Cairo, Al-Nas Hospital, we have started implanting leadless pacemakers since December 2022. So we have about a year and a half experience. We have implanted so far 14 patients in Al-Nas itself and 3 elsewhere, but with the Al-Nas team. And our range of patients were adults, of course, and it was about 60 to 80 years of age, with fewer patients younger than 60 years, and I'll come for the reason for that. And our usual weight was about 60 to 70 kilograms. However, we have implanted one small lady who was actually 30 kilograms only because she had advanced kidney problems and she had failure to thrive at a younger age. Our patients usually were implanted because of bilateral pocket infection. That was the overall, like the majority. Some were related to infective endocarditis. Some were related to lack of access because of either a Mahoker, for end-stage renal disease or for need for PICC line for cancer patients. I'll just go quickly. I think we have time. I'll just go for in 2 minutes quickly on how we do the device, just to give you an idea, and that kind of gives you the setbacks of that technique. So it's a big sheath. It's a 26 French sheath, and on it is the dilator and the delivery. The delivery is basically, sorry, I don't have the fish pointer. Can you see it? No. Okay, it's not working. Anyway, there is the tether. Anyway, okay. If you can see, there is these strings are called the tether, and these tethers are the thing that's keeping the device, which is mounted on the delivery system, to the it's okay. Okay. To the handle, and that's what's keeping the implanter in control with the distal part of the. Okay. Okay. That's keeping that device. It doesn't work anyway. It doesn't work anyway. Okay. That's keeping this device to the handle. So before we implant, we do some testing, and then we gain femoral vein access, usually, and we'll come to that in a bit in pediatrics. And we dilate gradually from 8 French to 10 French to 14 French in order to be able to get 26 Frenchies into the vein. And we can use right vein, you can use left vein, doesn't matter. And then you put a stiff wire and you mount the big sheath in it. And you can see this is actually, I tried to show a patient with tortuosity. So you can see that although it's a 26 French sheath, is going smoothly through the tortuosity in the vein. So it's not really a difficult, although it looks quite big, but it kind of moves smoothly through the tortuous, even if you have a tortuous vein. And then you put the device, and then you try to position the device into the right ventricular septum. Better to put it in the mid-septum, like this position, rather than the apex. And then you kind of do a gooseneck in order to make sure that this device is fitting on the wall of the right ventricle. And you can check your position in different views. And then you deploy the device, and then you interrogate the device, and usually you like to see an R wave of more than 5 millivolts, and an impedance of 400 to 1,500, and a threshold of less than 1 volt. Usually it's not the usual pacemaker parameters where it's 0.5 milliseconds. The device is set on only 0.24 milliseconds or 0.4 milliseconds. And it's best to really try to get the threshold as low as possible, because that will significantly improve the longevity of the device, which is important as as the device is kept in the heart. Usually we would not like to retrieve it after it's finished. Unlike the pacemaker, where you can change the battery, this device, if you put the battery, usually you keep it and you don't remove it. And then you do like a test to make sure that these tines are anchored on the wall of the heart, as like this kind, it's called pull and hold test. And then you reprogram again, and you can recapture it as long as you still have the tethers. If you lose the tethers, you lose the device. And then you usually it's quite successful from the first deployment. Sometimes you need a second or a third deployment, but not more than 5 deployments are usually needed to successfully implant the device. If all good, then you cut the tether, and that's the end of your procedure. It usually takes about 10 minutes, 15 minutes. It's not a long procedure, but it requires some training, and it requires general anesthesia, and sometimes it can go quite lengthy. The problem with this device is that it's kept in the heart. So for a child who's like 10 years old, you expect that the child will live till 80, 90 years old, and the longevity is about 10 to 15 years in the best estimates. So that child will need about 5, 6 devices in his lifetime. That is a lot. The usual number of devices implanted is 1. Some patients have 2. Very few patients have 3 in what we know. We don't know patients who have actually 4 devices. I don't think that actually even exists. So that will be a problem in the future if you decide to put a leadless pacemaker in a child. I expected it to be 20 minutes, so I'm sorry. I planned my lecture on 20 minutes. Can I have the extra 5 minutes, or it's too much?
Yeah.
Okay, thank you very much. So to extract, okay, can't carry. Okay, so to extract the device is actually quite difficult. So whenever you implant a device, you do not expect to extract it. However, sometimes you need to extract it, and that is difficult. You need to snare it. It's not impossible because there is a place where you can snare the device from. However, in reality, the device is completely embedded in the endocardium, and the endocardium kind of creates a shell around it, so it's difficult to snare it. And usually, even if you try to snare it, it will not be snared from where the locket is. It's usually snared from the body itself. So it's not as easy as what you will read in the manual. Let's put it this way. And so whenever you have the choice, you can always turn the micro off instead of extracting it. Similar is the Aver. However, it has a more sophisticated lead extraction device. So it has its own extractor. It has a device that is built to extract the Aver itself. And, but however, again, there is limited real-life data about how many cases have been extracted with the Aver. This is important because, again, every device you put, you expect that you need to put a second one next to it. In a pediatric population, this can be a little bit tricky. So advantages of putting a leadless pacemaker in pediatrics: there are no leads, so no complications related to leads. Minimally invasive, there are no scars, so it's aesthetic. It can work with possible limited venous options. If you have interrupted IVC, if you have a Glenn procedure, that can work through it. The disadvantages, the main disadvantage is really challenges related to device extraction. There is no CSP yet, but as Dr. Shadi said, it's under development, but still in a very early animal phase. Sometimes you have a small femoral vein, and in that case, you need to use the internal jugular vein, and we'll come to that in a bit. And again, the whole pediatric population is underrepresented in real life randomized trials related to leadless pacemaker. Having said that, there are real life data regarding leadless pacemaker in pediatric population, usually small case series. It started with 10 cases and then 15 cases, and then there is this series of 11 patients, some using internal jugular and some using femoral vein access. And then the global paradigm shifted towards using internal jugular rather than femoral vein in pediatric population, especially if the weight of the patient is less than 30 kilograms, because it turns out that the internal jugular is actually bigger in pediatric population than than the femoral veins. And what you usually need to do is you reset your lab. So you sit by the head of the patient instead of sitting on near the groin of the patient. And but the procedure is quite similar, and you still can fix it near the septum. And right now the company is directing everyone to move towards the internal jugular approach, especially in younger population, and also for the future purposes, as most probably the conduction system pacing will use the internal jugular approach, will not be able to do it through the femoral approach. The real-life data from 69 patients, that's the most recent published data from 2023. About 63 patients, most of them were femoral. However, 12 of them were done internal jugular. No significant complications related to the sheath introduction. Most of the complications were related to maybe catheter manipulation inside the heart rather than the sheath introduction itself. So it is safe to actually use the sheath in a small child through the via internal jugular approach. And now the AVEIR is using the internal jugular approach as well. And where the future is leading us, I think we need to, this leadless pacemaker needs to be properly represented as a subject on its own in guidelines. The internal jugular approach would be the common practice. We may think of a hybrid approach, so we can put a leadless pacemaker in young children and then adjust that once the patient is older to transvenous CS pacing, and then when he's older, tending towards the end of his life, we can shift back to leadless pacemaker. We need more data regarding AVEIR in children, and as Shadi has mentioned, and Dr. Tamer has very intelligently mentioned, the leadless CSP. I think this will be the future, but maybe in 5 to 10 years. Thank you very much.
Thanks, Dr. Muhammad, for this elegant talk. You answered one of my questions, that you can fix the device to the septum. Actually, my thinking was that I should fix it to the apex by its anchoring mechanism. This is my first question. My second question, can I catch the left bundle area by this device and it will be stable at that site or not? Third question I have, can I do the micro in the left side, left ventricle, to the most delayed area and to synchronize it with the right side to do CRT? Is it possible or done before? This is my question. Thanks.
So regarding first point, the company would say it's best to put it on the mid-septum and try to avoid the apex, because the apex now has shown it causes more perforation than the septum. So the preferable position right now is mid-septum. That's the first question. Second question, can we penetrate with that device to the CSP, to the left bundle or to the HIS? No, because these ties are not, they don't have a screw mechanism, they just catch. So you will not be able at all to penetrate into the depth of the septum. Number 3, can we put it in the left ventricle? There is one case report, one single case report in a post-mustard patient where they put it in the systemic ventricle. They claim it's good. I'm not sure. I'll be very worried about thrombosis and about the fact that the left ventricle is smooth, so you will not have enough tissue to catch the ties with it. You had another question?
Thank you. Any questions? Thank you, Dr. Muhammad, and we will go to the next speaker.
Next speaker will be Dr. Hussam Ibrahim. He will lecture about the role of EB in treating cardiac dysynchrony, and Dr. Hussam is a pediatric electrophysiology in NAS Hospital.
السلايد اللي بعدها كده السلايد اللي قبلها بس مفيش ليزر. الليزر من هنا بس مش هيشتغل على الشاشه. ماشي مش مشكله، بس في حاجه بتتحرك على الماوس، عاوز اشاور على حاجه. في حاجه ايه؟ بتعرض دلوقتي ولا لسه؟ هو هيعرض دلوقتي اول ما حضرتك تبدا.
بسم الله الرحمن الرحيم وما أوتيتم من العلم إلا قليلا. Thanks so much for inviting me to this meeting. Today we will talk about the role of AB in treating cardiac dysynchrony. First, to say about the definition of dysynchrony and cardiac dysynchrony. We have two definitions of dysynchrony according to what we talk about, either mechanical dysynchrony or electrical dysynchrony. Mechanical dysynchrony means discoordination between different segments of the heart. So I have simultaneous contraction and stretch within left ventricle at the same time. So mechanical dysynchrony is a diagnosis by echo and not by ECG at all. Electrical dysynchrony is associated with prolonged ventricular conduction time and prolonged QRS duration. So electrical dysynchrony is a diagnosis by ECG and not by echo. Every case of electrical dysynchrony has a mechanical dysynchrony, but not every case of mechanical dysynchrony has electrical dysynchrony. This piece of information is very important in dealing with cases of cardiac dysynchrony. That not every case, an electrical and mechanical dysynchrony, is not usually associated with each other. As we know, we have three types of dysynchrony. Atrioventricular dysynchrony, which means discoordination between contraction of atrium and ventricle. It may occur at the same time, early or late. Interventricular dysynchrony, which means delay between right ventricle and left ventricular activation. And intraventricular dysynchrony, which means mechanical discoordination between different segments in the left ventricle. First to say is the atrioventricular dysynchrony. It is defined by left ventricular filling time below 40% of the total cardiac cycle. As seen with this example, left ventricular filling time from the start of E wave to the end of A waves is 194 milliseconds. Total cardiac cycle is around 596 milliseconds. And the ratio between them in this example is 32%, diagnosing atrioventricular dysynchrony. What occurs if this AV delay is short? When the AV delay is short, so ventricular contraction occurs early, and this impairs the left ventricular filling and left ventricular preload. This impairs the left ventricular filling, left ventricular preload, and compromise the stroke volume and ejection fraction. When the AV delay is prolonged, so ventricular contraction occurs after a while from the end of A waves. So this allows for pre-systolic mitral regurg and allows for the native left ventricular conduction to occur, defeating the purpose of CRT. As we see in this image, the optimal AV time delay is defined when the E and A waves are separated and the end of A waves coincide with the mitral click and the peak of QRS complex. This is a satisfactory AV delay and the optimal AV delay. When the AV delay is short, we can see the A wave is absent or interrupted, like these two images. QRS complex. Okay. Many papers was talking about the importance of AV optimization after CRT implantation. And they found that there's only a minority of patients get benefit from the AV optimization of the CRT implantation with improvement of LV hemodynamics. And the most important patients get benefit from the AV optimization after CRT implantation are the patients of intra-atrial conduction delay, which need a prolonged AV time. It's reached up to 150 to 250 milliseconds. What about interventricular dysynchrony? Interventricular dysynchrony, as we know, it is a delay in activation between right ventricle and left ventricle. So leading to lack of lack of coordinated contraction between right ventricle and left ventricle. The most common example of that is left bundle branch block case. In left bundle branch block, right ventricular contraction precedes the left ventricular contraction, which lead paradoxical septal motion abnormalities, decreased of ventricular ejection fraction, and heart failure manifestation. How we diagnose the interventricular mechanical delay? The most simple method to diagnose that is when we measure time from the start of QRS complex, the start of aortic flow in the apical four chamber, and the time between the start of QRS duration to the pulmonary outflow on parasternal short axis. And when we subtract the two times from each other, we get in this example 89 milliseconds, which is more than 40 milliseconds, the cutoff value for diagnosis of interventricular mechanical delay. After CRT, the interventricular mechanical delay improved by 19%. 19% improving in the intermechanical delay with normalization of the delayed activation of lateral wall of left ventricle. The third type of desynchrony is the intraventricular desynchrony. Intraventricular desynchrony means mechanical discoordination between the different segments within the left ventricle. So early contracting segment don't contribute to the ejection fraction. And at late systole, the late contracting segment contract and the early contracting segment stretch, which means that there is a decrease in the stroke volume, ejection fraction, and heart failure manifestation. Also, mitral regurg worsen due to the desynchrony between the two papillary muscles. This table is the most important and valuable table. It illustrates the different technique and parameters and the reference cutoff values for diagnosis of interventricular desynchrony with the different cutoff values and different sensitivity and specificity. As we see in this example, we have intraventricular desynchrony between the time to peak systolic contraction between the septum and posterior wall, more than 130 milliseconds, which exceeds the cutoff value. In this technique, the cutoff value is 130 milliseconds. In the second, we can see a significant delay between time to peak systolic velocity between the lateral wall and septal wall. Here is 105 milliseconds. The cutoff value in this technique is 65 milliseconds. We can see here also a significant desynchrony between time to peak systolic velocity between the anteroseptal segment and the posterior wall. After CRT implantation, this time significantly improved. This example, another example for using of tissue synchronization imaging, which is a color-coded technique. Early contracting segment giving him a green color. Late contracting segment giving him a red color. And measures the standard deviation of time to peak systolic velocity in basal and the mid segment and give me a standard deviation. In this example, the standard deviation is 87 milliseconds. Cutoff value in this technique is 34 milliseconds. Is another technique using the radial stream at the level of papillary muscle. We can find a significant delay between the anteroseptal segment and the posterior segment here, more than 130 milliseconds, which completely improve after CRT implantation in the second image. This is another technique using the 3D echo, 3D volume, which use the systolic desynchrony index. In this example, it's 14%. The cutoff value in this technique is 6.4%. As we know, we know, there are two types of CRT, CRTD and CRTB. CRTD, which using the defibrillator shocks, and CRTB, which only uses, act only as a pacemaker. And we have a three leads, one in the right atrium, one in the right ventricle, and one of the coronary sinus, and this coronary sinus lead is quadripolar lead. About the indication of CRT, we all know about this indication in adult population. This using the three main criteria. They need a patient with New Heart Association function classification grade C or grade 4 in spite of medical treatment. And left ventricular ejection fraction below or equal to 35% and QRS duration more than 120 milliseconds. This is the selection criteria for CRT implantation in adult population. QRS duration more than 120 milliseconds, it can be a classic left bundle branch block morphology, like here, or it can be a non-specific interventricular conduction delay, which they are the patient who does not meet criteria of right bundle or left bundle, but they have a prolonged QRS duration. In guidelines, the patient with chronic heart failure and non-QRS complex less than 120 milliseconds is not recommended for CRT until now. But this matter is a matter of controversy. There are a lot of papers and controversy about this issue. Some papers published that this type of patient who have chronic heart failure and the narrow QRS complex get benefit from the CRT with improvement in their function class and ejection fraction. And some papers publish that they don't get any benefit from CRT. Like this paper, which talk about the beneficial effect of CRT in narrow QRS complex patient. And another paper was published in New England Journal, talk about there is no difference in the rate of hospitalization or rate of death in this patient after CRT implantation. So this makes the American Society of Electrophysiology says that in cases of borderline ECG, shouldn't include a recommendation whether the patient should undergo CRT or not. And this should be a clinical decision on a case-by-case series and basis. As we know, the CRT responders are characterized by improvement of their mechanical desynchrony, improvement in their electrical desynchrony, improvement in their function classification, and 6-minute walk test. This is the adult population selection criteria. What about the role of CRT in pediatric population? The role of CRT in pediatric population is another indication and another patient. This table illustrates the different indication for CRT implantation in pediatric, and how CRT can improve the QRS duration and improve the ejection fraction and improve the clinical improvement and the percentage of non-responder in every indication of CRT in pediatric population. The first indication in pediatric population is about the patient with pediatric dilated cardiomyopathy. But around 65% of patients with pediatric dilated cardiomyopathy has mechanical desynchrony without electrical desynchrony. Has mechanical without electrical. And just 0 to 9% of these patients have a left bundle branch block morphology in their ECG, which is better away from the adult selection criteria at all. And when CRT was implanted in this type of patient, we show significant improvement in QRS duration, significant improvement in ejection fraction, but the clinical improvement was not so statistically significant because these patients have a more myocyte function in spite with mechanical distinction. They have a poor myocyte function. The second indication, which is very important indication, is pacing-induced cardiomyopathy. The patient with heart block who is chronically RV-based may induce RV-based induced cardiomyopathy. The percentage of RV-induced cardiomyopathy in pediatric population, which is published, is around 13%. 13%, and especially who are based from the lateral wall of RV or RVOT. This type of indication is the most valuable one and the most category of patients get benefit from the CRT in pediatric population. We show a significant improvement of their QRS duration, ejection fraction, and the clinical improvement. The third indication is about the patient of RV dysfunction and right bundle branch block morphology. This common example for that is the patient after failure bay due to myocardial fibrosis from previous surgeries or due to the pressure or volume overload from the pulmonary valve dysfunction after operation, chronic pulmonary hypertension with right bundle branch block. When these patients are based alone or in conjunction with the left ventricle to achieve biventricular pacing, we show significant improvement of QRS duration, ejection fraction, and the clinical improvement. We have published a paper talking about that issue. We have found that chronic RV pacing patients after failure repair are associated with better clinical outcome and a less QRS duration and prevention of progressive LV deterioration of their function. Cardiac, the fourth indication is the patient of systemic right ventricular heart failure. Systemic right ventricular heart failure, this is a common indication for them are the patient of CCTGA or the patient of CCTGA and heart block or the patient after thinning operation with right ventricular heart failure. When CRT implanted in this type of patient, It induced decrease of QRS duration, improvement of ejection fraction, but clinical improvement was associated with the age at the time of CRT implantation. The younger, the better outcome, but does not improve the degree of valve regurg in this patient, in this type of patient. The last indication for that is using the single ventricular failure. The patient of single ventricular failure, especially after hypoplastic left heart syndrome surgery or failing Fontaine with poor ventricular function. Here is the issue on how to do a CRT in a single ventricle. It says we do a multi-site pacing in the two lateral walls of the single ventricle. We boost two leads, one on the right lateral lead and another one in the left lateral lead, left lateral position. They found significant improvement also of ventricular function, QRS duration, and a clinical outcome. This is a different approach for implantation of CRT in pediatric. There are three approaches. Either the epicardial approach, with the most common approach, we implant the three leads epicardially with sternotomy. Like here, the second approach is the transvenous approach, inducing the three leads through the subclavian axis. A hybrid approach, which use the right atrial lead and right ventricular lead through transvenous axis, while the left ventricular lead is tunneled to the battery in the pectoral pocket. The left ventricular lead only, which is done by surgery. As the CRT is the only solution for resynchronization in pediatric, no. We found that there is a possible an association between the accessory busway and the ventricular dysfunction in the absence of tachyarrhythmia. And also, they have the ventricular B excitation by the accessory busway lead to the ventricular dysfunction on long run. This is a common example with a patient with anteroseptal accessory busway. We can show this patient has a significant basal septal dyskinesia and LV dysfunction, segmental LV dysfunction by the bull's eye, which markedly improved after ablation, with improvement of this segmental dysfunction and improvement of synchronization of this patient after ablation of accessory busway. This is the bull's eye of this patient. We can find the segmental association and segmental dysfunction in the anteroseptal region, which is completely normalized after ablation. And also, this is another patient of right posterolateral accessory busway. When we ablate this patient, there is significant improvement of this segmental dysfunction in the bull's eye. Also, the MBI significantly improved in this patient. We can find a significant decrease of isoventricular contraction time and isoventricular relaxation time and the prolonged ejection time after ablation. And develop our new algorithm for localization of accessory busway using the bull's eye of the speckle tracking. And we published our paper about that, and using the 2T speckle tracking for localization of accessory busway and the evaluation of cardiac function of WBW after ablation. Our take-home message for this patient is that cardiac synchronization, CRT, is an efficient tool for correction of cardiac dyssynchrony, both in adult and pediatric population. Adult criteria for selection of patient of CRT cannot be applied for pediatric population, and there are many indications for CRT in pediatric. Electrical and mechanical dysynchrony are not always correlated to each other in pediatric population. And there are many patients in pediatric population have mechanical dysynchrony without electrical dysynchrony. WBW is an important cause of cardiac dysynchrony, and ablation is an effective tool for resynchronization. Thank you all.
Thank you very much, Dr. Hussam, for this highly illustrative lecture. I have one question. The least age for CRT in pediatric, how much? Least age, أصغر عيان.
There is no age for CRT, just indication. We can do an CRT even in infant by epicardial approach, if they are indicated. No. And they have published cases in 9 months old, and do CRT for this patient after sternotomy to improve his dysynchrony, and he published that. So
Okay.
there is no age specific for CRT in pediatrics. Just the indication. The difference is the approach. When I have an older child, more than 30 kilograms, I can use transvenous approach.
All right.
But when I have a young child, I can use only epicardial approach. And the papers who publish the CRT in pediatrics, mainly they say that the most common approach they used is the epicardial approach, not the endocardial approach.
Yes, that is what I asked about. Thank you.
الحقيقة أنا بختلف معاك في آخر ملاحظة قلتها إن WBW is a cause of dysynchrony. I have been ablating accessory busways for 30 years, and a number of colleagues here have been ablating and dealing with WBW accessory busways for many, many years. I don't think that WBW produces a dysynchrony that needs resynchronization therapy, whether by ablation or by any device. This is an observation.
So I presented in my slides a patient it's a real patient. Real patient in our series of our patient. He has an anteroseptal pathway, and he was having a significant LV dilatation and impairment of his function, without tachyarrhythmia, without supraventricular history, tachycardia history. And this patient normalized after ablation of accessory pathway.
I agree with you, it's not common, but
But it can occur.
much like the experience here in Egypt, we see maybe a handful, it's not many, but a handful that have had electrical dysynchrony from eccentric activation and ventricle that reverse that.
I agree with you, it is not common, but it can occur. So one of the manifestations of accessory pathway is tachyarrhythmia, and another symptomology for them is just impairment of function without tachycardia. And another symptomology for them is asymptomatic patient. And asymptomatic patient is common in this category of patient.
There is another observation. WBW is an exception of causes of tachycardia-induced cardiomyopathy. يعني الناس اللي عندهم WBW وبيجي لهم tachycardias كتيرة, they do not develop later on cardiomyopathy. يعني لا ال pre-excitation ولا tachycardia, in my opinion, are causes of dysynchrony أو cardiomyopathy. Maybe البيشنت اللي أنت بتقول عليه ده كان معاه association, rare association بlocal cardiomyopathy مع WBW. وإيه المشكلة؟ ما هذه كلها congenital anomalies يعني.
Yeah, we have had patients, particularly when the accessory pathway is a right anterior, right anteroseptal, or right anterolateral, where the conduction can selectively go down from the sinus node into the pathway before the signal reaches the AV node. And so you actually have a very wide QRS, left bundle branch looking, and you're right, in the overwhelming majority of patients, they do just fine. But we have seen, here in Egypt too, patients with significant LV dysfunction from dysynchrony. But I think the location of the pathway has to be kind of closer in time to the sinus node so that you can have a significant portion of the right ventricle that depolarizes early. So I don't think you see that with left laterals. You probably don't see that with posterior septal pathways. But with pathways that are high on the tricuspid valve annulus and anatomically close to the sinus node, there's a fair amount of preferential conduction through the pathway as compared to the AV node. And so those probably have some risk. Very low, but some risk.
Thanks a lot, Hussam, for this interesting topic. I think we have a lot of patients with end-stage heart failure, and we notice in the echocardiography mechanical dysynchrony and paradoxical septal motion. What about the role of cardiac resynchronization in this group of patients? Do we need to do for any patient with end-stage heart failure ECG to see if there is electrical dysynchrony also? Or what are the indications for CRT in end-stage heart failure in this group of patients?
Of course, in this type of patient, it's still now it is a matter of research if they can get benefit from CRT or not, because they have a poor myocyte function. So I have a dual pathology, desynchrony and impairment of myocyte function. So this group of patients has the least response to the CRT, and the percentage of non-responder in this type of this indication is 67%, which is a large number. That I say that 70% of my patients are not responding to the CRT. Only 30% can get benefit from this maneuver in end-stage heart failure in pediatric population in cardiomyopathy. Especially the patient, I think, of left bundle branch block is the most favorable one for this procedure. But at least until now, they say it is only 30% get benefit from this indication, and 70% are non-responders.
Okay, thank you.
Okay, Dr. Mohammed.
Okay.
Just I want to answer the question of Dr. Mohammed. Dr. Mohammed.
Dr. Mohammed.
Actually, in this publication in the pediatric team, I was involved with this publication. And actually, we have some precaution in these cases. I mean, it's just in pediatric group, not in adult group. I don't see, we see more patients for adult, but just pediatric. And actually, as Dr. Shady said and Dr. Peter, it's not all patients. It's just accessory like anteroceptor and anterolateral and posteroceptor is the most common accessories that we can see. And actually, there is a term now. It's called pre-excitation-induced cardiomyopathy. It's a term. It's published before, and we have some publications before we publish our paper. Just case report, not serious. But it's the first time to do serious with some case like this. But most of them actually we discovered them accidentally. They come into
they were diagnosed initially as
heart
having
failure.
dilated cardiomyopathy. They never had SVT, never.
And for the accessory, actually it's a benign accessory. When we do some studies for the accessory, it's benign. According to guidelines, it's a benign accessory. But with the pre-excitation and with septal motion, like we see in CRT, we see something that's called septal motion, like CRT. We have this synchronization, and we have dilated cardiomyopathy. And actually, in this paper, maybe Dr. Hussain will publish the results of this paper. We have immediately synchronization after ablation of the accessory, and after 6 months, we have very good results for them. Yeah.
Thank you.
Thank you.
Can we just okay, one more question, and then at the end of it.
In Mansoura, I am a professor of pediatric cardiology in Mansoura. I diagnosed an infant 2 months old with tachycardia-induced cardiomyopathy, and he was the cardiomyopathy was related to the presence of accessory pathway. And when the arrhythmia is improved, 48 hours, and the ejection fraction and fractional shortening become normal. This is a tachycardia-induced cardiomyopathy related to the accessory pathway. And many cases, not many cases, few cases was diagnosed as intrauterine arrhythmia and it was the cause of tachycardia-induced cardiomyopathy in the neonatal period.
Okay, thank you.
Commenting about what the doctor said, was every patient has accessory pathway and supraventricular tachycardia can get impairment of its function during this acute stage. But after it normalized to sinus cardiac function improve. But what we comment about tachycardia-induced cardiomyopathy, you need a special situation like BGRT or patient of atrial tachycardia. But the usual accessory pathway and acute supraventricular tachycardia is not a topic in the tachycardia-induced cardiomyopathy.
Okay. Thank you, Dr. Hussain, for the elegant presentation. And now it's my honor and my pride to present my dear colleague and younger brother, our genius, Dr. Al-Hussain Ahmad, a lecturer of pediatrics, pediatric cardiology, Cairo University. He will be talking about the Cairo University Specialized Children's Hospital experience in conduction system pacing.
Assalamu alaikum.
مساء الخير الأول. إن شاء الله you'll make it very short. This is actually our specialized hospital experience in conduction system pacing. We will talk firstly about pacing in pediatric population. Pacing in children is mainly performed as a setup of congenital or post-surgical complete heart block, and it is frequently in pediatric populations that we pace for sinus node dysfunction. The indication, anatomical variation, and technical skills required for pacing a child, although it seems simple, but it is more complex than it seems and actually requires special skills than adults. In children weighing less than 15 kilograms, our approach was a single chamber RV apical pacing in VVIR mode. In majority of cases, this pacing mode has low threshold for the lead, good R wave sensing, and long battery longevity. And in this mode, the operator just insert one lead in the subclavian vein, avoiding any complication and future venous thrombosis or venous obstruction, allowing for further upgrade later on in life. What are the pros and cons for this problem, for this pacing mode? Actually, it's technically easier, shorter fluoroscopy time, lower incidence of venous obstruction, and let's face it, single chamber pulse generators are smaller. And they avoid the need, of course, for epicardial pacing. But however, we have the problem of the synchronous pacing, especially if the lead was fixed in the lateral wall or in the RVOT, loss of atrial synchronous pacing with the ventricle, so we have an interventricular and an atrioventricular dysynchrony, and patient with high RV apical pacing burden, and actually a lot of our patients has this problem, are at higher risk for developing pacemaker-mediated cardiomyopathy. Actually, in this paper with permanent pacing in children, actually they found out that although some of these patients develop decrease in the ejection fraction, however, their symptoms are not that severe. Actually, they all pass without significant symptoms. But our dilemma is children who develop early onset significant dysynchrony with New York class 2 or 3, actually symptomatic patients, significantly symptomatic patients, patients with structural abnormalities requiring synchronous atrial and ventricular contractions, like patients with obstruction in their LVOT, patients with cardiomyopathy, and the patients, our main issue here with patients with high burden of RV pacing. Epicardial pacing gives us a partial answer for this question, which is epicardial dual pacing mode. But however, it's a surgery with a sternotomy or thoracotomy in a very young child. There are usually higher threshold and impedances causes excessive battery drainage and requiring early and frequent replacements. Batteries, because they are child, they play a lot. Batteries are more liable for exposure, infection, and malfunction. So part of it is answered and the other remains. Patients with high burden and children who develop early onset significant dysynchrony. Actually, in the 2023 HRS guideline for cardiac physiological pacing for the avoidance as well as management of heart failure, they answered this part of the question. Actually, our patients usually run in the blue line, in the yellow line. Is the patient with indication for pacemaker therapy, and the ejection fractions between 36 and 50. So we have a high benefit then risk for conduction system pacing or left bundle branch area pacing. And as our colleagues and my colleagues said before, CRT with biventricular pacing in young children usually will end up with an epicardial pacing rather than an endocardial. So if you have an endocardial approach, it is way better than the epicardial approach. From here started our journey. In the workshop immediately before the last our international conference, in collaboration with Cleveland Clinic, we implanted our first patient with left bundle branch area pacing. This was on October 2023. After that, we successfully implanted 5 cases in June 2024, and we started now to regularly implant, and now we have a total of 13 patients just in this labs area. Our patient ranged from 4.5 years old to 12 years old, and weight ranged from 12 kilograms actually to 55 kilograms. All of our patients suffered from complete heart block. Actually, our first patient was post-ablation block, but we have a congenital, we have post-operative, and we have post-ablation. 5 of these patients have received RV apical pacing with burden of ranging from 75 to 99%. Regarding symptoms, unfortunately, 80 out of our 13 cases reported dyspnea on moderate exertion, and only 2 cases received diuretics and ACE inhibitors. Our patient unfortunately had a left bundle branch block morphology with QRS ranging from 120 to 180 milliseconds. Non-paced patients, although showing a relatively narrow complex, but some of them suprahisian escape rhythms ranged up to 110 milliseconds. They show significant dysynchrony by echocardiography. Actually, these are some of the ugly speckle tracking series that we had. Actually, one of the patients have significant septal to lateral delay of 300 milliseconds. Okay, this is how much the septum activates very early, and the lateral wall of the left ventricle lags 300 milliseconds before, okay, prior to contractions. From this arrows is the yellow and the red, the green arrows, sorry, the yellow and the red arrow. All of them have some sort of dysynchrony in the anterior region, on the septal region, or actually in the inferior region. This is an echocardiography of one of the patients. Actually, this is our first implant. We implanted dual chamber pacing for around 12 out of these 13 patients. Only one case, we had a very small vein, so we decided to implant a left bundle branch area lead, only without an atrial lead. Those patients showed an average QRS of duration of 85 to 95 milliseconds after the implantation, with peak left ventricular activation time of around 55 to 80 milliseconds. Threshold ranged actually from 0.5 up to 1.2 volt, and the impedances ranged from 580 to 1,200 ohms, but I need to say that this patient showed rapid decline in the impedance after 24 hours to 890 ohms. All our 30 patients were Medtronic Sensia with dual chamber pacing pulse generator and an atrial lead of 5568 and the Select Secure lead model 3830 for the left bundle branch area pacing. Actually, this is the same patient that we implanted firstly. This is how this is how it showed a very good contractility and globular improvement. Actually, this patient, we stopped diuretics, we stopped ACE inhibitors. This patient went home without any medication. Actually, she reported no symptoms anymore. 24 hours. Actually, this is her same echo, but actually we just showing the lead right here in this 3D model. This is her lead in the septum. This is the same patient with her speckle tracking post-implant, showing a remarkable improvement of her global longitudinal strain. Regarding the ECGs, we have a very nice narrow QRS complex. We can appreciate a pacing spike in a QR pattern in V1 with this actually QRS complex with around 80 milliseconds. This is another patient showing the same phenomena with spacing spike and then a QR pattern in a V1. So to sum up, our journey of exploring new options for synchronous spacing is in a growing heart. Each option should be critically appraised prior to implant in the regular practice. Actually, yes, left bundle branch area pacing is a good option. It has a lot of advantages, but still it is understudied. This is a very important thing. Data about retrieval and removal of the lead is still not available, whether in adult or pediatric population. And many patients might be challenging, especially post-operative tetralogy of fallow patients and patients with wide VSDs and the wide patches after operations. So you get very hard to put a lead in the left bundle branch area. Thanks.
Thank you for your very nice presentation. We, all of us, is proud of you. You are the most junior, but most the best and excellent. I think in the future you will be there. Thank you. Now we'll end this session and starting the next for the fourth session now.
We call for session 4, and chairpersons, please come up.
لا لا خلاص هم مش اسمها
لا it's our pleasure to start session number 4. Okay, may I invite the chairpersons to the podium, please? So it's our pleasure to start this session. First presentation will be given by our dear friend and is becoming our old friend now, Dr. Peter. Is he around? You start. Yes, okay. Okay, so slight change of schedule. We will start with our dear friend, Dr. Shadi. And old friend as well. Our pleasure always having you here. So he'll be giving a lecture about ventricular arrhythmia in tetralogy of Fallot. Very challenging topic. Looking forward for it. And on to you.
Again, thank you so much for the opportunity to discuss this topic. So the disclaimer is that I'm an adult EP and not a pediatric EP, but nonetheless, I'll do my best here discussing ventricular arrhythmias and congenital heart disease with a focus on tetralogy of Fallot. So in general, this is a spread of a whole bunch of different congenital heart disease and the incidence of ventricular tachyarrhythmias in this patient population. And like I said, we're going to focus on tetralogy of Fallot because it's one of the conditions where you actually have monomorphic VT and a pretty significant risk of sudden cardiac death compared to many other of the congenital heart disease population. And to be able to illustrate some important points of this condition, we'll go through a patient case. So this patient is actually one that I shared with Dr. Peter, and we actually managed her together. So she had tetralogy of Fallot, and she was referred for a defibrillator implant. She's had palpitations and ambulatory monitoring that shows non-sustained ventricular tachycardia, and she's had several surgeries at the age of 6 months, 3 years, 6 years, and 16 years. Very complex repairs, and the last 2 operative reports were not available to us. So her echocardiogram showed a left ventricular ejection fraction of 50%, and her right ventricle was moderately dilated. She had moderate RV dysfunction and 2 to 3 plus pulmonic valve regurgitation. When you look at her ECG, you can see this classic right bundle branch block morphology with significant fractionation within the QRS, as you can see in the precordium and in the inferior leads. And her question to me was, Doc, I'm 42 years old. Do I need an ICD? And so she was a very intelligent woman. She was actually a dental assistant. And so we went through all of the guidelines to discuss, okay, well, what do our major societies suggest? And so if you look here, tetralogy of Fallot with clinical VT or multiple risk factors gets a class 2A indication for most societies and class 2 from ERA. And it became important for us to discuss, okay, well, what are these multiple risk factors that they're talking about? And this is what they list: a previous palliative or aortopulmonary shunt, a QRS duration of greater than 180, QRS fragmentation, NSVT, inducible VT, a ventriculotomy incision, or atrial arrhythmias. And the truth of the matter is that our patient had multiple clinical risk factors for ventricular arrhythmia and tetralogy of Fallot. And so like with every patient, we have a discussion about the risks and benefits of defibrillator implant. And I said, hey, you have a lot of different risk factors. There are a lot of different items that make us want to implant an ICD. And she's like, really, I'm young, I really don't want one. And so I said, okay, well, how about your demographics? What about you, from a demographic standpoint, suggests that you should receive a defibrillator implant? And in the study, they looked at atrial and ventricular arrhythmias in patients who had repaired tetralogy of Fallot. And the truth of the matter is, if you look at the red graph here, around the 4th and 5th decade of life in patients who are able to survive that much, there is a second increase in the incidence of ventricular arrhythmias compared to the first 2 to 3 decades of life, but that there was also an association between the incident risk of ventricular arrhythmias and the number of cardiac surgeries that you've had. And she has had 4. And so based on that, we had a shared decision-making discussion, and we agreed to implant a defibrillator. She came back for follow-up 3 years later. She had palpitations. She was getting shocks from her defibrillator. She was started on amiodarone. She continued to have therapy from her defibrillator. At that point, her ejection fraction on the LV side had declined to about 45%, and her right ventricular function continued to deteriorate. And so there was a multidisciplinary team approach to discuss, okay, well, what's the next best course of action? Her pulmonic valve is now severely regurgitant. Her RV is dilated and dysfunctional. And so the thought was, let's go ahead with a reduced sternotomy and consider a pulmonic valve replacement, as well as surgical ablation for the isthmuses that we know are responsible for ventricular tachycardia in patients with tetralogy of Fallot. So this was her EKG that suggests a right ventricular infraoapical exit site of her ventricular tachycardia circuit. And before we proceed, these are the common isthmuses of ventricular tachycardia in patients with tetralogy of Fallot. And so isthmus 1 is between a ventriculotomy incision or patch and the tricuspid valve annulus. Isthmus 2 is between that and the pulmonic valve. Isthmus 3 is between a VSD patch and the pulmonic valve, and 4 between a VSD patch and the tricuspid valve annulus. And so in 2017, she underwent pulmonary artery plasty, RV muscle bundle resection, plasty of the free wall, pulmonic valve replacement, and then cryoablative lesions delivered from the VSD patch to the tricuspid valve annulus and from the VSD patch to the pulmonic valve annulus. She recovered well post-operatively, and then she came back in follow-up and she said, Doc, I had a pulmonic valve replacement and I had an ablation for VT. I'm free of arrhythmias. Do I still need a defibrillator? And it turns out that in patients who have had pulmonic valve replacement and a history of VT, that doing the pulmonic valve replacement really does not have a change on the incidence of recurrent ventricular tachyarrhythmias. Again, in patients who have had ventricular tachycardia requiring shocks, who then go on to develop pulmonic valve, who go on to receive pulmonic valve replacement, there was no survival advantage as far as freedom from recurrent arrhythmia related to pulmonic valve replacement. And so in summary, no clear benefit in the sudden cardiac death risk reduction or incident VT in patients with pulmonic valve replacement. However, there likely is a role for EP study in these patients for surgical guidance for possible isthmus ablation. So patients that are candidates for pulmonic valve replacement, there is some discussion about taking them to the EP lab and doing an EP study, or prior to percutaneous, particularly stented pulmonic valves, because the metallic struts of a pulmonic valve that's percutaneous can start physically and mechanically boxing you out of the ability to deliver ablation in some of the substrate in this patient population. So 5 years later, She came back. She had recurrent palpitations and device therapies. This was worsening during a COVID infection. She required more diuretics, and she was transiently suppressed on amiodarone, which had been discontinued after her recurrent open heart surgery. You look at her device diagnostics, and she had a very significant uptick in VT-VF. This was around the time that she had COVID, and then that continued to kind of settle down, but then had another uptick here in June of 2022. And so we agreed to proceed to the EP lab, and we had two main objectives. One objective was to demonstrate block along the previously delivered surgical ablation lines, but then also map her substrate and try to understand what the mechanism was of her recurrent arrhythmia. In the right panel here, we see an RAO projection of her right ventricle. The tricuspid valve is here. The pulmonic valve is here. Everything in red suggests scar and low voltage. Everything in purple suggests healthy, robust voltage. And so by that token, you can appreciate that this island of red tissue is where her ventriculotomy incision was, and this connects all the way up to her pulmonic valve. This is a slightly different LAO view of the same surgical incision here on the anterior free wall of the right ventricle. These next two pictures demonstrate conduction time and conduction velocity in the same patient during sinus rhythm, and anything that has a white line running through it is a proposed line of block. And so it seems that there is a line of block from her ventriculotomy incision to her pulmonic valve, as well as from the tricuspid valve to the VSD patch. And so it really seems like the surgically delivered lines had continued block, but somehow she had ventricular arrhythmias. And so this was mapping in VT, and you can see here a circuit near the inferior portion of her ventriculotomy incision that kind of goes around in a circle, around this area of delayed conduction near the inferior margin of the ventriculotomy incision. And the truth is, we actually didn't have the entire cycle length of the VT in this region, suggesting the complex substrate in these patients of both endocardial and epicardial substrate. And the fact that she's had multiple prior surgeries obviously eliminated our ability to have an epicardial approach for her ablation. So we delivered ablation near the inferior margin in this area that appears to be an isthmus, and she did well for several months thereafter. She was free of recurrent VT. Now the problem, as we know with this patient population, is that they continue on, despite freedom from arrhythmias, to develop heart failure. She started developing further RV dysfunction and cardiac cirrhosis from the same. She actually had a transplant, but unfortunately that was really quite complicated. She developed kidney dysfunction, she was on dialysis, and ultimately, unfortunately, passed away. And so in summary, ventricular arrhythmias in adult congenital heart disease, but specifically in tetralogy of Fallot, it becomes important to understand what the mechanism of ventricular tachycardia is, to have some sort of an algorithm or a framework for risk stratification, whether that's the demographic information of the patient, considering the role of EP study prior to pulmonic valve replacement, whether surgical or percutaneous, triaging ICD implants, and then also understanding the role for catheter ablation in patients who have scar-related VT, but then also identifying ventricular tachycardia in this patient population as a marker for how well they're doing clinically. It's not always just the fact that they have electrical scar, that they have VT. Sometimes that's a marker for heart failure. Think of it as a symptom of heart failure and progressive disease of the right ventricle and so on. And so considering advanced therapies in this patient population when available. Thank you.
Questions, please.
I'd like to ask about the role of MRI. Do you have a role for detection of fibrosis in the RV or something like that?
Yeah, that's a great question. So in patients that don't have contraindications to MRIs, certainly I try to scan all of my patients prior to VT ablation, because it'll really shorten our procedure time if we have an understanding of where the scar burden is. Now the difficulty is many of these patients already have defibrillators. And so even if you have an MRI compatible device, the amount of scatter artifact that you get from the ICD lead in the RV, because that's really where all of the substrate is, can make it difficult to interpret. And so in patients with ischemic cardiomyopathy, for instance, and a lot of substrate in the left ventricle that we see for ablation, even if they have an ICD lead, sometimes we're able to get decent images. But because the substrate here is in the RV and your lead is in the RV, the quality can be poor.
Can I ask you about the setting of unipolar map, voltage map, in these cases with different complex congenital anomalies, with the thickness of the LV, RV, if it's systematic or not? How do you manage this?
To understand the epicardial surface? Yeah, so I've kind of moved away from unipolar mapping and honestly have been focusing more on ablating, on targeting delayed conduction and targeting areas of isochronal crowding with the St. Jude system, as opposed to really spending time understand. Because if the epicardium is something I don't have access to, then sometimes just using those surrogates for conduction time has been our area of interest, both research and during procedures. So thank you.
Okay, I have one last question. There's something you said that resonated with me on a previous experience now. When a patient has extensive scarring in the RV and develops ventricular tachycardia, I had a similar condition where after ablation and terminating the VT, the patient goes into rapidly progressive right ventricular failure. Yeah. Do you have any experience or any similar conditions to this in your practice?
Yeah, I'm trying to think. I mean, I generally haven't seen kind of you terminate the VT and they rapidly decompensate. Yeah. But I really do believe that in many of these patients, the VT is a symptom of things, that things are decompensating. And so you get rid of the VT, but that doesn't change their clinical course because the substrate is just so severely abnormal and the RV is so dysfunctional that you just eliminated a symptom, but the underlying process is just still continuing in the background.
Thank you very much.
Thank you. Yeah.
On the right ventricle?
Yeah, perhaps.
This is yeah. Could be.
Thank you.
Okay, thank you very much.
Thank you.
Okay. Next speaker, early post-operative. Dr. Peter, okay. Arrhythmia and heterotaxy syndrome. Professor Peter Aziz.
Okay, thank you. I'll try to be brief so we can end on time. So we're going to talk about arrhythmias and heterotaxy syndrome, and as always, we'll start with a case presentation. This is a 16-year-old patient with frequent PVCs who actually had palpitations and dizziness, so was symptomatic. Had a history of malrotation and polysplenia, but no diagnosis of heterotaxy syndrome, and had a Holter that showed 31% monomorphic PVCs. Her echocardiogram showed compromised LV function, which is the reason why we brought her, in addition to her symptoms, to the EP lab, which we'll show you in a second. But the echocardiogram showed that she had normal cardiac structure and function otherwise. This is her electrocardiogram, which shows frequent monomorphic PVCs. They have a left bundle going from high to low, look like it's outflow, and the transition is V3. And we do our cases without fluoroscopy, so while making the electroanatomical map, the fellow who I was with was showing me the catheter advancing with no electrical signals at all, and all of a sudden making a curve here, as you see. They're making a curve here down. I'll show you. The catheter was advancing here with no electrical signal, and the catheter started making this curve back down. So seeing this, we suspected here that this was a interrupted IVC with azygous continuation, which is what it was. We actually were able to get into the aortic, arterial system, and this was an LVOT VT PVC, so we were able to ablate it there. But this is a patient whose echo reportedly showed an IVC that drained normally to the RA, but that certainly was not the case. So this patient is an example of heterotaxy syndrome, though, without much cardiac phenotype. So it's important to discuss what situs salatus is before we discuss what heterotaxy syndrome is. And situs salatus, simply put, is when the right-sided structures are on the right side. That includes trilobed lung, liver, and the left-sided structures are on the left side, a bilobed lung, the heart, of course, the stomach, and the spleen. In the case of left atrial isomerism, they instead have essentially duplication of the left atrial appendage, as you see here, and typically associated with that is a midline liver, midline stomach, polysplenia, and then bilobed lungs. And the opposite is right atrial isomerism, where there's two right atrial structures, essentially, and again, a midline liver and stomach, though oftentimes without a spleen, so asplenia. So people often call left atrial isomerism the polysplenia type, right atrial isomerism the asplenic type. As you can imagine, if there's duplication, as electrophysiologists, what we really care about, if there's duplication of the left atrial appendage, then you may be absent the conduction system, because the conduction system, the sinus node and the AV node live in the right atrial appendage. Whereas if patients have duplication of the right atrium and right atrial structures, you may have duplication of the sinus node and duplication of the AV node. So in right atrial isomerism, the asplenic type, as we discussed here, 26% will have clinical SVT, with twin AV node reentry being most common. We'll see a picture of that in a second. These are benign supraventricular arrhythmias, not associated with sudden death, but certainly associated with burden of disease, hospitalizations, and such. And a small percentage have dual sinus nodes that typically don't get associated with arrhythmias, but something that you see on ambulatory monitoring and on ECGs. Another depiction here of right atrial isomerism showing an anterior AV node and a posterior AV node connected by the Machiberg sling, and this is the potential mechanism of twin AV node reentry. This is a rhythm strip from a patient of ours that shows upright P wave in lead 2 that suddenly shifts to a downgoing P wave with a associated change in the QRS axis. And what's happening here is when the anterior AV node is being used, the anterior SA node is being used, it activates the anterior AV node and gives you a conduction system axis and a P wave axis that are pretty normal. And that switches to posterior, a posterior and inferior SA node that activates a posterior AV node. So you see a P wave axis change. You also see an associated QRS change. And this is very common in right atrial isomerism when you do ambulatory monitoring, something to keep in mind when you're seeing these patients. The twin AV node reentry is sort of like typical AV node reentry. The difference is that instead of there being a slow and a fast in a single AV node, this is a slow and a fast in two different AV nodes, in the posterior and the anterior AV node, and you can have reentry between the two. In left atrial isomerism, or the polysplenic type, one, it's less common than right atrial isomerism, and really for arrhythmias, you think the opposite. We're getting supraventricular arrhythmias in right atrial isomerism, and left atrial isomerism, we're seeing bradyarrhythmias. Junctional rhythm from sinus node dysfunction, sinus bradycardia, and then heart block can also be an association. So looking at freedom from supraventricular tachycardia and right atrial isomerism, you see that by 20 years of age, about half the patients here will have some clinical form of SVT. And if we look at left atrial isomerism and freedom from bradyarrhythmia, you see there's quite a high burden of bradyarrhythmia pretty early on. 50% with bradycardia by 6 years of age. If we look at the tachyarrhythmias by subtype, there actually is not an associated statistically significant difference between left atrial isomerism and right atrial isomerism, but you see the graphs diverge a bit here, where right atrial isomerism patients will have more tachyarrhythmias as a subtype of arrhythmia. And then bradyarrhythmias, there is definitely a difference here where a left atrial isomerism patients are much more likely to have bradyarrhythmias. And if we look at transplant-free survival, the patients without tachyarrhythmias versus the patients with, the patients without do much better in terms of transplant-free survival. This is a study of 120 patients, 35% that died or underwent transplant. And tachyarrhythmias were associated with a higher risk of transplant and death with a hazard ratio of 2.2. So let's take a look at catheter ablation. We showed one patient with PVCs and interrupted IVC. We'll take a look at another. This is a case that Akash Patel did. He's my partner. 29-year-old with right atrial isomerism, unbalanced AV canal, and pulmonary atresia with a extracardiac Fontan, was having recurrent tachyarrhythmias that were adenosine responsive, failed medical therapy in the forms of digoxin, atenolol, and sotalol, so was taken to the EP lab. This is an electrocardiogram of the tachyarrhythmia. You see here there's a left axis and right bundle, relatively wide-ish QRS, though not as wide as you might see in VT, so we thought this is some aberrated SVT. We take a look at this first picture with catheters in. We have native sinus rhythm and QRS morphology of a right axis and a right bundle. And with atrial pacing, we find that there is a different QRS axis entirely with a left axis deviation now and a right bundle. They gave this patient adenosine at baseline, and you see here the PR prolongs, and as the PR prolongs, the first thing you might notice is the QRS axis changes, which is underneath this orange arrow. You see the QRS axis change most significantly, I think, in V4 you see that change, and then following the QRS axis change, then you have complete heart block. I think what we're showing here is block of one AV node and then block of the following AV node leading to complete heart block. The electroanatomical map that was created shows the Fontan baffle posteriorly here, the aorta anterior, and then the blue is the atrial mass. Green is a cluster of His signals, and yellow is another cluster of His signals. So there are two signals of AV nodes. Green was the anterior His bundle, and the yellow was the posterior His bundle that was recorded near the Fontan baffle. So what do you ablate? Which AV node are you supposed to get rid of in somebody with twin AV node reentry? And the answer is the one that you're not using for antegrade conduction. So the one that's being used for retrograde conduction is the one you're trying to get rid of, and that was the one that was targeted for ablation, the green one. So during ablation and sinus rhythm, you notice in orange, again, a change in the QRS axis where you're changing the antegrade conduction from one AV node to the other, and that was the measure of success in this patient with twin AV node reentry. So to summarize, arrhythmias are certainly a growing problem in this patient population. Lesion and heterotaxy type specific, oftentimes dictated by surgical palliation and hemodynamics. And the cases can be complex and challenging, but certainly understanding the anatomy is the first step. Thank you very much for your attention.
Thank you so much, Dr. Peter, for this very nice presentation. Any questions from the audience? Dr. Sonia?
You always ask me the difficult questions, Dr. Sonia. Please go ahead.
You mentioned that you would like to do an electrophysiologic study, an ED study, before sending them for heart transplant. Why would you do so if you're going to do heart transplant?
I don't think we mentioned.
They end up with a univentricular pathway somehow, and then especially the asplenia syndrome, cases, and then they end with heart transplant. So why would you do a
Yeah, we typically don't. We don't do electrophysiology studies in these patients unless they have some clinically significant arrhythmia or they're not progressing on medical therapy. But the ablations are complex, as you saw, so that
Exactly.
that's not first line oftentimes for these patients, especially if there's twin AV nodes, because you're never really sure which one is the dominant AV node. You may still end up having heart block after, or at least intermittent heart block after.
Thank you.
Sure.
Thank you so much, Dr. Peter. Now it's my honor.
Thank you for your interesting complex case, but I would like to ask you, what are the criteria that you choose which one AV node to ablate? You have dual AV node, but which one?
So if a patient has reentrant twin AV node tachycardia, then the antegrade limb of that reentry is going to be the robust limb. So that's the limb you want to preserve. So if the antegrade limb is the anterior limb, you don't want to ablate the antegrade limb. You target the posterior limb of the tachycardia. So you have to see which one's the more dominant antegrade conduction and target that. Target the other one. Yeah.
To the QRS, the endpoint QRS. You don't, because the other one will end up with the right bundle delay. I don't know. I would choose maybe to keep the narrowest QRS.
Yeah, that's an important consideration. Most of these patients actually will go back and forth between different QRSs in a 24-hour period, like we saw on the Holter monitor. But whether you get the synchrony, if you're ablating the node that gives you a narrow QRS, we didn't see that in this patient, but that's certainly possible.
Do you do an activation map during tachycardia to see where the atrium is activated so that this denotes the retrograde limb?
For sure, yeah.
This is how you get the...
Yeah, that wasn't shown in this case. This
Yeah,
was a published case by my partner. But practically speaking, we would use a high-density mapping catheter, like a pentarray or an octarray, and get an activation map of the entire atrium. In a Fontaine, you'd have to go transbaffle to do that, but that would be the... Yeah. So you know exactly which is the antegrade. That's right. That's right.
Thank you so much, Dr. Peter. Now it's my honor to present my dear colleague, Dr. Osama Abdelaziz. الحقيقة I am very proud to be part of this great team. And we are all proud of the EP team in our case unit. والحقيقة ربنا يجزيك كل خير يا أسامة، وفعلا فأما الزبد فيذهب جفاء وأما ما ينفع الناس فيبقى. فأنا I believe إن أنت دايما حريص على إن أنت تسعى أنت وكل الفريق الحقيقة، دكتورة رودينا ودكتور حسين طبعا دكتور وائل ودكتورة رانيا، كلكم يعني أحلى من بعض. ربنا يوفقكم يا رب. We are eager to hear your presentation. Early post-operative arrhythmia after pediatric cardiac surgery, the importance of atrial pacing wires.
Thank you so much. Bismillah ar-Rahman ar-Rahim. I would like to thank very much my Dr. Peter Aziz and Dr. Shadi. They are always supporting us and coming every year, give us a great help. I would like to thank my professors and colleagues, as their presence today is actually the cause of success of our conference. So my topic will be about early post-operative arrhythmia after pediatric cardiac surgery, and my main concern will about the importance of post-operative atrial pacing wires. So this is my agenda. So start with a case which is very common, that I have a call with a patient 2 years old, a status post-tetralogy fallow repair, who came from the OR very stable with stable hemodynamics, and then 2 hours later he developed this form of tachycardia, and I have a call from the intensivist that the patient became hemodynamically unstable. For that, I just asked him one question: that the patient had an atrial wire post-operative or not? So Postoperative arrhythmias are a well-known complication after congenital cardiac surgery. Although transient and treatable in most cases, they are a cause of substantial morbidity and mortality. In early postoperative period, hemodynamic fluctuations are common, making the patient unstable and may lead to low cardiac output syndrome and cardiac arrest unless treated promptly. A review of existing literature, the incidence of early postoperative arrhythmia reach up to 48%, which is very big incidence. So the etiology, like myocardial incisions, cannulations, sutures close to the conduction system, cardiac dysfunction, electrolyte disturbances, catecholamine stimulations, and most of the patients, they have inotropic support postoperative, acute changes in intracardiac pressure and volumes, cardiopulmonary bypass, related inflammation and ischemia and reperfusion, and residual hemodynamic impairment, and also pain and anxiety. So there is many factors related to the age of the patient, to the weight, to structural heart abnormalities, hemodynamic abnormalities, comorbidities, preoperative medications, previous palliative interventions, surgical technique, and electrolyte disturbances, or they carry the risk of postoperative arrhythmias. So the postoperative arrhythmia lead to low cardiac output either through a very high heart rate, low heart rate, or slow heart rate, irregular heart rate, and loss of EV synchrony, which is very important cause of postoperative low cardiac output. Postoperative arrhythmia leading to low cardiac output through different mechanisms, and then leads to metabolic acidosis, myocardial depression. So the intensivists will increase the inotropic support, so it's a vicious circle, leads to more arrhythmia. So it's a vicious circle, you have to interrupt it early to prevent morbidity and mortality. So in order to treat, you have to diagnose it properly through 12-lead ECG to establish a template to compare QRS morphology, if an arrhythmia develop or make a diagnosis of an existing arrhythmias. So with a 12-lead ECG, you can diagnose a lot of arrhythmias, like here it's a first-degree heart block. Also, the arterial pressure waveform looking for beat-to-beat variability in pulse pressure can aid in the arrhythmia detection. Most of the patient post-operative, they have an arterial, invasive arterial line, and they have also a central venous pressure monitoring. Regular and biphasic central venous pressure monitoring is on the bedside monitor is suggestive of EV synchrony, whereas a monophasic pulse contour, marked irregularity, or presence of a Canon wave indicate EV dyssynchrony. So it is very important log for also for the arterial wave monitoring and for central venous pressure monitoring for detection of arrhythmias. Like this on the left panel, the junctional rhythm, as we see, the pressure is low, and also the central venous pressure monitoring shows the Canon wave, indicating loss of EV synchrony. When the patient came to sinus rhythm, the pressure improved, and also the central venous pressure monitoring becomes biphasic and normal. So this is indicate the impact of postoperative arrhythmias on hemodynamics. Also, it's very important if a patient develops early postoperative arrhythmia to have an echocardiography to see if there is any structural abnormalities that may lead to arrhythmias and should be managed immediately. The third thing, which is very important, is the pacing wire. Temporary pacemaker wire is important in the management of postoperative arrhythmia after cardiac surgery, and it's life-saving in cases of bradyarrhythmias. The presence of atrial and ventricular pacing wires can help not only in arrhythmia detection management, but also in diagnosis certain types of arrhythmias by performing epicardial atrial electrogram. So as most of the centers, the patient come with 2 atrial wires and 2 ventricular wires, so they can connect it to a dual pacemaker generators. So the atrial ECG, which is very important, many cases on the post-operative arrhythmia, when we develop tachycardia, the P wave actually, they have a small amplitude atrial signals. They may make the rhythm discrimination is very difficult or impossible. The American Heart Association practice guidelines recommend adapting a 12-lead electrocardiogram to visualize atrial signals using temporary atrial epicardial leads for the improvement of diagnostic accuracy, which is very important, and this is very important for detection of many or almost every case with a post-operative arrhythmias. The P wave is accentuated and magnified and appears as a sharp spike, which can be easily visualized and can be identified with its exact position, where it's before, within, or after the QRS complex. There is two ways of doing an atrial ECG or atrial electrogram, either to do unipolar by connecting the temporary atrial wires to V1 or V2, or bipolar by connecting the two atrial wires to the limb leads to the right atrium and left atrium. As we see here, the atrial ECG looks as a sharp spike, so we can see the P wave clearly. Here, this is usually the practice to the temporary atrial wires comes on the right side of the patient and the ventricular wires on the left side. And we can use this type like an alligator clamp to just connect the atrial wires to the ECG and do the atrial ECG as so here with the atrial activity appears like spikes. So the atrial wire is very important. It has a diagnostic and therapeutic modalities. For diagnosis, it can differentiate junctional tachycardia from supraventricular tachycardia, sinus tachycardia. In junctional tachycardia, the P wave are either superimposed on the R wave, dissociated or dissociated from the R waves. Because also the treatment is, accurate diagnosis is important because the treatment is different. Also, atrial electrograms may be useful in differentiating various degrees of heart block and sinus node dysfunction. In heart block, the atrial rate is generally faster than the ventricular rate, as opposed to sinus node dysfunction, where the reverse holds true. This is an example with a junctional ectopic tachycardia done with an atrial ECG. As we see here, that the atrial activity it's done on V2. It's actually on top of QRS complex. This is another example of JET with the retrograde P wave. The P wave spikes comes after the QRS, immediately after the QRS. And this is another example with JET with dissociation, VA dissociation. See here the atrial spikes. So for those examples, we diagnose it as JET, and we diagnose either it's retrograde immediately on QRS or dissociated from the QRS. Here, this is an example also of post-operative tachycardia. When we do an atrial ECG, we notice that the P wave spikes comes before the QRS, so it's a sinus tachycardia, which is need no just to decrease the inotropic support, and that's all. بالشغل. So this is an example also of a patient with atrial flutter. Usually, many cases, the atrial flutter on the monitor, they may not appear clearly. So when we did an atrial ECG, we found that here in lead 2, that lead D1, there is two flutter for every QRS, so 2 to 1 flutter. There is many, based on the atrial ECG, we have a lot of algorithms that actually can diagnose all types of post-operative arrhythmias, like this algorithm and this algorithm, based on the QRS duration and the relation or the ratio of the P wave to QRS. So what are the therapeutic values of atrial wires? You can use the atrial wires for termination of tachycardia by using temporary overdrive pacing, can be effective means of termination of reentry tachycardia, such as atrial flutter and paroxysmal supraventricular tachycardia. Second thing, it can be used for restoration of AV synchrony in cases of jet, which is very important, either using atrial pacing wires to do pacing higher than the jet rate, after jet rate is successively reduced by medications as the addition of atrial systole to ventricular filling will augment the cardiac output. Atrial pacing alone may be associated with long PR interval or even Wenckbach due to effective trauma edema and postoperative. This is the first thing we do. We give medication to the jet to reduce its rate, and then we try atrial pacing to try to make use of the atrial kick for those patients. But sometimes when we do atrial pacing, it goes into Wenckbach or heart block. So we go to the second mode of pacing. We do DDD pacing or sequential pacing. There is another mode of pacing called R-wave synchronized atrial pacing. And this mode is a little bit complex, but it's also can be effective in cases of jet. We just reversed, we put the atrial lead to the ventricle, and we put the ventricular wires to the atrial socket, and we use the DDD function. It just sends the ventricle and then pace the atrium. It's called RV synchronized atrial pacing. As we notice here, when we use this modality, it improves the hemodynamics. Another thing which is relatively new is to do continuous monitoring of the atrial ECG using the Atriamp monitor. Actually, it's very clever idea to use this type of connector. We use the pacemaker cable here, and this is the cable to the monitor, and here the temporary atrial wires. So we can continuously doing an atrial ECG on the monitor, and we can still use the pacemaker function also. And this is an example of using the Atriamp. This is on the top, the usual monitor, and on the bottom, and see here, this is the Q-wave, very clear. And this is another example also of an atrial flutter, which was not appeared by the normal monitor. It appeared with the Atriamp with 2-to-1 conduction. So back to our case, it's a case of junctional ectopic tachycardia. What we use in this patient, we slow the conduction or the rate of the jet with a medication, and then we use an atrial overdrive pacing in order to attain atrioventricular synchrony. And we managed, and this is with the atrial pacing to do restore the AV synchrony, and we managed that the patient hemodynamics improved, and he returns back to sinus rhythm after 48 hours. So take a home message: post-operative arrhythmias are common after cardiac surgery and may result in increased morbidity and mortality. Early recognition and prompt management of post-operative arrhythmias is very important and leads to recovery of ventricular function. Temporary pacing wires for an atrium and ventricles are crucial after open heart surgery and can be used for diagnosis and therapy and restore the AV synchrony. Atrial ECG is an important tool for accurate diagnosis of early post-operative arrhythmias. Recently, continuous atrial ECG monitoring using an Atriamp is a very useful tool after cardiac surgery. Thank you. Not, yeah, it's just, I think it, do you use it, Peter or Shadi, for the Atriamp? But because it's just 1 year back in the US.
Yeah, I was going to ask about her. A colleague of ours who paces is the entrepreneur for it, but we haven't started it.
Yeah.
Do you use it routinely here?
The atrial ECG, we use it, but we don't have the Atriamp. But we use, for every patient, an atrial ECG post-operative routine.
The Atriamp looks helpful.
Yeah.
congratulate you and confirm the importance of the atrial wire, particularly I might add that particularly for postoperative congenital heart disease, the usual contribution of the atrial kick for the cardiac output in a normal child would be like 20-25%.
Yeah.
In the presence of diastolic dysfunction, particularly in the postoperative fallout, who 50% of these have diastolic dysfunction, the atrial kick component is 50%. So a question of life and death might be the atrial wire.
Exactly.
Thank you.
Yeah, this we noticed the very marked improvement in hemodynamics after restoration of EV synchrony in those patients with the stiff RV. Yes, exactly.
It's my pleasure to introduce Professor Dr. Ahmed Toher. He will talk about role of cryoablation in anteroseptal accessory pathways.
Thank you very much for the invitation. And thanks for the introduction, Dr. Azza. So, too much science in the previous lecture. Hopefully this one is going to be like a pause or a break. It's simple and introduces the cryoablation in pediatric population. So, so far, most commonly, I would say, I mean, we have PFA already, not in Egypt yet, but most commonly the energies we use for ablation are either radiofrequency or cryoablation. Now they differ fundamentally in the way they work. In radiofrequency ablation, we send electrical current through the tip of the catheter that passes through the tissue, and the resistance to the flow of electrical currents in the tissue is what produces the temperature, the heat. And heat is conducted back to the catheter, so you can measure it, and this heat at the interface between the catheter and tissue causes resistive heating, damages part of the tissue, disperses to the surrounding tissue, causes conductive heating, and the dispersion continues until the effect fades away. So heating starts in the tissue and fades from that point onward. Now, when cryoablation, the lesion formation fundamentally is different. So we inject gas, nitrous oxide, in the catheter, and this gas leads to excessive cooling of the tip of the catheter, which causes a cooling of the tissues it touch, and from that point, temperature drops to the surrounding tissue. So the way it kills tissue, it creates lesion, is by forming ice intracellularly and extracellularly. And these ice crystals destroys intracellular organelles and cause in the cell consequently. But importantly, because it's freezing, it doesn't cause protein maturation. So the structure and integrity of the tissue is maintained. The tissue is no longer functional, it is destroyed, but it retains its integrity. So whenever I use an energy for treating arrhythmia or creating lesions in the heart, I would be minded by safety first, not to produce any complications, safety second, to minimize radiology exposure, and finally, I need it to be as effective as possible to reduce its redo. So we might think that cryoablation is suitable for all of these. Is it safe? Yes, in a way, and we will prove that. This is the regular console of cryoablation. This is the console that contains the gas connected by umbilicus to the catheter, and this is the cable for signal that is connected to the recording system. And interestingly, it can be integrated with 3D mapping system to reduce radiation exposure as well. So is it safe, causes reversible electrical effect, and prevent damage to AV node? Yes. And this is for many reasons. One of the most interesting feature with cryoablation is the cryomapping feature. So I can exactly test the response to lesion creation in the site I'm touching by first reducing the temperature to around minus 30. So at that level, the tissue the catheter touches is not functional. So I have an idea about the efficiency of that location, and also I have an idea whether this site is safe or not. Now, importantly, at this temperature, the lesion I'm creating, or the energy, the effect I'm producing, is completely reversible. So there's no permanent tissue damage at that site. So once I reach a site that is deemed both safe and effective in terms of not inducing heart block and in terms of terminating the tachycardia I'm looking at, I then can reduce the temperature further low to minus 70. And this is the cutoff where the irreversible lesion creation starts. So the ability of cryo to allow you to cryo map the tissue is a great advantage in cryoablation. And this is the screen we get that monitors, that shows the temperature. Yeah, this is the tissue temperature around 37, and once you start cryo mapping, the temperature drops to minus 30, and during this period you observe the response on the tissue, whether there's heart block or elimination of pre-excitation, for example. And once you're happy with the location you have, you then go to cryo freeze and cryo ablate at minus 70. So this is why it is safe. The other reason why it is safe is because we have evidence that the collateral damage with cryo is minimal. So although this comes from an animal study, but when it is carefully studied, the collateral damage of cryoablation, the remote lesion formation is very minimal with cryoablation, and all coronaries are preserved, probably because of the heat sink mechanism in the coronaries that increases the temperature quickly to prevent any damage in the coronaries. Now, one of the other interesting features about cryoablation that contributes to safety is the cryoadhesion. So, interestingly, once the catheter temperature drops to cryomated tissue, it no longer moves. So once you are at a good spot, both in terms of safety and efficacy, you are sure that no matter how deep the patient breathes, no matter how the heart beats, and even if the tachycardia terminates or you decide to pace to make sure to study the effect of pacing, it won't change. And actually, as a demonstration, when we do cryoablation, once we reach to cryo-freeze within like 45 seconds, you just leave the catheter and it stays where it is, even if you're not holding it. And it will stay there until you thaw the temperature. So this is an additional feature for safety. And again, you can control exactly the lesion depth by controlling the catheter tip. So it is not titratable as the RF. I cannot push the power high up to create larger lesion. If I want larger lesion, I have to choose a larger tip catheter from the beginning. But I cannot titrate the temperature. It's all or none once I use the catheter. But because it preserves the cellular structure and does not cause protein deterioration, the endothelium lining the area I'm ablating at remains intact. And accordingly, thrombogenicity is minimal with cryoablation. This is also contributes to the safety of the catheter. So for all these lesions, we believe it is a very safe form of energy delivery and lesion formation. And yes, it is painless and effective, and we will show how effective. So when do we use cryoablation? Obviously, whenever we're dealing with an arrhythmia that is around dangerous area, around the AV node, be it AVNRT, be it JET, be it accessory pathway in the paraseptal locations, and whenever we're dealing with arrhythmia in highly mobile areas in the heart. So the right free wall area in the right atrium is notorious for being very mobile. So it's difficult to maintain your catheter. If you're using your RF catheter, it's difficult to maintain the position. The cryoablation gives you the advantage of once reaching in the correct location on the right free wall, the catheter sticks to where you want it to stick, and it doesn't move from there. So it's advantageous there. And of course, when you're ablating near the coronaries, like in the LVOT. So what is the evidence we have for that? In AVNRT, in pediatrics, specifically pediatric population, still it's very effective. The acute success rate and the late recurrence are comparable to RF, but you rarely see this number in medicine ever. No one describes zero complication in anything. But yes, cryoablation in AVNRT in children is very safe for all the reasons we described before, and we have the evidence that. And interestingly, when you combine it with 3D mapping system, and it is integrated with 3D mapping system, you get both benefits. You get the benefit of safety and the benefits of reducing fluoroscopy. So you can be very helpful to your patient as well. Now, again, when we chose cryo, we chose it for arrhythmias around the AV node. And the most notorious arrhythmia around the AV node is the jet, because very frequently the substance is actually within the AV node or the proximal hypopituitary system. So cryoablation still offers better results than radiofrequency for targeting these lesions, but because you are ablating very, very closely to the compact AV node, it is not bulletproof. It is not as safe as you would. I cannot show you the 0% complication rate if you're deciding to use it. Still, it is better than radiofrequency, and still it is more effective because it allows you to map areas, multiple areas, but there is a risk of mechanical complications and there's a risk of AV block. And again, this is another report that described almost no complication from the jet, but again, you cannot bet your life on this. Now, the accessory pathway, again, very, very effective. And you can see here that even more effective than radiofrequency in some instances, probably because of the cryo-adhesion feature of cryoablation, because it sticks to the tissue and it creates durable lesion at that site. And again, the complication rate is very, very low, almost near zero. So in my conclusion, we believe, or at least in my belief, I believe that cryoablation is reasonable option, reasonable first-line option for pediatric population because it combines both safety and efficiency for pediatric population. Thank you very much.
Questions?
Availability recently, it's not that available. It is still more expensive than. It is this good, unfortunately. I mean, it is that good. The thing is that we've been using RF for a very long time. We've got significantly better with radio frequency. We've known where the problems come from, and we've got better and better in avoiding it. And yes, there are still conditions where the patient himself, I was just discussing with Dr. Husseini today about a patient who read about cryoablation and specifically requested to be treated with cryoablation for fear of any complications related to AV node. So yes, there will be conditions where you offer cryoablation. The only concern some of us have with cryoablation is potentially the risk of recurrence might be slightly higher. Okay. Now this is debatable. I mean, the more recent evidence does not support this conclusion, but the early stages with cryo, you had slightly higher recurrence than with radiofrequency. Probably because of the way it was used. Now we deliver more lesion, more booster lesion. It is not as, when you deliver cryoablation, you don't deliver it the same way as radiofrequency. You get a lot of booster regions in the region you are ablating. So I think with this approach, the recurrence rate are better. But yes, I would prefer it as a first line if I had this opportunity. Or Medtronic to be more sensible about their prices. Okay, thank you very much.
So we'll end this session.
Thank you, professors. I would like to invite you to a coffee break. Yes, thank you.
Seems like a lot. I don't know. So we got 16 patients. So let's see, 16.
Inshallah.
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 That would be all. Yeah. And I'll catch up with you guys.
Yeah, تعالى.
Sounds good.
I want to check in, but
You should go right now. You have time.
so I have give the next call. What I'm thinking is finishing this and then doing this and then we'll do that. Go for it. Get some rest.
معايا تقريبا معايا او ابعته لك على الفيسبوك هاتي رقم هاتي رقم
Huh? Yeah, yeah. He seems like the
By the time we left, that was fine. I think that was so good. That felt so good.
Good afternoon. May the chairpersons join, please. ما يا دكتور؟ ما انا عارف، ما انا بتكلم في كده. لا يا دكتور رانيا، حضرتك مش في السيشن.
مش بقول انا بقول لك
دكتوره رودينا بس برن عليها مش بتقول. هو دكتور شيء our chairperson and you will give a talk. Yeah, yeah. I will start the session. Yeah. انت هتبدا اول حاجه بص يا فندم انت هتبدا على طول السيشن صح؟ بس عايز بس الناس تجوين بس برن عليها مش بترد.
طيب هنبدا؟ عايز تبدا؟ طيب اقفل المايك. مساء الخير. ان شاء الله هنبدا السيشن دي ودي سيشن نمبر 5. Please chairperson join. يلا.
نشتغل كل حاجة على المدفع.
شادي نخلة. أول presentation عندنا by Professor Shadi Nakhla, Professor of Electrophysiology, Cleveland Clinic. هيكلمنا عن ال utility of intracardiac echocardiography in EBI study. Please, Dr. Nakhla.
Thank you. Thank you. Thank you. So over the next few minutes, I want to go through the use of intracardiac echo in the EP lab. So I use intracardiac echo a lot. It's one of my favorite tools in the EP lab because, 3D mapping systems use a lot of assumptions and data from the tip of the catheter to understand where the catheter is. But intracardiac echo is the reality. It's exactly what's going on. And to be able to understand how to take advantage of the tool in our toolbox, it's important to understand how the catheter works, the catheter function, to understand what we're looking at, so the anatomy, but then also understand what the clinical applications are where using an ICE catheter can be useful. And so first we'll start with catheter function. And the most basic of all catheter functions, like everything in EP and in interventional cardiology, is rotation. So clockwise and counterclockwise rotation. And frequently we use this to resolve anterior and posterior structures or rightward and leftward structures when the catheter is in the right atrium. Next, we have three main knobs on the catheter. One that causes posterior and anterior tilt of the catheter, rightward, leftward, as well as a lock feature.
Now turn the AAM.
Generally speaking, when I'm using an ICE catheter, I do not use the lock feature.
Lock all the way on.
I just rotate or apply
Now turn the AAM.
rightward, leftward, or AP deflection on the catheter. But very rarely, like during transeptal puncture, I might use the lock feature to keep something in view. So now that we understand what the catheter looks like and how it functions, it's important to understand the screen and what we're actually seeing. And so the very top of this triangle, the very top of the ultrasound image, is exactly where the catheter tip is. And usually on most ultrasound catheter manufacturer screens, there's a small logo that's either on the top left or the top right of the image. And this small logo tells you where the shaft of the catheter is. And so when this logo is on the left side of the screen, it tells you that the shaft of the catheter is out here towards the groin. And the tip of the ICE catheter is here. And so if the tip of the catheter is here, and the shaft of the catheter is here, it follows that the top right corner of the screen is the small space within the heart that is in front of the catheter. And what that means is that if the space is black, echolucent, it means there's no tissue there, and it means that you can advance the catheter safely. Okay? If there's white, or if there's a white color in that area, then it tells you that there's tissue there, and you probably can't safely advance your catheter. So I use it sort of like a surrogate for contact force. Again, this is important and will come up later as we start thinking about advanced views using the ICE catheter. And so first, we'll look at some anatomy. This is what the ICE catheter image looks like when you advance it through the left femoral vein. The tip of the ICE catheter is right here. The top right corner is black, and that means that there's no tissue touching the catheter, and so you're free to advance the catheter within the femoral venous to the iliac venous system without fear that you might cause a puncture. As you continue to make your journey up the femoral vein to the iliacs, we start going into the IVC, and then the IVC transitions into the right atrium. And you keep rotating the catheter clockwise or counterclockwise to keep every lumen that you're in open. Once you make it to the right atrium, this is our home view. Again, the tip of the catheter is right here in the right atrium. This is the right ventricle, and here on the far right of the screen is the right ventricular outflow tract, and this is the tricuspid valve leaflets. With some mild clockwise rotation of the catheter, you're able to introduce a few more anatomic regions into view. So again, right atrium, tricuspid valve leaflets, right ventricle, RVOT, and the aortic valve in long axis. As you continue to clock from here, the tricuspid valve disappears and you start seeing the coronary sinus and the interatrial septum. So again, with clockwise rotation, we start seeing the coronary sinus, the interatrial septum, and the left atrium with the left atrial appendage all the way out here in the far field. Okay? Again, with a little bit more clockwise rotation from the same view, we start seeing the left-sided pulmonary veins. And so here's the left superior pulmonary vein and the left inferior pulmonary vein, the posterior wall and the roof of the left atrium. Again, with some more clockwise rotation, we start resolving the right inferior pulmonary vein, and it becomes difficult to see the right superior pulmonary vein. And so to see the right superior pulmonary vein, we apply some posterior tilt to the catheter that allows you to then resolve the antrum of the right-sided superior pulmonary vein. And so this is a brief tour of atrial structures with the ICE catheter in the right atrium. And it's important at the start of any case, when you have an ICE catheter in the right atrium, to take note. Okay, what's my pulmonary vein anatomy? Is there pericardial fluid at baseline? What's my best acoustic window to visualize the structures of interest that I'm about to do an ablation on? And always save images on the machine so that you can compare to later. With the slightest amount of hypotension, you'll scan quickly to make sure that you don't have an effusion. And if you have a small amount of fluid, you can compare it to your baseline images. And so I'm very, very methodical about saving and capturing images as the case goes on in case you have some unexpected hypotension and so on. So you might say, okay, I've mastered the atrium. I now have a good sense for what atrial structures look like, but the ventricle is really, really cool, and I've seen better ICE images on Twitter in the ventricle. And so how do you get the catheter into the right ventricle to be able to use that as a vantage point for the left ventricle? And if we use the same principle that the tip here of the screen is the tip of the catheter, and the top right of the screen needs to be free for me to advance the catheter, then what I do is I bring the tricuspid valve into view. I add anterior flexion on the catheter, and I advance. And then you see that the catheter tip right here now finally crosses the tricuspid valve leaflets, and this gives us a vantage point of the right ventricle. And so here we see the right ventricular free wall, and coming in and out of view are the tricuspid valve apparatus with a tricuspid valve PAP and the chordal apparatus of the tricuspid valve. As we start to clockwise rotate the catheter further, we start seeing the left ventricle open up. I'm going to let this play one more time. When we clock from the RV into the LV, the first set of papillary muscles we see inferiorly here is the posterior medial PAP. With more clockwise rotation, we start seeing the anterolateral PAP and its two heads with really excellent resolution. And so for me, doing a PAP muscle PVC ablation if I don't have ice, I frankly wouldn't be able to do the case. I've become so dependent on using the ice catheter to visualize these anatomic structures, to be able to place the ablation catheter on the tip of the pap muscle head. For me, this is, it's extremely important. Again, with some more clockwise rotation, we start to resolve the aortic valve. In this view here, the ice catheter tip, again, is in the right ventricular between the inflow and the outflow. And so the cusp that's closest to the ice catheter tip will always be the right coronary cusp. And then the cusp that's closest to the left atrium, which is here, is the non-coronary cusp. And then here is the left coronary cusp. And in this patient, you can briefly see the left main coming out of the left coronary cusp right there. In the far field, you can see the left atrial appendage right here, and the tip of the Coumadin ridge right there, and the left superior pulmonary vein just behind it. And so now we have a sense for the anatomy. How do we leverage the ice catheter and the anatomy to help us with clinical applications? And so for me, one of the most important clinical applications other than transeptal puncture is being able to adjudicate the interface between the tissue and the catheter. So here is a very common ablation that we do in EP. It's a CTI line that's being delivered for typical right atrial flutter, and you can see the tip of the catheter just along the annular aspect of the CTI line, right around the tricuspid valve annulus. This can be an area that's difficult to get stability in, difficult to get contact in, and so with the ice catheter, I can see that my catheter is very stable, delivering ablation along the annular aspect of the line. This is a patient of mine where we were doing a papillary muscle PVC ablation at the posterior medial papillary muscle, and you can see that the PVC was coming from the tip of the muscle, and that the area where we have our ablation catheter is turning white as it becomes more edematous from RF ablation. This is another patient who had a PA type outflow tract PVC, and you can see in the fluoroscopy that the catheter is looped backwards and tucked right behind the pulmonic valve leaflet. And without ice, I wouldn't be able to adjudicate the fact that the tip of the ice catheter, the tip of the ablation catheter is tucked right behind the pulmonic valve leaflet. This is a different patient who had a post-surgical right atrial appendage, atrial tachycardia from the cannulation site. And here you can see a deflectable sheath, and then the ablation catheter all the way out in the tip of the right atrial appendage. And again, without the ice catheter, it would be very difficult to visualize the interface between the catheter and the tissue. And so the other part is using ice in very, very specific device implant procedures that are difficult. This is not a common use, but just something that we've been using every now and then. And so this is a patient of mine who's 77, who had a prior coronary artery bypass graft. He has a left bundle branch block and an ejection fraction of 15%, and he presented to my clinic for a CRT implant. And so this is his chest x-ray, and this is during a right arm contrast injection. Can anyone tell me what the condition is that we're dealing with? And there's a wire that's going down from the left subclavian. So he has a persistent left SVC. And you can see here that the contrast coming in from the right arm crosses over to the left-sided SVC. There's no right-sided SVC, and there's no bridging vein. And so this is actually a very uncommon scenario with persistent left SVC cases. Now, has anyone tried to put a CRT in a persistent left SVC case? Yes? Yes, and what was your experience? What was your experience implanting the CS lead in a patient with persistent left?
Oh, CS lead, pacemaker.
The CS lead.
CS I've tried once, it was heavy.
Yeah. So the problem that we experience with these patients is that their coronary sinuses are severely dilated. It's impossible to do a balloon contrast injection that sufficiently fills the CS for you to see branches. And so I thought, okay, what am I going to do? His creatinine was elevated. I didn't want to keep giving him more and more contrast. And so what I did is I actually advanced an ice catheter from the pocket using one of the other accesses that I had. And what I was able to find is the ostium of a coronary vein from the coronary sinus. And here you can see it's slightly more elongated. And once I identified that branch, I was able to selectively cannulate it with a CS catheter, and we were able to implant a lead at that location. Here, the red arrow shows where the ICE catheter tip, and it's inserted from the pocket superiorly. And this patient ended up getting this sort of a system for CRT. So again, a very rare utilization for ICE, but it goes to show you that beyond just ablation, there is utility for using intracardiac echocardiography. And so in summary, for me, taking advantage of the ICE catheter is really important. It's important to understand how the catheter functions and how to interpret the information that's on the screen, to understand the anatomy that we're looking at, and being able to use it in specific clinical applications, particularly to guide catheter tissue interface and transeptal puncture. Thank you.
Thank you, Dr. Shady. Any questions?
Thank you, Dr. Shady. Do you think intracardiac is really superior to TEE? How much superior?
So
because you have more invasive procedures, you have more material inside the heart.
That's a great question. I think that intracardiac echo for intraprocedural guidance, particularly for ablation, is more superior to TEE because of my ability to guide and manipulate the images myself. For diagnostic purposes, I think ICE catheters have no role. For non-invasive diagnostics of valve disease, function, whatever it may be, I think that the ICE catheter has no role and TEE is extremely superior. The other reason why TEE is superior is your ability to biplane certain anatomic structures and 3D reconstruct certain anatomic structures, and the current common use of 2D ICE catheters can't really do that. And so within limitation, I think for live procedural guidance in EP, I think ICE is superior, but anything else, I agree with you, TEE, image quality and the ability to manipulate the images is superior.
So you won't tell me that ICE is superior in intervention, electrophysiology, of course. Would it affect the outcome? It have a better outcome, or there is no difference?
Compared to TEE?
Yes.
Or in general?
So compared to TEE.
I think with interventional procedures like transcatheter valves, for instance, I think TEE is still superior, for sure.
Sure.
But again, for the purpose of EP, ICE, for sure. Yeah.
Thank you.
Yeah, I would like to just have a small comment, Dr. Shady.
Yeah.
Maybe like in 2008, we were trying a car-to-sound catheter in Cleveland.
Yeah.
And we did a 3D reconstruction. And I don't know where are those catheters anymore because we don't do any reconstruction in cardiac mapping in EP using the ICE. But at that time, I thought it would be a boom. But it didn't go anywhere. But again, I see it reviving again, especially in the ventricular cases. So what's your take about that?
Yeah, so I use CardioSound for all of my cardio cases. Okay. And they integrate the anatomy from the ultrasound into the 3D map. And they have some new AI modules that allow you to just take 15, 20 slices of, for example, the left atrium, and it reconstructs a full 3D anatomic map of the left atrium that you can then build upon with your mapping catheter. For me, what I use the CardioSound module for the most is they actually have the ability to display your catheter tip with color on the ultrasound map. And so that for me is the most definitive way that you know what you're touching. And so for example, if I'm doing an ablation for a PVC that's coming from the cusp or from the pap muscle, I can definitively tell you where the tip of my ICE catheter is, more so than the assumptions of a 3D mapping system. Yeah. And so I would say they probably didn't make a boom, the introduction of these catheters, but we use them all the time.
Yeah, but no further modification for a 4D. I mean, the problem is with the diastolic images.
Yeah.
But is there any possibility or in the horizon
for
systolic and diastolic images in a 3D.
So they only,
Let's 4D.
Yeah, so with 4D, their newest iteration of catheters aren't fully integrated with sound.
Okay.
So they're integrated with cardo, but not with sound. So you can't acquire anatomy from them. They have a software update that's going to show that. But they do have a 4D ICE catheter that's fully integrated with the mapping system, but just not sound enabled yet.
Okay.
And then depending on the cardiac structure that you're trying to highlight or introduce into your 3D map, you'll pick whether to highlight it during systole or diastole. But accounting for both is difficult. But you can scroll through a rhythm strip to decide where you want to acquire your image.
Okay.
Yeah.
Yeah, exactly like the 3D mapping.
Like usual, yeah, exactly. End expiratory or end systole, exactly.
Thank you so much.
Thank you. Yeah, thank you.
Now the next speaker is Professor Akram Amer. He's a consultant in Al-Nas Hospital, and he's going to talk about ultrasound-guided vascular access. This is a very important subject for both pediatrics and adults.
Assalamu alaikum. Thank you to be in this valuable conference. It's an honor to me. I will speak about basics of ultrasound-guided vascular access. I'm Dr. Akram Amer, consultant anesthesiologist in Nas Hospital. My objective in this topic, how to prepare ultrasound-guided technique, some knowledge, practical knowledge, to do safe ultrasound-guided vascular access, and what's the basics of scanning and needle techniques, and what's the common problem and troubleshooting, and also common approaches. Ultrasound give a lot of advantage, direct visualization, no blind techniques. You can see anatomical variation, decrease the risk of complication. You see what you do. And it is a dynamic, which is safe teaching tool, and also decrease the time and latency. First, you have to prepare yourself. First, prepare the patient, assess your patient, assess consultation, preparation, consent. Then prepare your equipment. Which probe you will use, equipment, needles, and so. And you have to some technical guidelines, ensure aseptic technique for sure. If patient is awake or not anesthetized, you have to give local anesthesia. And you have to monitor your patient, at least ECG, pulse oximeter, and non-invasive blood pressure. Essential or practical knowledge for understanding machine knobs is essential to do safe ultrasound-guided technique. All machines share the same operative features, the basic features. You have to know to do vascular access safely, the frequency, the gain, the depth, the focus, and the time gain compensation, color Doppler, and pulse wave Doppler. You have to be familiar with your machine before starting your technique. First knob, you have to know frequency and the probe selection. High frequency probe, less penetration. You can see superficial structures, and unlike low frequency probes, usually see deeper structure. Usually in vascular access, we use linear probe with high frequency. Penetration is superficial penetration, usually 3 to 4 centimeter, and you can see your vessel easily. The types of probes, as you know all, linear and curvilinear and phased array. There is usually there is a button to change the transducers. This is a commonest type. Usually for vascular access, we're using the linear one. And for tiny neonates and tiny infants, the hockey stick probe is valuable. Also, probe orientation is very important. You have to put what in the right of the patient to be on the right on the screen, and vice versa. So every probe, usually there is a groove or a notch, and this is on the same side. You have to put it and this icon like this. Sorry. Like this. Okay. Gain and time gain compensation. The gain, how bright your image, increase the gain, make the the screen more bright, and decrease the gain, make the image more dark. For time gain compensation, this one, this adjusts the superficial and deep gain in your screen. Okay, so the button for gain will increase whole screen brightness and or decrease, but if you want to change superficial brightness or deep, you have to use time gain compensation, this one. For optimal gain, you have to see clearly your vessels or your target, and you can differentiate from surrounding structure. Excessive gain will make blurred or loss of the picture or good picture, like this. If you can see here, I can see the vessels clearly and the boundaries of the vessels so clearly, but here it is more bright and this too much gain, so you cannot see the boundaries of the vessels. And here, this is too little gain, so the dark image, and you cannot see your structure clearly. For time gain compensation, it will allow you to see two structures behind each other clearly. If you want to see this and this, you can just adjust the gain, so see both clearly. Depth is important. You have to put your target inside the screen. Like this. This is auxiliary vessels. You can see, and no excessive structure behind, but this is excessive depth. You cannot see the target small, or you can see the target small, and there is a lot of tissue behind the target you will not use. And here, this is less depth, and the target is not clearly visualized. So you have to adjust your depth also. The focus is makes the ultrasound beams concentrated in your target, so you can differentiate two adjacent structures. This improves the lateral resolution. Focus usually presented here in the side of the screen by small arrow, and you have to put this arrow at the level of the target structure by the button for focus. Here, as you can see here, the focus is higher in the screen, so you cannot see the structure clearly, and here away from the structure. This is not proper focus. Color and pulse wave Doppler to differentiate vessels. Usually use it to differentiate artery from vein. As you know, the ultrasound emit stationary waves and strike moving RBCs. When reflected back to the transducer, it will received by another frequency. If the blood moving away from transducer, it will appear blue, and blood moving toward the transducer, it will appear red, like this. You can differentiate. No need to know the color. Just see the pulsatile of pulsation of the color. If you can see the pulsation, like here, appear and disappear, it will be artery. But continuously, like here, it will be vein. Or use pulse wave Doppler. Pulse wave Doppler inside the artery, it will give pulsatile waves, but inside the vein, it will give continuous waves. You have to do pre-procedural scanning to optimize the anatomy. Choose appropriate transducer. If you are using or you scanning for neonate or small baby, choose the hockey stick one. So see the anatomical variation and anatomical relationship, and you can use some movement to improve your picture. And this is summarized in this mnemonic part. B, to apply some pressure or to decrease the pressure. Usually applying too much pressure, it will compress and close the vessels. Align, you have to align and search for your vessel. And you can fine tuning with rotation or tilting, like this picture. And this fine tuning, it will improve your ultrasound scanning. Scanning technique, we have two scanning technique, either short axis or transverse scan. And the ultrasound will cut the vessels in long axis. It will be the beams of ultrasound will be perpendicular to the long axis of the vessels. And the long axis scan or longitudinal scan, the beams of ultrasound will be parallel to the vessels. Like here, this is transverse scan or short axis, and this is longitudinal scans for the internal jugular or carotid vessels. And here, short axis scan, the vessel will appear as a round structure, but in long axis scan, it will appear as a tube. Needle probe interface, you have two needling probe interface, in plane and out of plane. For in plane, you will go in the path of the ultrasound beams like this, and the needle will be passed through the whole beams, and you can see the whole needle, all the needle and shaft and tip you can see. And out of plane technique, here the needle will go perpendicular to the ultrasound beams, and you only can see the needle tip. You cannot see the whole needle. To optimize your needle imaging, you have used shallow angle in case of in-plane technique. When you go in-plane, like this figure, if you go by steep angle, a lot of ultrasound beams will not reflect it back to the transducer, and you cannot see clearly the needle. So if you can use a shallow angle, so all beams will return it back to the transducer and you can see it clearly. Sometimes due to anatomical obstacles, you can do it easily. If you can heal like this, the transducer, just tell transducer to see the needle. Rotation and tilting is very important. Use echogenic needles. Actually, our needles using for vascular access all are echogenic. Hydrodissection, you can inject very small amount of saline to see where you are if you cannot see the needle tip, but take care not inject a lot because it will disturb the anatomy. For safe needle guidance, you have to perform a pre-procedural scan. Use color Doppler to identify the vessel. Don't advance if you cannot see the needle tip. Hydrodissection, but take care just very small amount. Optimize your position and the patient position. You can see here, you are tilted a lot and you cannot see what you do. But here, ultrasound machine in front of you, you can easily do your technique. If you cannot see the needle, don't advance. Try to optimize your view. Here a video. This is the internal jugular vein, and using out of plane technique, we'll insert the needle now and try to search for the needle tip. Here the needle tip is here, yes. And now it is piercing the vessel. Yes, and searching the tip. And this is a longitudinal scan to see the guide wire. Here's the guide wire. Okay, this is out of plane, and this is in plane. Here, out of plane, you can only see the needle tip, but in plane, you can see the whole needle. Here, out of plane, when you make some tilting, you can see the tip clearly. There are some artifacts affecting your picture. You have to know it. The major ultrasound artifact, acoustic shadowing. This is if there is a bone. Behind the bone, there is acoustic shadowing, a black area. You cannot see anything. And there is enhancement. Behind the vessel, usually this is a whitish color structure. This is not a structure, don't worry. And if you use a needle, you can see these reverberation artifacts, repetition of the photo. When you see this one during out-of-plane technique, that means you are seeing not the tip, you are seeing the shaft. Different approach, we have internal jugular and subclavian and femoral. These are the commonest approaches for us, either oblique, out of plane, in plane, like this, in plane technique. And you have to see the guide wire. For subclavian, usual ultrasound is difficult infraclavicular, so you can use supraclavicular approach in plane. And the femoral, usually using out of plane technique, and take care sometimes the vein behind the artery. Don't advance when you cannot see the tip. Thank you. Any questions?
لا مش اريزميا ان شاء الله.
It's my pleasure to introduce Dr. Al-Hussein Ahmed. He's going to introduce the title, lecture title TE for EPS. Please.
All right, good afternoon. Nice to see you again. So we will discuss today about the TE utility in pediatric electrophysiological studies. Actually, I have none of conflict of interest. Well, first of all, I want to discuss the impact of fluoroscopy on pediatric age group. Actually, there is an increased cancer risk associated with radiation exposure at doses levels that can be received by any a child going into cardiac catheterization. Actually, cardiac catheterization in complex congenital heart disease might be lengthy with excessive exposure. Actually, the fluoroscopy risk depends on the duration, the type of the procedure, actually the machines that you are using for imaging, and the complexity of the anatomy. Actually, you might say that arrhythmias doesn't allow for much radiation exposure, but actually atrial tachycardias, AVNRT and AVRT, actually the procedure time totally might expose the patient to more than 220 X-rays. This is in a child. So actually, to minimize fluorodoses, actually we can use intracardiac echo and 3D mapping system. Actually, this can shift the procedure to a zero fluoro procedure with no radiation risk. However, in a limited setup like us or a smaller child with IF catheters poses a great risk of vascular damage, attempt at reducing the fluoroscopy times is highly recommended. Utilizing transesophageal echo is available in majority of pediatric cath labs and can give the benefit of guiding multiple steps during the ablation procedure and reducing fluoroscopy time. So we can very simply, as Shadi discussed earlier, we can see the catheter position in complex congenital cardiac disease, such as Epstein anomaly, identify the presence of intracardiac shunt, guide the cannulation of the coronary sinus, especially in isomeric patients, and guide transeptal access to the left atrium. We have a lot of arrays for pediatrics. 1, C, and D actually are designed for pediatric population. They are, first of all, they were 2 planes, and now there is multi-planar TE for children. Mic. actually that can be used up to 5 kilograms of weight. So this is a very simple example of coronary sinus cannulation in a patient with dextrocardia. Actually, he's a Cartagner syndrome. This is a very simple fluoroscopic images in fixed images. This is a CS. This is a tricuspid valve, the right atrium, the right ventricle. So this is a video of the patient. Actually, this patient is dextrocardic. So actually, we rotated the entire angle to 180. And this is while we are identifying his coronary sinus. We can see that this is his coronary sinus. Sorry. So this is while we are cannulating the coronary sinus. And this is just for confirmation of cannulation. Actually, exclusion of blood clots. This is a patient who is just exploring his left atrial appendix. It's completely clear out of any clots prior to intervention. Actually, to guide transseptal access, this is very important as it reduces the flow time exponentially. Actually, this is why we are trying to position the needle into the interatrial septum. We are advancing the needle. And here we are piercing the septum. And then the needle and the sheath went up to the left atrium. Actually, in older children, we can use real-time 3D echo images like this. This is actually this is the 3D reconstructed images in lifetime, and this is the sheath going into the left side atrium, and this is the right atrium, and this is the aortic valve. So you can see that you are in a safe position. Assess cath stability and position. Actually, this patient was an epistein anomaly, and we had a lot of problems stabilizing the catheter, even when in 3D. So we decided to go for transesophageal echo and start to manipulate the catheter until we get a good signal and a good stable position. Actually, this is now prior to ablation. This is while we are ablating. The spontaneous contrast that's happening is that we are using an irrigated catheter tip. So this is saline bubbles coming out of the catheter to reduce the temperature and make it safe procedure. Actually, to sum up, attempt at fluoro reduction or zero fluoro strategy should be attempted in every pediatric population patient during the ablation procedure. However, we have a very limited resource setup. We have small children going now up in ablation, so we cannot use IF catheters. And even if we have it, we will preserve it for patients with ventricular tachycardia, things like that, which we don't see a lot in SVTs. We don't see VTs a lot in children. So TEE might be good, acceptable, and easy to achieve utility to decrease fluoroscopy times. The main problem here is that if you want to do it in a 3D mode, you need a child that's more than 25 kilograms. I think now GE developed a new probe that's called the 9VT 3D probe. This can work up to 5 kilograms, but it's very expensive and not available in Egypt. It was a very short presentation. Thank you.
Thank you so much, Dr. Hosseini. Any question from the audience?
I have a suggestion for the next time, just to pick two cases, the same diagnosis, the same criteria, the same intervention. Do one with ICE and one with TE, then compare together live, and we can see the outcome.
A debate.
Yes.
هو صراحة الحمد لله احنا عندنا very advanced cath lab. الحمد لله we have a lot of toys that we can work with. بس اوكي بس ان شاء الله ان شاء الله بكرة بإذن الله.
مش سؤال، هو بس يعني حاجة كده انا طرقت في دماغي. هل لو احنا قارنا ما بين الايس وما بين التي اي regarding the stressful conditions اللي هي added على الاوبريتور، لان في another colleague بيشتغل تي اي حضرتك you are shouting and screaming for him، انت خلاص هو اللي هياخد كل الحاجات. انما في الايس I'm the operator، انا اللي بعمل كل حاجه. فايتس time consumer او more stressful conditions I don't know حاجه، بس يعني ما فكرت فيهم الكومباريزون ما بينهم للغاند ستريس والتايم كونسيومينج.
هو طبعا التي اي definitely time consuming، بس هو actually دلوقتي في اوبشنز ان انت تبروجكت التي اي ايمج اون ذا فلوروسكوبي وهو شغال، فهو بيبقى قادر يبص على التي اي قدام.
The second operator.
We almost always have two operators, so we have no problem. أنا second operator دايما. Yeah, exactly.
With the ice, you can be frustrated over the fellow. That's not the thing. And yeah, that's right.
You don't need a reason.
My question is there, what is the least ice catheter French? I mean, can we put an 8.5?
8 Frenchies, yeah.
Through a 9.
Yeah, it's
So can
8
we
French,
put,
that's right.
But it has to be 5 kilograms for.
No, yeah, 8 French cheeses. I think it needs a bigger child, around 15 kilograms or 20.
So
It's definitely a limitation,
that's
yeah.
where the comparison
For sure.
comes.
Yeah, definitely
Because,
limitation.
The
Smaller
50
child.
rope for 5 kilograms.
Yeah, it's for 3D echo, but not for.
No, you're right. I think for most of the limitations we have for electively taking somebody to the EP lab, as far as size is 15 kilos. Studies have shown that kids that are less than that have higher risk of vascular complications. So they're usually going to be at the age where you can get an ice catheter in if you need to.
Okay, thank you so much. We'll close this session and I invite the chairperson for the next session. Thank you so much.
برضه مش هجيب لك الفورمز بتاعي برضه مش هجيبه لك.
لا صليت الظهر فضل العصر اي حاجه.
اخلص المايك التاني.
لا لذيذ يا حسين عشان بتخلص بسرعه. كلمه ورد غطاها. كلمه ورد غطاها.
لا ودي ان شاء الله تبقى نفس الفكره.
مساء الخير. احنا دلوقتي مع محاضره مع واحد ما قالش اي محاضره النهارده خالص، مع دكتور الحسين احمد. دي اخر محاضره
ان شاء الله.
لو المايك فصل مش هتكملها.
بالظبط كده.
اتفضل يا احمد. محاضرة بعنوان ايفابرادين in pediatric population. الحقيقة يعني الدواء ده على مدار السنتين اللي فاتوا كان يعني مصدر ديسكشن وريسيرش كتير عندنا في الوحدة في أبو ريش، فحسين هيقول لنا بقى الاكسبيرينس بتاعتنا كلنا. شكرا.
بالظبط، ما هو ان شاء الله تخلص كده ان شاء الله. طيب احنا هنتكلم دلوقتي عن الايفابرادين in pediatric population. طيب اول حاجه الكونفليكت اوف انترست still I do not have anything for regarding evabrudine. So first of all, back to basics. We will discuss the hyperpolarization activated cyclic nucleotide gated channels. Simply, they are pore channels that are voltage gated, allow passage of sodium and potassium, and to a lesser extent calcium. Those channels are actually comes in 4 subunits. Each subunit have a 6 tetramer, and the fourth one of them is actually a sensor for voltage. These channels are extensively expressed in our bodies, but actually type 4 is the main one that expressed in the sinoatrial node and the cardiac tissues, to a lesser extent HCN1 and HCN2. Actually, the current through the HCN channels is now called the pacemaker current or the funny current, which play a key role in the generation and the modulation of cardiac rhythmicity, as they are responsible for spontaneous depolarization and the pacemaker action potential in the heart. Evabrudine is the only available pure inhibitor of HCN4 employed in the regulation of heart rate. Actually, it has something called use dependence, means that if your heart rate is higher, it will be more efficient. Additionally, this is the main or the core benefit from it. Evabrudine has no negative inotropic effect, nor positive inotropic effect. It has no effect on the inotropicity, rather than, and it has no effect on the vascular resistance in the body. Actually, it has been a work from 2005 with 3 major clinical trials. The first one is called Beautiful, the second is Shift, and finally Signifies. This actually, after that, it gained in 2015 an approval from the US FDA for stable patients with cardiomyopathy, with heart failure, with reduced ejection fraction, and the heart rate above 70. From this point, it has been the target for many studies and reviews for off-label use and for management of automatic tachycardias, either as a single agent or an adjuvant agent. These are just the pediatric cases, actually case series, case reports, retrospective studies, and only one randomized open-label controlled trials that we will discuss shortly. So evabrudine in pediatric arrhythmias, either in post-operative arrhythmias or native automatic tachycardias. First of all, with post-operative arrhythmias, actually with junctional ectopic tachycardia. This is the most common and the most troublesome post-operative tachyarrhythmias in children. Actually, it happens in 5 to 10% of the post-operative cardiac patients. I think Dr. Osama discussed the usefulness of atrial AKG in these patients. Well, they have a very simple triangle: sedate and analgesia, modest hypothermia, correct your electrolytes, adjust your vasoactive materials, and then pharmacotherapy and using DDD pacing. If all this failed and the patient is hemodynamically unstable, you go for mechanical circulatory support. All antiarrhythmics, unfortunately, apart from evabrudine, are myocardial suppressants. And in post-operative arrhythmias, we will need them on a necessary evil base. All antiarrhythmics were assessed actually for JET, but many centers present treatment algorithms based on a published literature. Amiodarone is still a negative inotrope, but this is the most one to be used during this tachycardia. Till this evabrudine versus amiodarone management of post-operative junctional ectopic tachycardia, this is an open-label randomized controlled trial. Actually, I think it was held in India on 94 patients with age less than 18 years old. Actually, they used evabrudine, oral evabrudine via intraroute versus an IV amiodarone, and they show non-inferiority. Actually, both of them made the patient resume sinus rhythm, but actually the amiodarone limb reached rate control faster than the evabrudine limb. Actually, one of this study limitation is that they didn't use IV evabrudine because it is not available at their center. However, they used the dose. Actually, I think this will be interesting for pediatricians. Evabrudine was administered via intraroute in a dose of 0.1 milligram per kg every 12 hours. And if failed, you go for the second day and you discuss if the patient is hemodynamically stable, you can go for up titrate the dose. If the patient is hemodynamically unstable, you might revise your entire algorithm for treatment. So in management of native arrhythmias, Actually, it was used extensively in the last 3 years for focal atrial tachycardia. Actually, they are a rare cause of tachyarrhythmias, but actually they cause a very problematic incidence, which is the tachycardiomyopathy. They are incessant arrhythmias. Usually the patient doesn't present suddenly. It presents with a very strange presentations, feeding difficulty, vomiting, rapidly breathing, and pictures suggesting of congestive heart failure. To date, the sole effective treatment for focal atrial tachycardia is CAS ablation. However, it may not be applicable to all patients, particularly in the acute settings. Actually, this is a case report where there is reversal of tachycardiomyopathy from the left atrium via ivabradine. Actually, this patient had, once rates controlled, there is increase in the ejection fraction from 40 to 60% after just 1 month of treatment. Actually, this is a very larger sample. Actually, from this study, patients, pediatric patients less than 50 kilograms received still 0.28 milligram per kg ivabradine. Actually, from ammonium therapy. Sorry. Just a moment. Actually, the study started with 71 patients. Only 28 patients fulfilled the entire criteria that they are having a focal atrial tachycardia with a structurally normal heart. Actually, from those 28 patients, 15 was children. Oral ivabradine started. The ivabradine responder were 18 of 28 patients. From this 18, around 11 was pediatric. So this, until CAS ablation, showed very significant results. So what about ventricular arrhythmias? Actually, it's not extensively studied, but there is a case report of a patient with CPVT that was on nadolol, flecainide, and did sympathectomy, and this failed to control his CPVT, and just with administration of ivabradine with beta blocker with the nadolol, the patient had exhibited a little bit of control, and the ICD didn't show any shocks. So what about ivabradine in the guidelines? Actually, it is now stated in the guidelines in inappropriate sinus tachycardia as a class 2B. And in focal atrial tachycardia, it is used, but with beta blockers and after failure of all other medical therapies. So to sum up, ivabradine appears safe and effective in many automatic tachycardias, appealing to physicians and with very minimal side effects. However, its extended off-label use require excessive trials so as to assess its true potentiality and management of such significant arrhythmias. per kg per dose كل 12 ساعة. هو ال 0.2. 0.2. No. This is a maximum tolerated dose.
It's safe to use a combination of beta blockers with the ivabradine.
Yeah, all the literature recommending them.
This is better. Better combination gives you excellent results.
We use it in focal atrial tachycardia in neonatal period. Yeah, we started to use it this year extensively. Yeah, I know, but in neonates we give it simply. مش fetal. I know.
FDA approval من سن سنتين. من 2019 واخد FDA approval في النيونيتس بس.
لكن مش pregnancy to convert to fetal arrhythmia. لا هو contraindicated. هو contraindicated في pregnancy. بالظبط.
في الانابروبريت ساينس تاكيكارديا. ممكن الاثنين يعني دايما ساعات يستخدموا.
ممكن افابرادين سول ايفنت او بيتا بلوكر. بروبرانولول هو اللي افيلابل عندنا في مصر. From 2015. هو got FDA approval for use from 2015, but actually, yeah. Yeah. significant bradycardia sometimes induce significant sinus bradycardia. Actually, one of the problems with the CPVT case is that it most probably inhibited the ventricular repolarization, but actually the sinus bradycardia that it induced actually might induce the CPVT, might exacerbate it. Yeah, but in arrhythmias, it's not. In arrhythmias, gain a lot of experience from 2019, the EHRA consensus guideline for SVT.
But I mean, in heart failure guideline, its rule is coming down.
Down, yeah.
So just I want to add something that ivabradine we use it now in post-operative junctional ectopic tachycardia, and it gets very promising results. Usually we use it in addition to amiodarone, so we can use a low-dose amiodarone beside the ivabradine, and it's very effective. Usually we use it we started to use it after 6 months of life, but now we use it even with the first month or second month of life. It's very safe. We use it with a started dose with 0.05 milligram and increase up to 0.2 milligram per kg per dose, but gradual increase.
نستخدمه في الاوت بيشنت، يعني البيشنت اللي هو dilated cardiomyopathy من غير ما يكون admitted في المستشفى ولا نتابع ضغطه بعدها.
Usually you start with a very low dose and then come just follow a patient after 1 week or 2 weeks, and then you can increase after that after doing an ECG.
لو احنا عايزين نوقفه طيب ممكن نوقفه مرة واحدة ولا لازم weaning؟
No problem. You can stop. Yeah, exactly. Yeah.
I've used it for atrial tachycardias, and it's worked at first, and then I found that the bradycardia is a limiting step, so we'd had to stop it. Only a handful of times. I haven't used it for jet, and I think that is promising just because of all the problems with amiodarone.
Because jet is transient arrhythmias, and then we stop it after we return to sinus rhythm. Yeah.
Do you have procainamide?
No, we don't have. So we have to think about alternatives to procainamide because we don't have it.
انزل بقى يا حسين. خلاص نزلت. السيشن اللي جايه دكتوره الحسين احمد بدل دكتور عمرو نوار. السيشن اللي جايه دكتور عمرو نوار، سيشن بعنوان كارديو نيورو ابليشن.
Hello everyone, thanks for the kind invitation. I hope the audio video is working just fine. I thank all the organizers and congratulate them for the kind invitation. Today I will talk about this relatively new, promising effective therapy of reflex syncope. I will talk briefly today about regarding the rationale, indications, and gaps in evidence of this new technique. As any reflex, also reflex syncope, is constituted by receptors, an afferent branch, a central integration at the mid-stem level, and an afferent branch, and finally effectors. The receptors are somatic, visceral, emotional, and hemodynamic, mainly the baroreceptors located in the carotid sinus or in the aortic arch. The sympathetic effectors cause vasodilatation at the level of the lower limbs and the splanchnic region. The vagal branch effectors act on the heart, mainly on the SA node, and the less extent in the AV node. The target of the ablation on the ganglia of the heart is to counteract bradycardia and asystole caused by the vagal effect or the sinus node. and the AV node. In this way, it is CNA or cardiac pacing acts similarly on this mechanism of action on the reflex symptom. Both counteract the bradycardia. In particular, the two ganglia to target for ablation are the two groups, which one is close to the SA node and one close to the AV node. The first is the superior post-receptor ganglionic plexus for the SA node, and the inferior one is the infra-post-receptor ganglia for the AV node. The superior paraceptal ganglionic plexus is located close to the superior vena cava in the atrium septum, and close to the right superior pulmonary vein. The distance is very, very thin in this area. The inferior paraceptal ganglionic plexus is located close to the inferior vena cava on the back of the coronary sinus ostium, and close to the right inferior pulmonary vein ostium. This means that the ablation of this ganglia can be approached from the right, from the left, or from both sides. As you can see here, this is a diagram of the ganglion plexi and the associated nerve bundles on the level of the epicardium on mice heart. This is what the corresponding image that we obtained by electron anatomical mapping in the cath lab. You can see the superior ganglionic plexus, which is on the other side of the SA node, close to the SA node, few millimeters from the SA node, and you can see also the phrenic nerve and the inferior group, which is posterior to the coronary sinus ostium. The acute result consists of changes in the electrophysiological properties of the both AV node and the SA node. The acute success is usually generally successful as an increase in heart rate. For example, in this case, this 36-year-old male heart rate basically increased from 50 beats per minute to 74 beats per minute after ablation. Also decreasing the rate of Wenckebach. As you see before ablation, it was from 100 to 120 beats per minute after ablation. And decreasing also the AH interval from 95 to 76. So all these markers means that the vagal effect on the heart, SA node and AV node, is eliminated or decreased. There is today only one considerable or randomized control trial performed in Poland, which shows a great benefit by reducing syncopal recurrence at 2 years from 54% in the control group to 8% in the ablation group. You can see that these results are similar to the results obtained in the last years in the same randomized trial, including cardiac pacing. More or less, the same results. It's not surprising for me because since the two procedures have the same rationale and the same target, we expect that also the clinical result and benefit will be the same. How to identify the proper candidate for cardio-neuro ablation? Well, there are two most important tests. The first is the tilt-table tasting and the implantable loop recording, because both are able to document episodes of asystole reflex syncope. What is less known is the effect of the cardioneural ablation when a systolic syncope is not documented in patients with mixed forms or in patients with non-syncopal extrinsic sinus node dysfunction or AV nodal block. By sure, of course, it will not be performed in patients and should not be performed in patients with pure vasodilated depressive forms and in patients with intrinsic disease of the sinus node and AV node, because there is no rationale, of course, for the therapy. Tilt testing seems to be the best test to select in patients. Nevertheless, while in a systole, tilt responses predict a similar systolic response during the implantable loop recorder. So if there isn't a systolic response during tilt test, there is no need to confirm this with a loop recorder in majority of cases. The contrary is not true, because at least half of the mixed vasodepressor response during tilt-table testing have a systolic response with loop recorder. This means that we have to go, if we think that the patient is a good candidate for CNA, we cannot stop investigation after tilt table, but you have to go further, one step, 1 mile ahead with the implantable loop recorder, but because you have to document systolic. And this is what happens in one of such patients or spontaneous reflex syncope during ILR. You can see there is, again, for a few beats, decrease in sinus rate, followed by long pause of 25 seconds. So it is clear that the candidates must have an asystole, documented asystole, but this is not enough. We also want that the patient is severe enough to merit either a CNE intervention, CNE or pacemaker. So we have to define severity. And severity means that this decided primarily by the patient himself. The physician is not allowed to define the severity of the patient. As the patient should select what is decided. And so far, all the patients that choose cardioneural ablation, they're very grateful that they have been saved from a pacemaker and living a life which is free of syncope, as we'll see one patient example later in the presentation. And in general, the patient asks for therapy when syncope is so frequent to impair the quality of life, when absence of progress in the daily risk activities or the risk of trauma or high-risk occupational activities. This is one patient. She was 54 years old, female. As you can see, this is a baseline ECG, 37 of heart rate, and baseline just before the procedure. And that is a recording from the loop recorder showing a bradycardic response, an episode followed by a systole of 21 seconds. You can see that during ablation there is a considerable increase in heart rate. As you see, there's an immediate response during the procedure. And this is the ECG During the high-frequency vagal stimulation, you see on the left side, heart rate increases to 30 and even goes back to more than 30 beats and continues. And after ablation, during the high-frequency vagal stimulation, there is no effect on the basal heart rate. Usually the endpoints for, you should have an endpoint while doing the ablation. Usually there's persistent decrease in sinus rate, which does not decrease by high-frequency vagal stimulation. You can test the wink-back points. Some people use atropine pre and post, but usually we do the high-frequency vagal stimulation. And this is the ECG on the next day. As you see, heart rate increased from 37 to 81. And on the left side are the results of the loop recorder 8 months after the ablation, and you see there is 0 bradycardic events compared to 171 before the procedure. But you have to also to measure that reflex syncope is a benign condition, so the fact that cardioverter ablation is effective does mean that it is always necessary. And please consider that the natural history of the reflex syncope is characterized by a spontaneous decrease of recurrences just after the index visit. In this very good meta-analysis performed on 1,900 patients from 17 studies, patients had before the visit, the index visit, 2.6 syncopes per year. And after enrollment in the study, this is a control group. Without any specific treatment, syncope spontaneously decreased to 35.4%, had no recurrences after 1 year. And relative risk during reduction during this without therapy was 56%. There are several areas of uncertainty, of course, as any new therapy that require explanation in the future. How to perform ablation? We don't know whether to ablate only on the superior posteroceptal plexus, or also add the inferior group. We do not know whether to ablate from the right, the left, or the combined approach, right and left. It's center, different from one center to center, and the acute success is variable from one center to the other. We have uncertainty about the outcome because we don't know if there is a long-term efficacy, the reinnervation. The longest follow-up is 2 to 3 years, and it's likely that reinnervation can happen later, and the effect of cardioverter ablation decreases or disappears in the future. There is, of course, the obvious problem with the patient and physician expectations effect. This means that we need a randomized trial, and we need to have subgroup effects, for example, age or gender or other comorbidities. We don't know if it's effective in the young or the old. So there is a great space for future research that hopefully will be performed in the next years. What we can say today in 2024, we can give some advice. Advice of CNA is indicated to reduce recurrent syncope in adult patients aged less than 60 years with severe unpredictable recurrent cardioinhibitory syncope after proven failure of conventional therapies. We have spontaneous documented symptomatic asystolic pause more than 3 seconds or asymptomatic pause more than 6 seconds due to sinus arrest or AVNT block, or cardioinhibitory carotid sinus syndrome or systolic syncope during testing. May be appropriate to reduce syncopic recurrence in patients with clinical features of adenosine-sensitive syncope. There is no studies, but there is rationale for that, because the vasodepressor component is minor. CNA is, of course, not indicated in the presence of dominant vasodepressor component. If you are interested, to know more, to have a balanced opinion about the indications, the pros and cons of the technique, I invite you to have a look at this clinical controversy that has been published in the ESC. Thank you. Thank you very much for your attention, and I hope we have a space for questions and the online approach. Thank you.
It's my pleasure.
You guys haven't had any children. So we have some experience with adults and not much with children. I try to avoid this patient population personally. So one of my partners has taken on the lead with cardioneuroablation. The short-term results are really good. So most of these patients are very symptomatic before and have done well. I think the points that Dr. Amr emphasized about patient selection are key. So specifically patients that have very clear cardioinhibitory component as opposed to a vasodepressor. Yeah.
Their lifestyle that affect hurts from somebody. Patients, they're not very happy with their lifestyle maybe after the ablation.
So we've had some patients, there's been reports about patients that develop symptomatic inappropriate sinus tachycardia. And so those patients are likely unhappy and so on, but I'm not entirely sure if there's something other than that, but definitely we've seen heart rate increases that tend to become symptomatic.
You know, I'm very torn about putting pacemakers in children for things like this. Sometimes you have to do it, you know, for the breath holding spells where there's 30-second pauses, and it's consistent. That one example where we've been forced to put in a pacemaker in somebody who's young. But if this has promise in that patient population, we were just saying it's probably better than a pacemaker for somebody who's young.
Thank you.
Yeah.
Okay, I am so grateful for this kind of invitation. Congratulations to the organizing committee. And it's my honor to introduce Professor Dr. Rudaina Sobhi that tell us about the exercise testing in pediatric arrhythmia.
Okay, hi again. I hope my lecture won't be too much. Okay, so I'm talking about the exercise ECG testing in pediatric arrhythmias. My agenda. Exercise testing has vast applications. However, I'm going to focus on the exercise testing in children, mainly focusing on their value in arrhythmia. Exercise test is a valuable tool for diagnosis and management of pediatric arrhythmias. Variable arrhythmias can be maybe induced or abolished by exercise. We've talked about this through the presentations. It also helps to assess how the cardiovascular system responds to physical stress. Okay, so the role of exercise testing in pediatric arrhythmias, identifying what are the exercise-induced arrhythmias, like mainly ventricular arrhythmias, or less commonly supraventricular arrhythmias. As I said, exercise can trigger arrhythmias which are otherwise absent during rest. To evaluate also, an important thing is to evaluate the heart rate response to exercise, or as we say, the chronotropic competence, and to correlate symptoms with ECG findings. Exercise testing can be helpful in provoking arrhythmias, uncovering potentially diagnostic ECG abnormalities, and assessing a response to therapy. As for the indications, The coronary artery disease is rare in children, which is the commonly thing in adults. Indications for exercise testing in children are more broad, okay, including in patients with known arrhythmia for evaluation to assess if this arrhythmia is abolished or induced by exercise. Patients with familial history of certain cardiac death for their risk assessment, as the CPVT, the catecholaminergic polymorphic ventricular tachycardia, long QT, Brugada syndrome. In patients with syncope and dizziness, and for post-treatment monitoring after a cath ablation or pacemaker implantation to assess their effectiveness. For example, they are recommended as class 1 for the patients, the family members to be evaluated of SADS decedents, recommended for the first degree relatives. This is the EC guidelines. Ventricular arrhythmias, the role in the ventricular arrhythmias, premature ventricular contraction are the most commonly encountered arrhythmias during exercise. As we said, if a patient has PVCs or ventricular arrhythmias, they may be abolished. Or if we have PVCs during an exercise test, they should raise a concern in patients with a history of cardiomyopathy, valvular heart disease, myocardial ischemia, or with a family history of sudden cardiac death, especially if they are triggered on low levels of exercise, if they are multifocal, or associated with concomitant ST segment abnormalities. As for the VT, exercise-induced VT is highly suggestive of an underlying heart disease. Exercise can induce the CPVT or VT from the RVOT origin. In CPVT, you can see the pattern, the bidirectional PVCs. And it's a very important, reliable method to establish diagnosis, exercise testing. Long QT, and we monitor the response of prolongation of the corrected QT interval to exercise. Response to beta blocker therapy can be assessed. However, should be very cautious because tachycardia can be induced, the VT can be induced during the exercise. Supraventricular tachycardia, generally we don't use exercise testing. It's of limited utility in patients with SVT because they occur less commonly during exercise. However, in WPW syndrome, patients with children with manifest Wolff-Parkinson-White pattern, if we exercise them and the accessory or the pre-excitation disappears, this is probably a low risk accessory pathway because with a long refractory period. For example, this patient has undergone exercise and the 2 ECGs on the upper one, the lower one, it disappeared, pre-excitation. It's also can be used in young athletes who have symptoms, may experience symptoms during competition, like syncope, chest pain, or dizziness. Although these symptoms may indicate the presence of a serious underlying cardiac abnormalities like hypertrophic cardiomyopathy, ARVD, anomalous origin of the coronary artery, or other ventricular arrhythmias, however, sometimes they can just be benign conditions, for example, dehydration or hyperthermia, and exercise testing can be helpful in differentiating the etiology of these symptoms. We can use it in conduction system disturbances to determine the maximum achievable heart rate during exercise. For example, children with congenital complete heart block, their ventricular rate response to exercise may guide on the timing of pacemaker. Actually, we rarely use it. However, we can use it to relate the symptoms of the patient and know his chronotropic competence, especially patients with, for example, sinus node disease. However, we must know that the such patient may have, their heart rate may not increase. On the contrary, they may be at risk of syncope or decompensation, so we should be aware of this and taking care to prevent the injury. AV blocks that results from high vagal tone, they disappear during exercise. Complete heart block induced by exercise is uncommon and may be the result of sinus node ischemia. And if this happen or starts to happen, you should stop immediately the exercise testing. As I said, its heart rate response to exercise may be important in children who demonstrate chronotropic incompetence after certain types of surgery. As well, the cardiopulmonary functional capacity testing is we can use a gas analyzer during the exercise ECG to analyze the oxygen consumption and know the functional capacity of the patient. This can be important in patients with congenital heart disease, myocardial diseases, to guide on therapeutic interventions and assess the rehabilitation programs and the patient's capacity to participate in activities. I'll skip these because they're not arrhythmias. We should know that children are not small adults. There are some differences from pediatric patients from adult exercise testing. There are, as I said, the indications are more diverse. The wide range of patients can be really small and larger ones. So we have more flexible approaches. We need to select an appropriate testing protocol, proper equipment that's age appropriate. Also, children need encouragement and special attention for safety during the testing. They have higher heart rates. It's my mobile. Yeah. I'm sorry. Okay. Sorry. Okay. ECG changes generally they are quite the same as in adults. In general, the responses to exercise, ECG to exercise, are similar in children and adults. Also, the ST changes that are indicative of ischemia are the same in adults and adopted by the pediatric patients. The testing modality we use for testing, exercise testing, either the treadmill or the bicycle. And bicycle is actually the preferred method. It can be possibly to be used in children more than 5 years and more than 110 centimeters. Protocols used, the standard Bruce protocol or the modified Bruce protocol, that's what we use for the young children. Blood pressure should be monitored at rest and during exercise and recovery, and the ECG to be continued during recovery for the late arrhythmias. There are contraindications to exercise testing, not particularly in children, they are just absolute contraindications. Patients with acute myocarditis or pericarditis, severe outflow tract obstruction, acute myocardial infarction recent, less than 2 days, or unstable angina, pulmonary embolism, acute aortic dissection, very, very serious conditions. If a patient has a decompensated heart failure, patient with symptomatic severe aortic stenosis, if already the patient has severe uncontrolled arrhythmias, has acute infective endocarditis, or active illnesses like acute hepatitis or renal failure, or he has a physical or mental disability, will not make him able to go through the test. Okay. Generally, it's in children. It's not. It's a safe test and can be done. But however, we need to know when to stop the exercise. If we're doing the exercise, ECG in patient is not contraindicated. We need to stop the test. There are absolute indications to stop the exercise testing once there is a drop in the systolic blood pressure, more than 10 millimeters mercury from the baseline, despite increasing the workload, especially لو ده معاه evidence of myocardial ischemia, or if the patient develops significant symptoms during the test, like chest pain, dizziness, dyspnea, or severe fatigue. If he starts to have dizziness or near syncope, or exhibits signs of poor perfusion, or he develops sustained ventricular or other serious arrhythmias, including the second or third degree heart blocks, or if you have ST elevation, or simply if the patient wishes to stop. Okay, to sum up, exercise testing is a powerful non-invasive tool for diagnosis and management of pediatric arrhythmias. It provides a valuable insight into the relationship between physical activities and arrhythmias, helping to stratify the risk and guide treatment. We need to select the proper protocol, interpretation, and awareness of the pediatric specific factors, which are key to ensuring an accurate diagnosis. And actually هو ليه applications تانية كتير حتى non-cardiac, بس أنا it was not the scope of my talk in children. Thank you. Oh, yes. Yes, we do. We use the treadmill, ما عندناش البايسكل بس احنا we use the treadmill. لا اللي عندنا في العيادة we use the treadmill. Yeah. وعندنا cardiopulmonary. Yeah.
And the height. Why the height has to be more than 110? You said that? Or I
عشان يقدر use البيدالز.
bicycling بس ولا في other
more than 5 years يبقى familiar بالبيدالينج لأنه كمان مطلوب منه إنه يمينتين a steady rate of pedaling ما يبقى.
This is but the height is all related to cycling, right?
Yeah.
عشان يطول بس صح؟
ما
فيش حاجة
تانية. height of a 5 year old.
ما فيش حاجة تانية يعني.
height بتاع 5 years old. Okay. Anyone? Thank you.
My pleasure to present our last speaker, Professor Dr. Ahmed Mustafa, and he spoke about modern ways of arrhythmia documentation. We are eager to hear from you, Dr. Ahmed.
Presentations. Actually, today I'm very happy to be here today because I see one of our dreams in Abu Rish is born today as a conference for pediatric arrhythmia. Actually, it's the team of Abu Rish and critical care department. At the end of the day, I think all people will sleep and it will be light session, not like other session of my colleagues. And it's about modern ways of arrhythmia documentation. I will take it very rapidly. Heart arrhythmia, of course, is one of its orders at about 2% of population, about 46.3 million people every day. البرزنتيشن يا جماعة مش باينة. And actually, atrial fibrillation, one of the most important and one of arrhythmias that affecting most of people. هي مش بتقلب. اوكي. And for atrial fibrillation, of course, one of the major cardiovascular diseases affecting most of people, and early the detecting atrial fibrillation, the less we decreasing the stroke. Monitoring for arrhythmia, we have traditional method like 12-lead ECG and Holter, modern method like smart wearable and telemetry, and pocket device, I actually called it like it, pocket device, ALAVCOR, and invasive method like intracardiac loop recorder. For traditional method, we have less or limited period for recording, and not useful for asymptomatic patient like paroxysmal atrial arrhythmia. And also for smart wearable, we have many technologies now like photoplasmography and single lead ECG that increasing the accuracy of these devices. And from this literature, we appreciated this figures that showing how the photoplasmography can differentiate between irregular rhythm as BVCs and as atrial fibrillation. And also we have many wearable devices like watches, many actually for brands of watches, patches, and mobile telesystem, and clothing and accessories. Actually, I don't know that before preparing this literature, but we have some FED certified devices. I don't have all the devices, but just as example, Apple Watch, Fitbit, Samsung. For batches, Zybatch, which is most common. Also we have Cardostat, other chest strap like Limbo Heart, and smart accessories like Aura, which is the ring. And smartwatch actually is the most growing in the market. It's about 20%. It's predicted to be 20% of the market in 2026. Apple Watch and the Fitbit is the most popular. And actually Apple Watch is more superior. And from Apple Watch, we have very large study, Apple Heart study, which was about 400,000 patients, and showing how the accuracy of Apple Watch and how accuracy of superiority for detection tachycardia. And from this nice literature also, we can from Apple Watch we can do like 12-lead ECG localization of 12-lead ECG by using Apple Watch on the same points of chest leads to detect V1 to V6, and for lead 1, and we can do standard method by right index and the bottom surface of the watch from left hand, and for lead 2 and lead 3 also. So I can, for patient with frequent BVCs, I can make localization of BVCs just with Apple Watch. And it was nice actually. And we have actually many studies about Apple Watch, but at the end, all of them just recommended that physician involvement is necessary. Actually, these cases from real life, I have two cases. One of them was 9 years female living in USA, and actually they have recurrent attacks of palpitation, but no documentation of tachycardia, and of course not referred to a specialist in arrhythmia. Actually, I am just recommend her with Apple Watch, and this ECG from her Apple Watch, and after this one, she referred and has ablation. I had ablation after that. And another one, he was 76 years male. It was bedridden, many comorbidities. All the time he had the ECG in the emergency department with atrial fibrillation, and of course for as atrial fibrillation ablation, he refused it because it's a complicated procedure. But with Apple Watch also we recorded that SVT and disorganized in atrial fibrillation, and actually we do SVT ablation. After that we had Fitbit wearables. It's like Apple Watch. Also they have large scale for patients, for 400,000 patients, and all of them proving the accuracy and for detection atrial fibrillation. Also another study for validation to differentiation between sinus rhythm and atrial fibrillation for Fitbit. Another one, Samsung smart devices. Maybe Samsung is more market sharing now in all the world, and also it's validated now and FDA approved to detecting arrhythmia and atrial fibrillation. Huawei smartwatch, they have two large studies actually, MFA 2 trials and Huawei Heart study, but till now it's not approved from FDA. It's a Chinese national approved. For the batches, for comparison between the batches and the Holter, for the batches we have longer time for recording, easier to use, more comfortable to the patient, and less complicated for the connection, and of course less interference. I mean, with the batches they can go to swim, they can making sport, not like the Holter. The most popular one is Zybatch, and we have two types of Zybatch as recording system, Zio XT and Zio Monitor. Zio Monitor is a new one. It's lighter and thinner, and it's more comfortable to the patient. And also we have another one, it's Zio ET. It's telemetry by mobile. And also we have actually two excited literature about the Zio patch can detecting about in 100 patients. We can detect about 6.7 new atrial fibrillation patient. Another system is CAM system. Actually, it's made mainly for bradycardia by augmentations, the B wave and signal clarity. It's mainly for bradycardia, and in the bradycardia, it's not inferior to Zio patch. We have another system from Canada, because all other systems from USA. From Canada, we have CardioSat, and this actually is 14 days like Zio patch, and it's not inferior to Zio patch. And also we have some validation in literature. For telemetry, we have mobile continuous outpatient telemetry is MCOT, and for MCOT, it's a batch which used for 5 days, and it's replaced every 5 days till the monitoring period is ended. And it's Bluetooth connected, and it's actually 2-lead ECG. And this is the first one till now that we have 2-lead, not single-lead ECG. Another version from this telemetry is called ePatch, and this one is just a patch and is sent back to the manufacturer to interpretation of ECG. And for MCOT, it's versus ILR, it was superior to loop recorder. Vital patch from UK. It's like MCOT and everything, but it's not just for heart rate, but it's heart rate, body motion, respiratory rate, temperature. But actually for arrhythmia detection for arrhythmia, till now that is still lacking. Other accessories, it's very funny to know that I have rings and headphones and shoes that can detecting arrhythmia, but till now for headphones and shoes, till now we have lacking data to prove the validation for arrhythmia and atrial fibrillation. Actually, this one was conference, a sport conference paper, not a scientific paper. Also have necklace, and it's a very good system. It's COVA monitoring system, and it's mainly for heart failure more because it can detect in cardiac output and the fluid status, also heart rate, and also we have some proving from the literature about it. Vestis, we have Nebo system and the master cushion chart. Also for them, from them also was validated in literature, and because they can detecting according to the literature about 20% of participants in this study. Actually, arrhythmia detected by real devices is not just atrial fibrillation, all types of tachycardia, bradycardia, ectopus, even RT, EVRT, not just AF. But for smart clothing and accessories, as we said before, it's not proved till now for detection of arrhythmia. And we have many studies for Apple Watch, Zio patch, and CardioSat, and MCOT, and they are superior to other devices according to the studies. We have some limitation to this, and the future, of course, for wearable devices. Limitation for all these wearable devices. It's not affordable for all people. The first, and second, battery life. Not all of them have long battery life. Third thing is the signal quality, because most of them is depending on just single lead ECG. So we have some noises, and we can detect all the arrhythmia, not accurate. And for watches, we have for Apple Watch. Another problem is that anxiety, because some people have some palpitation, and when just have some alarm, maybe false alarm, and they have more anxiety about due to Apple Watch. And of course, also we have some noise detected for watches. For batches, skin irritation, and we have some waiting time to send back the holder, the batch to be read. And for the Vestis, it's make clothes more bulky, and it's not durable. Future actually companies have many technologies, many sensor like ultrasonic sensor, optic sensor, bioelectrical sensor for improving their accuracy for detecting tachycardia and make it more affordable. For a life core, which I call it, it's a pocket ECG. Actually, it's FDA approved from 2013. It's iOS Android system compatible, and it's depending on algorithm, which is artificial intelligence dependent, and according to also that the literature, they are superior to 12-lead ECG. And for intracardiac loop recorder, we have two types: injectable and traditional one. Injectable is smaller, And implantable recorder, we have some drawbacks: the cost, skin erosion, infection, oversensing and undersensing, and at the same time, the invasion. It's a procedure. It's not normal. For pediatrics, I found a very excited paper about alternative smartwatch in children. They recommended smartwatch more, and this study was done on 145 pediatrics with children with just palpitation. We found that about 41 patients have already detected tachycardia. 5 of them, they have congenital heart disease. Home message monitoring arrhythmia is very important to make a decision. Second thing, wearable devices have some drawbacks, but the future will be or will have more and more future for this. Thank you, and this our team and our reach system, of course, and I'd like to thank them all. Dr. Osama, please on the stage. Dr. Rodayna, Dr. Nabih, Dr. Abu Hadima, Dr. Al Hassan, Dr. Rania, Dr. Rania Hagizi, Dr. And now I will give the microphone to Dr. Osama to thank you and the people.
Thank you, merci قوي جدا على it was a very nice talk. At the end of this very long day, بصراحة احنا as a pediatric arrhythmias team, دكتورة حنان, please join us on the stage. يعني we have so many people that we're grateful to. Special thanks to our international guests. Thank you very much, Dr. Peter and Dr. Shadi, for joining us and for cooperating with us on so many patients. يعني الحقيقة your prints are on every aspect of the upgrade that has happened in this practice over the past few years. Thank you very much for that. We're missing Professor Wael Lotfi. He had to leave. بس طبعا يعني we cannot ever forget about his very important role in our team. النهارده ده يوم أسامة عبد العزيز ورودينا وحسين ودكتور أحمد وكلهم الحقيقة they have been heroes. This is a celebratory day for us إن إحنا كpediatric arrhythmology team نقدر نطلع this في رأيي one of the best scientific days that I've attended الخاصة that have been dedicated for pediatric arrhythmias. I hope إن كل حد يبقى استفاد. عايزين نشكر طبعا أساتذتنا اللي قعدوا معانا اليوم كله، الأستاذة الدكتورة سونيا، دكتورة فاتن، دكتورة أمل، دكتور مجدي، كل الأصدقاء الغاليين اللي جايين من كل حتة. I do not want to forget anyone. دكتورة سهى، محمود كمان قاعد بيبص لي فثانك يو محمود. دكتورة فاطمة، دكتور مجدي الشكر، مش عارفة مش شايفة كل الناس بس thank you for everyone. دكتورة سوزان بيومي منورانا من الصبح. فإن شاء الله بإذن الله I hope this is the start of a series of events إن شاء الله نقدر نرتبها وربنا يجعله علم نافع في ميزان حسناتنا كلنا. و I hope تكونوا كلكم استفدتوا و thanks on behalf of the arrhythmia team. أنا عايزة بس أسامة ورودينا يقولوا كلام.
لا كلمت كتير. اولا انا عايزه اشكر كل التيم، دكتور اسامه عبد العزيز، دكتور حسين، دكتور رانيا، دكتور حنان، دكتور وائل طبعا definitely، دكتور احمد مصطفى ذا دينامو وصاحب الافكار العظيمه. thank you Dr. Peter, دكتور شادي. يعني your contribution is tremendous, your support is endless. we're very very grateful لكل أساتذتنا وكل الناس اللي حضروا وفضلوا معانا لغاية الآخر. بجد your support and your presence هو اللي ادى success للإيفنت يعني. فاحنا يعني احنا مبسوطين جدا ان حضراتكم موجودين و hopefully نبقى ان شاء الله next time احسن واحسن ونقدر يعني spread زي awareness of pediatric arrhythmias وان شاء الله activities more and more. and finally انا حابه اشكر الشباب الجميل اللي جم النهارده ويعني تطوعوا يعملوا support لينا ويفضلوا معانا لغايه الاخر. تعالي يا دنا أسامة عبد العزيز.
Hello everyone. I would like to thank my friends for their support and effort throughout the day, and I would like to call them to the stage. مريم عقبو، كوثر عيد، جانا وليد، جانا نادر، أسامة عبد العزيز، محمد خالد، سيف أحمد، أحمد ناصر، زياد أيمن، ندى هاني، روان فودة، جانا أشرف, and finally جانا الناظر. Finally, I would like to thank the organizing committee for offering us such an amazing experience. Thank you.
ندعوكم صورة جماعية. دكتور بيتر، دكتور شادي، اتفضلوا يا جماعة.
دي حقيقة فعلا الأول، بس ما المفروض أنا أقول الكلمة بس يعني الحقيقة بصراحة نشكر جدا جدا الدكتور محمد الشاهد، يعني اللي ماسك ماونتنز. أحب هو يقول كلمة على التيم بتاعه. احنا زنقناه جدا في وقت قليل جدا، ويعني قابلتنا عقبات لحد النهارده الصبح. والدكتور أسامة أنا وهو ما نمناش بصراحة. يعني أنا كنت جاي من استراليا ومحدش فينا نام يعني عشان يطلع أحسن حاجة، وهو الراجل يعني خلال شهر تقريبا هينام لسه يعني إن شاء الله.
أنا حابب أشكركم واللي أنتوا اديتونا الفرصة إن نقدم لكم حاجة كويسة. ماونتنز ده فريق كبير جدا، مش فرد واحد. معانا دكتور محمد إبراهيم، دكتورة سيدة، أستاذ إسلام، دكتور مروة العقدة، عادل، وليد بالتيم، الشباب كله يجي يا شباب إن شاء الله. إحنا بنشكركم جميعا إن أنتوا اديتونا فرصة نقدم بعض الحاجات البسيطة إن إحنا نسعدكم، وإن شاء الله منتظركم في مؤتمرات أكتر وأكتر. وبنشكر أبو الريش بالتيم بتاعه كله، تيم الحالات الحرجة، وحدة الدكتور شريف مختار، وشكرا لكم جميعا. اتفضلوا يا شباب.
Thank you both.